The 20 years back, when the army went to now, instead of 30, great social activities. The name of Arna 2003. The CME is installed by the Chennai City branch. So once again, I welcome all students to our ASI Chennai CME of RM. I welcome our senior Madam Susudikam Madam, our Director of Academics, Chennai City, Dr. Kanagwel. Just say I. Our welcome of Dr. Kanagwel, Chairman of Narona sir. He is our finance and welcome Professor Ganesh sir, Finance Medical College. Exactly, it's not at 9 o'clock. The whole program is live in the YouTube. That is Chennai Service YouTube. This is the first time live program from ASI the nation. The long case, first case at the 9 o'clock. That's the Standard Medical College. We are waiting for our staff of Dr. PROF.DR.R.NANJUNDA as a convenient and the examiner and faculty. Dr. Naveen Alexander sir, Dr. Stephen Madam Stanley, and Paripala Madam. In the first session, I welcome our professor and pioneer and creation of the trend setter of the Chennai City branch, Professor Susudikam Madam.
Friends, warm welcome to all of you. So it is not an examination. It is going to be a learning experience for both of you, us and the examiners. So I requested the examiners to help you if you are not able to get an answer. So it is going to be a dual presentation. So two of your friends are going to come to the presentation board. So one person will be handling the history part, the other person will be handling the clinical part. So you can take turns to answer. If one person is unable to answer, finds difficult to answer, you can move on to that. There will be a timer. Bell will be run for 3 minutes before your final question or so. That will inform that you are getting over, right? If you are unable to tell an answer or if you are unable to give an answer, please tell them, sorry madam or sorry sir, I do not know the answer. Keep going further because we have also told the examiners to give you the answer, right? It is going to be a learning experience. So keep your mobiles in silent mode. I request again, please check if your mobiles are in silent mode. You are absolutely free to use your mobiles in a silent mode. You can browse or whatever you want to check your WhatsApp. But then I wish all your concentration is on to the teaching program so that the connect between you and the teaching program is perfectly maintained. And be aware, there are going to be in between questions. Between every session, there will be quiz questions. Don't jump or shout answers. Please raise your hand. We will take you up and to give the answer. And then and there, prizes will be given to the correct answers. So this is how it is going to be. We have another 5 minutes to go. We will go on air shortly. Good luck to you. All the very best to you for the upcoming exams.
Check, check. Okay, va?
Good morning to all. I welcome our National President, Dr. Sanjay Kumar Jain sir, to address the students.
I first of all, welcome everybody. Good morning. So I am so happy that we are starting academic program. But I want to speak. I will just speak just for 2 minutes. I would like to talk to you. Means kind of informally. I welcome all the faculties, respected teachers from this state of Tamil Nadu. And rest I will be talking. I request the organizer to kindly start this meeting, which is going to be a grand success. Thank you.
Thank you, sir. Thank you, sir.
I also request all the senior faculty for first session. I request our teacher of teachers, Professor Shruti ma'am, to convene the first session. Darwin sir is expected to join shortly. Professor Naveen Alexander from Sri Ramchandra Medical College, very favorite teacher for the young students. Satyapriya ma'am from Stanley Medical College. Parimala ma'am is expected shortly. Can we have Ganesh sir to come up with these statements?
I welcome Professor Surya Malvinder, the Professor of Surgery and our surgical faculty. He is a Professor of Surgery, but standing and asking now, not in the Department of Surgery in Surgical Medical College. Please.
So can we have?
I welcome Professor Ganesh, Professor of Surgery from University Medical College. Welcome, sir. Welcome, Alexander, sir.
So by the time the PPT are loading, I can ask a couple of quick questions to the examiner. So as a senior examiner, in hernia, like when do you think a candidate deserves a fail? Or what are the more important things a candidate should not miss? While they wrote about, when can I take all the faculties comment, quick comment on what the students should take care so that they are taken as a serious flaw and they are given a fail. Because hernia is one case, a good student can also struggle. So can you please tell what candidate is minimum experience?
Madam, please. I welcome Professor Stephen Madam for this. Welcome, Madam. The Professor of Surgery from Stanley Medical College.
Morning to all of you. At the outset, I'd like to thank the organizers of the Chennai City ASI for inviting us here. The hernia is a long case which is kept for you in the examination. We do see a number of things failing for simple reasons. The thing that they should know is the inguinal canal anatomy is very, very important. All questions can be asked in that. How to differentiate a direct hernia from an indirect inguinal hernia clinically, and also the clinical signs for you to elicit to differentiate between these two. Examination of the scrotum, very important. And also the examination of the genitalia is very important. And also the abdominal wall weakness on the clinical aspects. Then, of course, they will ask you about theoretically the complications of hernia and more points, because you will become a rotatory intern and then you should know how to diagnose a strangulated hernia as an emergency. You should know how to examine what are the clinical findings for you to say that this is a strangulated hernia, and also the various types of other hernias also they can ask you, you should know. So these are the things which are taken, and a general examination. I think I'll give it to the, so all my colleagues are also examiners. From their perspective, they also will have a lot of points, they will tell you.
Yeah, because I think as an examiner, madam, and as an examiner, we will be interested to people to demonstrate that yeah, deep inguinal occlusion test. Real time occlusion test, and we expect you to perform it, and we ask you to demonstrate it. So if you are making some mistake there, if you're not able to demonstrate it properly, and it we consider that as a serious flaw. In the sense, the purpose of keeping the inguinal hernia case in the examination, you people to demonstrate and find out the type of hernia. So it is purely of an academic exercise. So that we expect you to do correctly. We will not accept any mistake there. We consider this a gross flaw. And moreover, if you are making some, it's an test of an anatomy again, the inguinal canal anatomy. Suppose you are making very gross mistakes and discussing in anatomical aspects, then we take it very seriously and we consider the major flaw. And other areas, I think I'll give it to Professor Divya.
I think the candidate
start
is
the
ready. So, dear students, off we go. You please give a rousing welcome to Satish and Renuka, who are going to start the sessions. So, Madam, I request the candidates be allowed to present the history part without hard. You can go back, revisit if they have missed or something. Same way when they do the clinical part, they can be allowed to do it and then take it further. And we have 30 minutes for this case. I'll be giving you an indication at 25th minute so that we can try to wind up and close. All the very best to you students. Good luck.
Good morning, professors, and good morning, everybody. I'm Renuka Satish from Stanley Medical College. Moving on to the case. Mr. Sundaram, a 55-year-old male, a shopkeeper by occupation residing at Vasarpadi, came to the OPD with chief complaints of swelling in the right groin for the past 8 months and pain in the right groin for the past 1 week. History of presenting illness. The patient was apparently normal 8 months back, and then he noticed a swelling in the right groin, which was insidious in onset and has gradually progressed to attain the current size, not extending into the scrotum. The swelling becomes prominent on cuffing, straining, standing, and it disappears on lying down. There's history of pain for the past 1 week over the right lower abdomen, which is localized to the swelling and which is intermittent in nature, dragging type of pain, not radiating, and there's no specific aggravating and relieving factors. There's no history of abdominal distension, nausea, vomiting, constipation, and obstipation. There's no history of chronic cough. There's no history of micturition difficulties. There's no history of trauma, no history of fever, and there's no history of any other swelling in the body. Past history, there's no history of similar complaints in the past. There's no history of epilepsy, chronic obstructive pulmonary disease, bronchial asthma, and tuberculosis. There's no history of previous surgeries or blood transfusions, and no other histories of previous hospitalizations. Comorbid history. He is not a known case of type 2 diabetes mellitus, hypertension, and coronary artery disease. Personal history. The patient consumes a mixed diet. He has normal bowel and bladder habits, the normal sleep pattern, and he's a chronic smoker for the past 20 years. And he doesn't consume alcohol, and there's no history of substance abuse. Treatment history is not significant, and family history is not significant.
Can we interrupt you here? Okay. Now you have finished the history. You have elicited one history. When the patient gets up, it comes, and then when he lies down, it goes away inside. From that, what are you able to infer?
It is a reducible hernia.
What type of hernia? What else?
Direct hernia.
Huh?
Direct hernia.
The first point, what you should say is, it is a direct hernia. Why in a direct hernia, when the fellow gets up, it comes, and when he lies down, it goes away.
So direct hernia usually occurs in old age people where the neck is wider.
You say that the neck is very broad and wider. No? That is number one. Second, like you said, reducible. You have elicited the history that the patient has got what you said, the pain.
Yes.
What are the reasons why one should have pain in a hernia?
Pain in the hernia, it can be because of dragging or pulling of the peritoneum into the
Peritoneum? You should use the correct words.
mesentery.
Drag, first the contents. It can be an intestine. It can be an intestine, or it can be omentum. If there is a drag, if the intestine is caught there, naturally it is going to drag the mesentery, which you said. So where will be the pain? Pain only
Local.
abdominal, central abdominal discomfort, lower abdomen is going to have. So the momentum is another content that can drag. Where is the attachment? It can pull the transverse colon also. So they can have pain in the epigastrium. Other things are when there is a compromise to the vascularity. There also, there will be ischemia and also pain will be there. Next, when there is an inflammation in a hernia, when the contents are inflamed, like it can be an appendix, it can be a Meckel's, it can be a tube, what we call the ovary with the tube, the fallopian tube, or when we call an inflamed hernia, there also they are going to have pain. Similarly, it can be a small rich chest hernia. That is why the history taking is very important. Suppose somebody says, I got loose stools. Pay more attention to that. Loose stools and the swelling there, it is going to tell you. You were telling about the previous history of surgery. What surgery did you ask?
Appendicectomy surgery or previous hernia for recurrence sake.
That is for the right side. What
Yes.
about the left side?
Recurrent hernia, previous hernioplasties.
No. That is, no, you said, why did we ask about history of surgery? History of previous surgery is for two things. One thing is a cause for a hernia can be because of a previous surgery, like the appendicectomy, especially when you are doing the muscle cutting incision, you are going to damage the what nerves?
Ilioinguinal nerve and iliohypogastric.
You damage these ones, which results in a direct hernia because of the muscle that is going in for weakness. Similarly, left side, any surgery, it can be colon, maybe somebody had a sigmoid colostomy or something like that done, or distal ureter, lumbar sympathectomy, like that, wherever some kind of a muscle cutting incision, then always let us not concentrate on the right side only. You have to concentrate on the left too. And also the previous surgery, you are rightly telling probably a hernia has recurred. Okay, thank you.
Can we just go back 2 slides? Go back. Yeah, so would you like to see now, how old is this gentleman?
Sir?
How old is this gentleman?
How?
Age.
52-year-old.
So 52. Now we have to give a little more weightage to the bladder habits over here. I don't think we can just get away by just saying normal bowel and bladder habits in one sentence. Some kind of weightage has to be given to whether he's got any prostatic symptoms. It's very, very important because we know that it starts off the late 40s itself. And if you had to list out for the benefit of everyone here, what are the prostatic symptoms that can come?
Sir, the prostatic symptoms can be storage symptoms and voiding symptoms, and it can be because of infection. First, storage symptoms, increased frequency of urination, nocturia, and urgency, and voiding symptoms like dribbling of the urine, poor stream, straining during micturition, and the arc is lost. The arc of the urine is lost.
Yes, excellent. Now, if a patient had a kind of prostatomegaly, which do you think will be the first symptom that he notices?
Urgency.
Urgency is one. Another thing that you will see that their sleep gets disturbed because they get up at night.
Nocturia.
Okay. And if you had a patient who is saying, I get up once and go to the bathroom, or if there's another patient who's getting up 4 times and going to the bathroom, once is considered very, very pretty much normal. Yeah. Okay. Depends on what he's had for dinner and how much water he's drank or what else he's drank. We don't know. Okay. But 3 to 4 times, definitely they will find that their sleep is disturbed and will be a very like a proper symptom that they will report. Okay. Right. Now, the next point that I'd like to ask about chronic smoking. How does smoking predispose to developing a hernia?
So there are 2 possible reasons. One being it disturbs, collagen, impairs the collagen synthesis.
Do you know which one, which type of collagen gets
Type
removed?
3.
Okay.
And the other reason, it precipitates respiratory illness like chronic.
Excellent.
obstructive
So let's not discount the respiratory problems that can predispose.
That can
because you
predispose.
have said there is no history of chronic cough, which is a very good thing. But another thing is smokers over a period of time, there is an increased intra-abdominal pressure.
Pressure.
Okay, so that itself will predispose. Which kind of hernia do you think it predisposes to?
Direct hernia, acquired
Naturally, it will be
hernia.
a direct hernia. Yes, okay. Sir? You can continue.
On to the general examination, after obtaining consent, the patient was examined in a well-lit and ventilated room with adequate privacy. He was conscious, oriented to time, place, and person. He was moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, pedal edema, and
Little slower, little lower. Okay, right.
and lymphadenopathy. Vitals. His pulse rate was 86 beats per minute, regular rhythm, normal volume and character, no radial or radiofemoral delay. His BP was 110/70 mm of mercury measured in the left arm in the sitting posture. His respiratory rate was 17 per minute and his oxygen saturation was 99%. His body temperature was 98.6 degree Fahrenheit. On local examination, the patient was examined in a standing posture, being exposed from umbilicus to mid. The patient was examined in a standing posture, being exposed from umbilicus to mid-thigh. On inspection of the right inguinal scrotal region, an hemispherical swelling measuring 4x4 centimeter in the right inguinal region, extending 1 centimeter medial to mid-inguinal point up to pubic tubercle. The swelling was smooth and skin over the swelling was normal. Cough impulse was present. Swelling reduces completely on lying down. There was no scars, sinuses, and dilated veins, and no malgaining bulges was seen. Penis was in midline. Urethral meatus was normal, and normal rugosities were seen over the scrotum.
I'd like to pause over there. Ma'am, would you like to say just cough impulse is present, or would we like to characterize that kind of cough impulse?
Expansile cough impulse is on palpation. Correct, ma'am? So the cough impulse on inspection you made out.
Yes.
I always wonder, when the patient is already standing up, the swelling is already come out, right? When can you observe this cough impulse?
You can ask the patient to cough, ma'am.
So
we
of
can-
course, only when you cough, you get how to appreciate when the person is lying down, you can see. When if you are having a thing, sometimes you can see in standing up, if it's a bigger hernia, it is already projected and come out. No? You cannot appreciate much more. But when you lie down, you can see something coming out like that. So on palpation, the expansile cough impulse will be able to appreciate the thing.
See, you've written something like no Malgagny bulges, no? How do you, on inspection, how do you differentiate that Malgagny bulges from hernia?
Sir, actually, we can make the patient to lie down in supine position on performing the head raising test. In case if there is any posterior wall weakness, we can see some multiple swellings over the anterior abdominal wall, which indicates that patient's posterior wall is weak.
Where exactly you look for a Malgagny bulges? Which part of the inguinal canal you will look for a Malgagny bulges?
Above the medial half of the inguinal ligaments.
Yeah, that's right. Okay, okay.
Continue.
On palpation, there was no warmth, no tenderness. A solitary hemispherical swelling of size 4x4 centimeter, extending between 1 centimeter medial to mid-inguinal point up to pubic tubercle. It was doughy in consistency, and expansile cough impulse was felt. Swelling was reducible, and by Ziemann's 3-finger test, an impulse was felt at the middle finger. On deep ring occlusion test, swelling appears medial to the occluded finger, and not able to get, we were unable to get above the swelling. Bilateral testis was palpable separately. Urethral meatus was normal. There was no phimosis and there was no strictures present and the cord structures was palpable. On
palpation, can I interrupt you here? On palpation, I want to know whether you examine this patient on standing posture or lying down posture.
on standing posture,
Standing posture.
on standing.
How can you reduce the swelling
And,
and then hold on to the deep breath?
you can ask the patient to lie down in supine position. We can flex his knee and hip, and we can medially rotate his hip.
No,
And-
I am not asking you about how you reduce the swelling. I am asking you, how did you made, you are making the patient stand up and then do all the, what is that, ring occlusion test. Is it very easy to do? It is embarrassing both for the surgeon as well as the patient himself. So always, I do not know, a lot of books are writing about this, but I think we have to use our, basic knowledge and common sense to do. First is make the patient lie down. Patient is very comfortable. Okay. Then it is easier to reduce the contents when the patient is lying down, rather than holding on to the swelling and pushing it well, this person is standing up. You only told when the patient gets up, it is coming out. So you need too many hands. One fellow should put the contents inside and prevent it from coming out. Then you occlude your deep ring. When you are occluding the deep ring, the content will come out. Is it not? So it's better common sense. Make the patient lie down. Reduce the contents. Find out where the deep ring is. Where is the deep ring?
The deep ring is like 1.25 centimeter above the mid-inguinal point.
What is this mid-inguinal point?
Mid-inguinal point is the midpoint of line joining the anterior superiliac spine and the pubic symphysis.
Okay, so you occluded. How many fingers do you use for examining a hernia?
All 5 fingers we can.
Very good. All the 5. You are knowing. These are the questions that they will ask you. So, okay, you occluded the deep ring. Then what did you do?
After first you have to reduce the swelling. After reducing the swelling, you have to occlude the deep ring, and we'll ask the patient to stand. After standing, we'll ask the patient to cough. If the swelling appears, that shows that the swelling is appearing through the Hasselback's triangle, which is your direct hernia.
It's not necessary. If it is very small and you are not able to appreciate, you can make the patient stand up. First, you try while lying down only, ask the person to cough. Then you will be seeing something coming medial to your finger that shows it is from the Hasselback's triangle that is there. Okay. Now you told me solitary swelling is there. Why you told solitary swelling? You expected some multiple swellings there?
In case of any malgang bulges can be seen.
No. Because we don't know the answer, no, you should not get into trouble by answering something else. You get multiple, so refrain from using, I'm seeing one solitary swelling like that. It's better to not to use extra fittings to your description. Okay. Then go in an orderly manner.
You said not able to get above the swelling. Do you look for that in inguinal swelling to get above the swelling? Where do you look for get above the swelling?
Hydrocele will check for.
Sir, is in a scrotal swelling. So for inguinal swelling, you cannot. So you have to differentiate between a hernia and a hydrocele. So if it's going to be an inguinoscrotal swelling, then you can say get above the swelling. So purely inguinal swelling, no need to say get above the swelling. If it's going to be inguinoscrotal swelling or a scrotal swelling, you have to say. So whether you're able to get above the swelling. Okay? Purely bubonoscele, I don't think you have to say about that. And then here again with this, I wanted to mention, you don't say the solitary. The swelling, A is the same. A is also the same as solitary. A swelling is seen. That is now.
You were describing your deep ring occlusion test. What is the plane of the deep ring? At what level? What is the plane the deep ring is situated? Where exactly the deep ring is situated? So you told about the surface marking, but where exactly the deep ring is situated?
So actually it's in the deep facial plane, sir.
Deep fascia.
The facial plane.
See, so the fascia transversalis. Fascia, what is the site of the deep ring? Which ring you will use to occlude the deep ring? Which finger you will occlude the deep ring?
Sir, we'll use for,
How did you perform the deep ring occlusion test? Using,
by using our,
how did you occlude the deep ring?
sir, in Zienman's test, we'll use our index finger, whereas in deep ring occlusion test, we'll use our thumb, sir.
Why? Why do you use them? Why not other fingers? I think you got other fingers. Why do you use them? And what is that in point blank? What is the size of the deep ring?
You understand what sir says? See, sometimes what happens is in the deep ring, it gets wider. Okay, so that's one of the main reasons why an indirect hernia occurs. Okay, so sometimes just an index finger might not be enough for occluding it. So thumb might be a better thing. Sometimes you might even need to use 2 fingers. Okay, see, one of the things when we see a large indirect hernia, although we keep saying indirect hernia, the neck will be very narrow and all that. Okay, there is a chance that it might be wider than the size of your thumb, examining thumb. So it's important to, if you think in spite of you holding with the thumb, you are able to feel something more, use more than 1 finger is also possible. Okay, right? So one more thing is, said you would not, she would prefer not to get above the swelling in this case. But sometimes if you have a patient who's got both a hernia and a hydrocele, I think it's very much warranted that you need to. This case, definitely, I would not check for getting above the swelling. Okay, right? We have 5 minutes more, so you can go little faster. Okay, right? Go on. Anything else? See, one more thing you said, no phimosis here. Okay, but you have not mentioned anything whether there was excessive foreskin in the inspection. Okay, right? Whether there's any BXO, all those kind of things you need. Yeah, so you, another thing is, yeah, urethral strictures. How do you palpate for those?
For to palpate over the shaft of the penis, we can look for any we can easily, in case of any strictures, we can see some thickness or
Thickening. That's all. Excellent. Nodularity. Yeah, there are many terms you can use for that. Go on.
On percussion, dull note was seen, and on auscultation, no bowel sounds was heard. Examination of the left inguinoscaudal region, it was normal. Examination of the regional lymph nodes was also normal.
Yeah.
Just,
Anything significant?
no.
Right. Okay. Go on to the diagnosis.
So,
you can go ahead. Forget the summary. Just go to the diagnosis straight.
diagnosis.
Tell it straight away.
Like
Exam, you're not going to be
on
looking at the
diagnosis,
paper. No?
right-sided incomplete direct inguinal hernia without any complications, probably an omentocele as the content with no comorbidities.
Okay, so here we have a problem. Incomplete is a term used for direct or indirect? Incomplete and complete. What is direct famous for being staying only in these anterior surface of the abdomen? It rarely goes into the scrotum, right? So the term, whether you use incomplete or complete over here, I would not agree to it. Ma'am, I don't think any of our panelists over here agree that you can use the term complete or incomplete. Yes, sir.
But it's not necessary. You can straight away say it's a bubonosele, not even incomplete or direct, right? Direct hernia, commonly they don't descend to the scrotum. So it will always be incomplete.
Proceed.
I would like to perform routine investigations like hemoglobin, blood grouping, blood typing, total count, differential count, ESR, bleeding time, clotting time, urine albumin and sugar, blood urea and sugar, renal function test, liver function test, X-ray chest, electrocardiography.
Why liver function test?
To look for any
So remember one thing, nothing is routine. Everything is based on the diagnosis and management. Nothing is routine. Go on.
And we can do abdomen, ultrasound abdomen and pelvis. Management, right sided hernioplasty can be done for this
So what is
patient.
the indication in this patient for surgery?
It's main thing is the patient is having pain for the past 1 week, ma'am.
Is that the only indication? If the patient does not have pain, will you not operate?
I mean, the patient is in age is 55 years and it's swelling. We have diagnosed to be as hernia, so probably
No. Hernia as such,
we,
why do you want to operate on a hernia?
especially when it has gone for any obstruction.
So
stra-
to prevent
strangulation.
complications, the other way, is it not? To prevent complications, you're going to operate the hernia.
I would say this way, you have to ask the patient to stop smoking, number one. Okay, he's a chronic smoker. And with your anesthetist in the picture, how long to stop smoking? Because all this matters for your anesthesia as well as your surgery. Okay, right? If he's not in an absolute emergency situation, I think you should give him some more time for him to get his optimize himself prior to surgery. Smoking is a very, very dangerous factor when it comes to hernia surgery. Okay, right? Did you mention about the BMI in this patient? So we have to look at that as well. Okay, so obesity, smoking, all these factors for recurrence of hernia. Okay, right? So it's very important. We don't want a recurrence. Okay, one recurrence will give you sleepless nights. Okay, so try to optimize the patient as much as possible. Now, right inguinal hernioplasty. What is the standard, gold standard method that we follow?
Lichtenstein's mesh repair surgery.
Tension-free mesh. You have to use the full terms. Lichtenstein's tension-free mesh repair. Whether you're going to do it under local, spinal or GA, it doesn't matter.
What is the last question for you? What is the most dangerous complication of hernia? Strangulated hernia.
Strangulation.
How does a patient with strangulated hernia present to you?
Severe excruciating pain in the abdomen with obstructive symptoms like vomiting, abdominal distension, constipation.
Local findings are tense, tender, irreducible swelling, absent cough impulse with all overlying inflammatory signs on the skin also you can have, and also abdominal distension. The patient initially will present with hypovolemic shock. Later on, the patient will go in for a septicemic shock. Why the patient goes in for a hypovolemic shock? They'll ask you, because you know the vascularity is compromised. First, earliest go away is the venous return. Then the artery keeps on pumping. And so some amount of blood is sequestrated in the bowel that is directly proportional to the length and circumference of the bowel. So management is you put a rice tube, antibiotic, fluids, and take the patient for surgery, emergency. Okay. Look for the viability of the gut. Finished. Okay. Viability. Yeah. Okay.
Thank you, students. Thank you, faculty.
They're running short of time.
We request Shruti ma'am to hand over the faculty certificates to Ganesan sir. Sir will have to come back again. Now, I thank the students. Students, stay back here. At the end of the hour, you will receive the certificates. Hearty welcome to Professor Darwin sir, again teacher of teachers and most eminent faculty for the program. And we request my teacher and again teacher of teachers, Professor Ragumani sir, Ganesan sir to stay back, Shruti ma'am to stay. The team from MMC, please come up to the stage, please. Ragumani sir, Ganesan sir, please stay back. Shruti ma'am, stay back. Anandi ma'am, Darwin sir, sir, Inge sir.
Who is your colleague, madam?
I'm only present.
You are
Two
going
persons
alone.
can
Can take the questions.
Okay, sir.
You present, he can examine, but both of you can take questions. Huh?
Subhashri, you have any of your colleague within, you ask someone of your colleague to join you, that means. No, you can call by name, whomever is your friend. So who
Guys-
wants to volunteer for Madras Medical College?
Sukrit, want to join?
Come.
You can start.
Okay. Sir. Good morning, everyone. I'm going to present a case on hydroxy. 65-year-old male, Mr. Poshay Pandian, who is unemployed, hailing from Porur, presented with chief complaints of. Next slide.
Lower down your mic. Don't bring it closer. A little bit lower down. Okay. So that it doesn't echo.
Swelling in the left side of the scrotum for past 2 years. History of presenting illness. The patient was apparently normal 2 years back, after which he developed swelling in the left side of the scrotum, insidious in onset, initially small in size, gradually progressed to the current size. No aggravating and relieving factor. It does not reduce on lying down and on manual reduction. No history of pain, no history of trauma, no history of fever with chills and rigor, no history of loss of weight and loss of appetite, no history of burning micturition, increased frequency and urgency, no history of any other swelling in the body. Past history, there is no similar complaints in the past. History of bilateral inguinal hernioplasty done 5 years back and no history of any post-operative complications. Comorbid history, the patient is a known case of diabetes mellitus for the past 8 years and is on regular medications. Personal history, he consumes mixed diet, not a smoker or an alcoholic. He is having normal bowel and bladder habits. Family history, there is no significant family history. Next. Summary. Case of 65-year-old male presented with complaints of swelling in the left side of the scrotum for past 2 years, insidious in onset, slowly progressive in nature, not associated with pain and trauma.
Hello. Yes. Madam, my first comment will be, you are saying the patient is unemployed.
Yes, sir.
Don't say a 60-year-old man remain unemployed. Reminds வடிவேலு காமெடி வேலை இல்லாம மரத்தடியில படுத்துட்டு இருக்க மாதிரி. You should know what is previous occupation.
He was a coolie, sir.
No,
8 years
that
back.
word coolie doesn't mean anything. Manual
He is a
laborer
manual
means whether it's a construction worker. Exactly, you should know. As an undergraduate, this is very, very important. What has been he doing? Whether he was working in the field, sedentary worker, what sort of job, weightlifting job. So these things are important. Auto driver Manikam கிடையாது. Our Basha. So is past occupation you should enlist, right? That is comment number 1. I'll quickly go through my comments. You have to be very quick. The time is very short. ஆண்டொன்று போனால் வருஷம் வயதொன்று போகும். Reduces on lying down. Is it relevant in hydroxyl?
No, sir. Actually, in case of congenital.
No, actually, no. All reduces with swelling. Can it reduce any hydroxyl?
No.
No. Any hydroxyl, can it reduce? Partial variation. Shall I put it? Reframe my question. Is there any partial variation in hydroxyl swelling? Congenital hydroxyl? Congenital hydroxyl will reduce. Not exactly on lying down, overnight. Because it is got a small communication to the peritoneal cavity.
Yes.
Right? Third, Pain, trauma, fever. These are things you mentioned very fast. What is the relevance of trauma to scrotal swelling?
So, trauma, there can be a sudden increase in the size of the swelling. After
What
trauma.
exactly happens on trauma?
There would be
Trauma produces acute hematocele.
hematocele.
Over a period, that acute hematocele becomes
So, chronic cold hematocele.
chronic clotted
Clotted
hematocele. Right. Okay. Fever with chills. What is the importance of fever with chills in scrotal swelling with the fluid formation?
Any recent urinary tract infection that
Urinary
can be,
tract
acute,
infection and hydrocele,
epidemic.
Amavasaikum, Abdul Kadarkum. More relevant will be filarial origin. Filarial
That
origin
periodic-
will have chills. Chills are due to lymphangitis, right? Any angiitis in surgery produces chills. Any active invasion of bloodstream produces chills. In surgery, cholangitis, chills. UTI, chills, right? Medicine, malaria, chills, right? Loss of weight, loss of appetite. Is it relevant for a scrotal swelling? What is the final diagnosis?
Hydrocele.
Hydrocele.
It's a primary.
By no stretch of imagination, I can correlate a loss of weight or loss of appetite. Don't mention so many. See, we are fighting against time, 15 minutes time. So I am holding the mic for too long now. Second thing will be the bilateral hernia plasty in the past. Where was it done? Who did that? What was the indication?
It was done in MMCs.
MMC?
In MMC,
Same sitting, open surgery. When was it?
5 years back.
5 years back. Open surgery or laparoscopic surgery?
The open surgery.
Open surgery in the same sitting. What is the relevance of that, if at all any, to a scrotal swelling?
There can be a post-operative complication of hydrocele, sir, because there will be a damage to the lymphatic drainage of.
Bilateral hernioplasty has been done.
Yes.
How can a bilateral hernioplasty or a unilateral hernioplasty be a cause for a hydrocele?
A damage to the lymphatics or
Okay.
tunica.
Anything more apart from damage to the lymphatics? You can have that the distal sac has to be left open. If you are going to close the distal sac, there's a chance that this patient can develop a hydrocele because the secretory surface is going to be contained. Okay, so that might be the reason.
Okay.
You need not call it a complication. Complications are classified per-operative, immediate post-operative, late post-operative. This is a necessary event. See, you operate bilaterally, open surgery, you disturb with the lymphatics. So there is a chance of the patient developing a hydrocele.
What is, this is called hydrocele of the hernial sac. What is hernia in a hydrocele?
The hernial sac, which is large, it will invade to the daughters. Yes.
What you just now had is a hydrocele of a hernial sac, like madam saying, distal sac, if it is not laid open, it will close and you are getting a hydrocele. Now I am asking, what is hernia of a hydrocele? That is nothing but a small defect in the daughters. There the fluid is just outpouching there and it looks like a small hernia there. Okay.
Yes.
These are small, tiny questions they will ask you.
We'll go with the examination.
On examination, local examination of the scrotum. After obtaining consent from the patient is examined in the well-lighted room. In standing position, exposed from umbilicus to mid-thigh. Inspection, a left-sided scrotal swelling of size 12 cross 10 centimeter, ovoid in shape, extending from the root to the base of the scrotum. Surface appears smooth, skin is stretched, rugosity is lost. No scars, sinuses, dilated veins over the swelling. No ulcer discharged from the swelling. Cough impulse absent. Penis in midline and pubic hair suspense.
Rugosity is lost, you said, no?
Yes.
What is the importance of that dartal rugosity lost? What does it tell you? You know, you tell 30 seconds, I'll give you.
So, the primary hydrocele because of.
No, what is the importance of this dartal rugosity? What is the exact, why is it there?
For the maintenance of spermatogenesis. Temperature regulations.
It is a thermoregulatory
Yes.
mechanism. So the scrotal temperature, how many degrees it is lesser than the body temperature?
It is covered by the dartos muscle, which regulates.
It is less than 2 degrees
degrees.
from the, like you said, spermatogenesis. When it is lost, it is telling you that's a very big hydrocele there. What are the skin changes that you will see in the scrotum in a hydrocele?
The skin will be stretched and shiny. There will be many engorged
Thickening of the skin also you can see. Some
veins.
any scars and any sinuses. Where will you look for sinuses?
In case of tubercular hydrocele.
In no, where means you should tell site. So it can be posterolateral. It can be anterior. Anterior means gamma. Posterolateral means epididymis, tuberculous epididymis, no, which you can get. So these are the things that you sometimes in an anteverted testis, these things can get reversed also. Okay.
A supplementary question to skin changes. Madam said,
Sebaceous adenomas.
in a filarial origin, extreme filariasis, what do you get?
Yes. There will be elephant.
Like elephantoid limb, you get elephantoid. You have what is a penile lesion of filariasis? Yeah, extreme filariasis, long-standing filariasis, as a part of skin of iris.
How does the penis look like?
She's answering for.
Ram horn penis.
Good, great. Later latest first time I adding a sixer. Okay, fine. Ram horn penis, right? Good. Yes, go ahead. Right side of the scrotum is normal, testis is palpable. When you palpate the testis, you have to clinically assess one important finding. What is that?
Testicular sensations.
What is the importance of testicular sensation?
It will be lost in case of any testicular malignancies and in hematocele, tubercular.
A diseased testis. Put it as diseased testis. That diseased testis can be hypoplastic testis, atrophic testis, flabby testis, or a tumorous testis, whatever it is, right? Okay. No palpable lymph nodes. Where will you look for lymph nodes of scrotal pathology? What?
Inguinal group of lymph nodes.
Supposing I say testicular lesion, where will you look for?
Para-aortic group of lymph
Where are they? In the anatomical segment. Para-aortic nodes.
in the abdomen.
Abdomen, all right, madam. 9 segments are there.
Aorta around the umbilical.
Where the renal arteries are taking off. 2 minutes. So you have to look at the epigastrium. Beware of an epigastric lump in a male. You have to go back to the scrotum. And one more thing is left supraclavicular fossa. Once this thing is there.
How will you differentiate between a primary and a secondary hydrocele?
Primary hydrocele will be large compared to the secondary hydrocele. It will be a tense cystic swelling, and it will be a lax swelling in the secondary hydrocele. The testis will not be palpable in the primary hydrocele, and it's palpable in the secondary hydrocele.
Okay. Yeah. When do you get a translumination negative in a hydrocele?
In case of thick sac and chylocele, hematocele, and in case of any infections, pyocele.
What is the composition of the hydrocele fluid?
It consists of fibrinogen, albumin, cholesterol crystals, tyrosine compounds.
How do you know there is a presence of fibrinogen in this fluid?
The hydrocele fluid does not clot while
it comes into contact with the blood.
Contact with the blood, it get clotted because fibrogen gets activated, so there will be fibrin formation.
How do you elicit fluctuation in a hydrocele?
Fluctuation, first asking the patient in a standing position, make the patient in a standing position, fix the upper pole of the testis with the thumb and the other 4 fingers, and the lower pole is fixed with the other hand.
So you need to catch hold of both the poles and try to compress from one side and try to look for the displacement on the other side. Okay. Why can't you do it in lying down posture? Not necessarily. It can be done even lying posture, right?
Okay.
What do you mean by bilocular hydrocele?
The hydrocele,
When you have an inguinal component and a scrotal
Scrotal.
component, we call it as a bilocular hydrocele.
You are doing very well. True to traditions of MMC. Coach, so what is the hydrocele of canal of neck?
it is the female counterpart of the hydrocele where the round ligament is involved.
Oh no, it is persistent processus vaginalis in a female. Processus vaginalis, a representation there in female also, even though you relate it to testicular return, it is there in a female. When it is persistent, you call it, and some people say it's a femoral sac also, they call it, where is the correction of fluid?
The in a tunica vaginalis.
Distal to the obstruction.
Okay.
When there is a collection of fluid in the cord in a male, what do you call that? When there is collection of fluid in the cord in the male, what do you call that?
It's a encysted hydrocele.
What is the clinical sign for that?
Traction test will be performed, sir, to check for the mobility of the
Madam wants
right
to.
side.
Where is the fluid collection means tunica vaginalis, you should not say, you should say
Between the two
between the
layers of-
visceral and parietal
parietal
layers of the tunica vagina. That's what you have to say.
Okay.
Jaw place, eversion of sac. Because the swelling is large, it is of 12 cross 10 centimeter. So
No, what is the purpose of whatever excision or eversion? What is the principle behind this?
we are so after everting, the fluid will automatically drain to the lymphatics. If any of the fluid get collected, automatically drain to.
So the secreting surface will become non-secretory in a due course of time. Until that time, it gets absorbed by the lymphatics, which is present in the dartus musculature.
How will you manage a bilateral hydrocele?
So excision.
Incision, yeah.
Excision.
Have you known one procedure called Lord's procedure? Can you elaborate?
Lord's procedure is Lord's plication of the sacs.
It is plication. Yeah, you do underrun, aggregate the sac.
Sac.
Which category of people you do? Early hydrocele, job hydrocele, or to filarial hydrocele?
So in case of a small early hydrocele.
The so-called job hydrocele
hydrocele.
are uniform. Dr. Kanagavel is restless. We got the program to go on. Full marks to you, the MMC team. All the best to all the exam going undergraduate students. From Chettinad, I think we have finished our final year exam. Probably you are taking up all the best for you for this session.
Thank you, sir.
Can you tell me some conditions where you can have a cross fluctuation? In a bilocular hydrocele, you can have cross fluctuation. Apart from that, any other reason where you can have?
Ganglions.
Compound palmar ganglion, which occurs in the wrist, which is due to tuberculosis, and bubo, where there is a fluctuation on either side.
Any collared abscess, you can have
Collared
a
abscess.
fluctuation. Psoas abscess, iliosoias, you can have a fluctuation.
They are matching our amplifier, madam. We leave them.
Thank you.
Great.
Thank you very much, faculty. I request Shruti ma'am to hand over the faculty certificates. And students of the first two thing, I think Renuka and Satish, can you come up to the stage, please? Students stay back. Renuka and Satish, come up to the stage, please. Satish, are you here? I request madam to hand over the certificates to the presenters, Renuka and Satish from MMC and from KMC. You are from? Yeah, please come. Sir, Ragumani sir, students certificate. I now request Dr. A.R.K. sir, Anandaram Krishnan sir to come up to the stage. To come up. Balaji sir, Jai Vinod Kumar sir and Dr. Senthil Kumar sir, please come up. Thank you, faculty. And I request the next team of faculty to take over. Dr. A.R.K. sir is from Chettinad Hospital. Kuberan sir from Balaji Medical College. Dr. J. Vinod Kumar from SRM. Dr. Senthil Kumar from Chettinad. Can we have the student from KMC? You are ready? So Mugilan and Malini, give them a big hand. Cheer up. Good morning. I am Mukilan. She is Malini from Kilpak Medical College. We are presenting a case on malignant ulcer extremity. Mr. Mani, a 60-year-old farmer coming from Red Hills, presented a chief complaints of ulcer over the right foot for the past 6 months, bleeding from the ulcer for 3 months, multiple swellings in the groin area for 1 month, and difficulty in walking for the past 2 weeks. Next. History of presenting illness. The patient was apparently normal 6 months back, after which he noticed an ulcer in the right foot, insidious in onset, gradually progressive in nature, initially started over the side of the foot and gradually increased in size to involve the feet, not associated with pain. History of bloody discharge from the ulcer present for the past 3 months, on and off, on foul smelling in nature. Next. History of multiple swellings in the inguinal region present, insidious in onset, not associated with pain. History of difficulty in walking for the past 2 weeks present. No history of fever, no history of trauma, no history of loss of sensations around the ulcer, no history of restriction of joint movements, history of significant loss of weight and appetite present, no history of evening rise of temperature, no history of cough with expectoration.
Present only the important relevant history.
No comorbid disease present. Next.
Anything in the past history?
Nothing, sir. No exposure of toxins. No.
Go to personal history.
Personal history not relevant, sir.
Very good.
Dental examination normal, sir. Vitals normal. Sir.
Anything is important?
Nothing significant is present here.
Think again.
Ill nourished.
No. You didn't examine the lymph node.
Sir.
Have you examined the lymph node?
Generally, yes.
You should mention that.
Yes, sir. Generally,
that is important finding. Yes. You remember that. Okay.
Doctor, in the previous slide, you asked for history of fever cells. Why did you ask in this patient?
Sir, inflammatory ulcers and superadded infection over the ulcer can present with fever, sir.
So in such a long-standing ulcer, you still think of inflammatory ulcers?
Superadded infection in the ulcer can present with fever and sepsis.
Okay.
So in your history, you told about history of swelling in the inguinal region. What do you mean by that?
So it might be due to the metastasis from the malignant ulcers.
So you are meaning it is a inguinal lymphadenopathy.
Yes, sir.
So in general examination, you should mention that, right? You should mention that there is inguinal lymphadenopathy, which will be elaborated in the local examination.
Okay.
No generalized lymphadenopathy important, but I will mention.
Local examination of the right leg. After getting consent and adequate privacy, the patient was exposed from the umbilicus down, patient in supine position. An ulceroproliferative lesion of size 10 × 7 centimeter is seen in the medial aspect of the right foot, starting 1 centimeter below the medial malleolus, extending to the plantar aspect, almost covering the heel and midfoot. It was irregular in shape, well-defined margins, raised and everted edges, covered with slough and minimal granulation tissue. Bloody discharge is seen. The surrounding skin appears normal. No scars, sinuses, or dilated veins present around the lesion. No visible inguinal lymph nodes present. No dilated tortuous veins in the right leg, and no edema in the right leg. On palpation, all inspectory findings are confirmed. Ulcer is not tender. The surrounding skin is not warm. Base is indurated. Bleeds on touch. Examination of the right inguinal region. 2 discrete lymph nodes are felt. 2x2 and 2x1 centimeter in size. Non-tender, mobile, hard in consistency.
One point. You said no generalized lymphadenopathy. In that, you should mention inguinal lymph node present, other areas normal.
Okay, sir. Dorsalis pedis artery and posterior tibial artery pulsations are felt equally on both sides. No distal neurological deficit, no restriction of ankle joint movements. Examination of the left leg and left inguinal region is clinically normal. Other system examination.
Normal.
Normal. Diagnosis. An ulceroproliferative lesion of the right foot with inguinal lymphadenopathy, most probably a squamous cell carcinoma of the right foot.
See, in this, you need not mention about the ulcerative or ulceroproliferative. It's not necessary. Just
Okay,
go ahead with the squamous cell carcinoma of the right foot.
Okay,
That's enough. That should be our diagnosis. In
Okay.
case if the examiner asks you, why do you say so? Then you can say the ulceroproliferative lesion, then raised and everted edge. What else?
Base is indurated, sir, and it
Indurated.
bleeds on touch.
Bleeds on touch. These are the features we should say.
Yes, sir.
Otherwise, in a simple term, squamous cell carcinoma in the right foot.
Right.
That should be your diagnosis.
Okay.
With
Sir, inguinal lymphadenopathy.
very good.
Is there any induration in the surrounding skin?
Yes, sir.
You should
Sir.
mention that for how much centimeters is the induration present. And on inspection also, you told there is no visible inguinal nodes. You
Yes,
should
sir.
tell there is no swelling in the inguinal region. So you can't tell there is no inguinal nodes seen.
No
That
swelling
should
in
not be
inguinal
the
region.
inference. Okay.
Okay, sir.
Okay. Then
Doctor,
can you
on
tell what are the changes in an ulcer which denote that it can be malignant?
So the raised and everted edges on the inspection, sir, it's a proliferative growth and bloody discharge is seen, sir, around the ulcer. Induration is present
Okay.
and inguinal lymph nodes are hard in consistency, which probably indicate.
Pigmentation is seen in low pigmentation is seen in malignant melanomas.
Is inguinal lymph nodes always to be present in a malignant ulcer, or you can have an
We
ulcer
can-
without a inguinal lymphadenopathy? Okay, what is that called?
What are the features to say it's
What is that ulcer which do not present with an inguinal lymphadenopathy?
So Barnes-Jones ulcer, which arises from the burn scar. Basal cell carcinoma because the cells are larger in the ducts.
Okay.
Doctor, go back to palpation. No, see you in palpation, the positive findings you put off. There are for a routine ulcer, we see a lot of things. We look for mobility, fixity and all. We see if it is a region where the ulcer is smaller. In this such a large ulcer, usually no need to see. That is the usual part which confuses undergraduates. So where to say mobility, where we no need to check for mobility. See, this is an ulcer. As rightly you have put up, you have not said anything on mobility. Such large ulcers involving almost a compartment of a tissue. The entire foot is involved. 3/4 of the soft tissue of the foot is involved, where you cannot look for. Suppose you will see a smaller lesion of 3 into 4 centimeter ulcer in the calf muscle region where you have good volume of underlying soft tissue where you can check for mobility. Those things.
Yes.
Okay. So you can mention on joint mobilities in this area. On palpation, so almost it in and around the ankle joint involving all in the midfoot area joints and the subtalar joints where definitely range of movements in the foot you could mention on palpation.
Okay.
Okay. That's definitely should be mentioned. So adile ungalku how much the foot is functionally useful, you get a clinical idea. Whether you can salvage a foot or though or whether you cannot salvage the foot. Okay.
what are the other types of edges you know?
Sir, undermined edge seen in the TB, tuberculous ulcer. Punched out edges seen in arterial ulcers. Sloping edges seen in healing ulcer or varicose ulcers. And rolled out and beaded edges and basal cell carcinoma.
What's a common site for basal cell carcinoma?
Sir, above the line joining the angle of mouth to the ear lobule, sir.
What are the other sites for you get squamous cell carcinoma?
So squamous cell carcinoma can arise anywhere in the skin, sir. And skin mucous membrane.
You know from which layer it originates?
Squamous cell carcinoma arises from prickle cell layers, stratum spinosum.
Granular cell layer.
Sir?
It arises from the granular cell layer.
Okay.
Okay. See, in your investigation, you have put up MRI, CT, again CT, abdomen. Why you want to do CT, abdomen and pelvis?
Sir, for nodal status, sir.
Do
Involvement
you
of-
think SEC in extremity will spread to the retropatellar nodes, or you have the nodes around the iliacs involved?
Sir,
Is it common? Is it common?
Sir, if the pre-aortic, para-aortic and ilio,
See,
not
you,
common, sir.
you inguinal lymphadenopathy, okay. Next echelion becomes the common. It's very rare in extremity, but particularly in cutaneous malignancies going to the nodes in the para-aortic region or the iliac nodes. You don't need to mention at all. Of course, what we observe in undergraduates is, see, you write off the investigations as you write for a theory exam in a practical exam, not necessarily. What is your diagnosis? What you are going to do for the patients? You are writing from head to foot, all the, if you give a varicose vein, you're writing all the investigations. Don't write like that. What will be the most appropriate metastatic workup you think for in this patient?
FNAC writing.
So CT abdominal is not necessary, definitely. So CT or MRI, either or the other, you are correct. Okay.
So doctor, what are the malignancies which can present as an ulcer? Can you tell? Other than squamous cell carcinoma?
Basal cell carcinoma can present as ulcer, sir.
Okay.
Malignant
What type of basal cell carcinoma?
nodular ulcerative type of basal cell carcinoma
Okay.
can present as ulcerative type of malignant melanoma can present, sir.
Okay.
Be the finding in malignant melanoma clinically?
Intransit nodules and satellite nodules around the primary ulcer.
Suppose this is, you are going to give a diagnosis of malignant melanoma. So then CT abdomen pelvis could have been appropriate investigation. Okay. So in the same case, do you think the ulcer started as a de novo and presented as a ulcer proliferative lesion? Is it very common? Squamous melanoma starting as an ulcer.
Starting as a proliferative growth and the
Most of the time it starts as a nodular lesion, which goes unnoticed. The patient ignores. Then it ulcerates. Then it proliferates. Okay. Or the vice versa. Long-standing non-healing ulcers turning into a squamous cell carcinoma. So starting as a ulcerative lesion, very, very rare, presenting as a SEC. Okay. Most of the time it's a nodular lesion.
Other than the skin malignancies, doctor, do you know any malignancies presenting as an ulcer?
Sir, leukemia cutis can present as ulcer, sir.
Okay.
There
are many malignancies which can present as an ulcer in the skin.
Yes, sir. Carcinoma inclusions in breast cancer can present as an ulcer in the breast.
Okay, okay, that is metastasis. I am telling primary tumor.
Sarcomas can present as an ulcer, sir.
What type of sarcoma?
Fibrosarcoma and
Commonly angiosarcoma can present as nodules, okay, which is reddish in color and can ulcerate. Okay. Then you can have a cutaneous T-cell lymphoma, okay, mycosis fungoides. So that can present as an ulcer, non-healing for a long time, and it can be a T-cell lymphoma. So other than these three skin malignancies, you should have those also in mind if a patient is having a non-healing ulcer. Okay. Then as you tell, there can be metastasis from breast or
Sir,
GA malignancies,
Not
colonic
necessarily.
malignancies. Okay. So they can have a skin metastasis also, right? So the most important investigation to clinch the diagnosis. One investigation to clinch the diagnosis.
edge biopsies.
Edge wedge biopsy. What do you see?
Sir, keratin pulse, a mass of keratin surrounded by whole bundles of normal pink pixel cells.
Why it is important in classification of the malignancy?
Broadest classification, sir, it determines the prognosis, grade 1, 2, 3, 4, from well differentiated to undifferentiated.
Okay. So what is the
More number of
treatment?
keratin pearls, it's good prognosis or a bad prognosis?
Presence of
more
keratin
keratin
pearls is a
pulse.
good or bad is asking, sir.
Increased number is a good prognosis,
Good.
sir. Decreased number is a worse prognosis.
Where will you take the biopsy?
Sir, edge biopsy, sir.
Edge wedge biopsy. Why not from the center?
Center usually undergoes necrosis, sir, and edge is the most proliferative area, and we have to compare with the normal epithelium.
What other investigation? Relevant investigation. Don't write as you write in the theory. It's not at all
LFT.
necessary.
Why you want to do LFT in this patient?
Sir, albumin after wound covered by flap, albumin is needed.
Albumin is needed.
Serum albumin decrease.
Is it common?
Sir?
Is it common? Extremity malignancies producing cachectic picture.
No, sir.
See,
but
even in the
vision-
last case in inguinal hernia, I saw LFT was written in the investigation. Why you need to want to do an LFT for a patient with inguinal hernia?
Any palliation
Is it necessary?
and treatment wise?
Not
You are
necessary.
going to give, suppose if it is inoperable,
Ah.
what
On
you're going to give?
chemotherapy drugs.
So before starting chemotherapy,
In that way, you can see, you discuss in such a way, you are only pre-off stage. So no need for LFT at all. Okay, no, don't even mention. So what are you going to do for this patient?
On CT, if there is no bone involvement, wide local excision and primary wound.
No
are by-
involvement. No involvement. We take it as
No
no
bone
involvement.
involvement.
Yes, what
no
you'll
bone
do?
involved.
What
What
you'll
is
do?
the treatment?
Wide local excision.
For this patient, is it possible for you to salvage the foot even if there is no bony involvement? Can you show the picture?
Yes, sir.
Show the picture.
Anna.
See, it is not only the bony involvement which decides whether the leg is to be amputated or not, right? So the lesion is extending from the heel medial malleolus till nearly the anterior aspect, right? So is it possible for you to salvage the foot by doing a wide local excision alone?
Try flap, sir.
Huh?
We can try the wound cover by flap, sir.
Wound?
Cover
Sir is
by flap.
asking, is it possible to salvage the limb? He's
Show,
asking.
show that picture, doctor.
Anna, first slide.
The lesion is more of. Is it possible?
So the lesion is more of an exophytic
For
growth.
this case, ideal it is an amputation. Okay, so one joint above you do an amputation. Only for smaller lesions you do a wide local excision, giving how many centimeters of clearance?
So wide local excision 1 centimeter of clearance for lesions.
For squamous cell carcinoma,
1 centimeter for lesion.
you ideally give 2 centimeters of clearance from the point of
Maximum duration.
induration. So it is not from the point of the ulcer edge, it is from the
Margin.
palpable induration. From that you give the clearance, because the palpable induration tells that there is a micro invasion of the malignancy to the surrounding skin. Okay, thank you.
If it's a small lesion, you can go for a wide local excision, then go for a flap, not a SSG. Remember that because it's a foot weight bearing area. So flap. Second thing is how will you manage about the lymph node?
Right ilioinguinal block dissection if the lymph node.
Try with antibiotics. If not, go for a
If not, go for radiation therapy.
2 to 3 weeks of antibiotic, if not resolving. So one thing what I want to say is always be prepared for the lateral questions. So hydrocele vachittu 25 peri hydrocele, don't expect the exam to ask the same question. Sometimes they go into the anatomy physiology. So you prepare in such a way. If this is the case, they will go into the muscles, attachments, joints. Prepare. So what are the regional draining areas? What are the nerves involved? What are the soft tissues around the joint? What are the ligaments? Anything you might be. Apart from this, if you do that, if you face such a question, means that you have done well. You are scoring more. So be prepared for that. Prepare a case. Always think of the lateral aspects. So this is anatomy. Thank you.
Suppose the notes are fixed, how will you manage?
Palliative radiotherapy. Thank you, sir.
Thank you, faculty. Students, please stay back. And I request the convener, Dr. A.R.K. sir, to hand over the certificates to the faculty. Friends, we have the pleasure of having the national president of the ASI. Again, a very eminent teacher, Professor Sanjay Kumar Jain, sir. He is professor and head of the Department of Surgery, Gandhi Medical College, Bhopal. Very, very favorite teacher for all the students and our national president. He is going to give you a brief talk on how to approach a case of hernia, because hernia is almost a mandatory case for all of you. Sir will highlight the important tips one should keep in mind when I'm presenting a case of hernia. Sir, can I have the honor
Good morning, everybody. Are you want to say something, please?
Yeah. Good morning, all of you. Today we are happy to have our national president, Dr. Sanjay Kumar Jain, from Bhopal. Actually, he is a professor of surgery, HOD, and very much involved in
ASI activities for the past 25 years. I am seeing him. He is going to give some important tricks and trade in the field of inguinal hernias. Yes, sir. With these few words, I invite Dr. Sanjay to offer his remarks.
Thank you, sir. And good morning, everybody, all respected chairpersons, and I see so senior faculty. Sometimes I feel, little conscious when speaking in front of so many dignitaries and all dear students. And I'm so happy that for your examination, you are here to learn. And what we have seen, often the postgraduate classes going on, and I'm so happy that undergraduates are following the same trend. There are a few more thoughts which I will just share in the in the inaugural function. Before that, hernia, you all know, it's very important case. And this presentation, if you want, you can either take pictures, or you can, even if it can be shared with you. This is simply simple way to remember what you have to do in a hernia. Most of the candidates, somehow it will be given either theory, practical, so you cannot skip. So by definition, what is hernia is? So hernia is a protrusion of a viscous part of a viscous through an abnormal opening in the wall of its containing cavity. Remember, whenever an examiner asks about the definition, give the definition. There is a difference between defining, describing, and defining. So when we ask for a definition, you people start, means the students start describing it. Do not describe, say these 2.5 lines. This is what a hernia means. Then if he has got any other query, he will ask you. So etiology, the classical teaching, which I have read as a student about 40 years ago, even you need to remember, there are few things today in an era of the evidence-based medicine. The evidences have gone little different, but it is not that you forget what has been the classical teaching. So any condition that raises intra-abdominal pressure, like whooping cough in the children, chronic cough, straining on micturition and defecation, these all are important factors, but they are not only the positive factors. What is happening? So what has happened? I just humming is coming. Mobile. Okay. So what is happening? There have been researches that is this incidence is more common. So who is lifting the heavy weight? It is the Olympic weightlifters, but there has been no evidence that there are any increased incidence of this Olympic weightlifter. So remember, for the theoretical aspect, if your examiner wants, you can give, but as an evidence, we may not be the responsible factor. Smoking is very important. Smoking is the only thing which is indicated as per the European Hernia Society guideline. If a hernia patient is a smoker, he should be off smoking before operation. So smoking is very important. And there are two aspects in smoking. One, it induces the cough. Definitely the chronic smoker will have chronic cough. And the second thing, it causes the acquired collagen deficiency. Now this acquired collagen or a congenital collagen deficiency is the main cause of development of the hernia. So these are the few things. Obesity, again, question mark. Yes, our even Belly and Love will give the obesity as a cause, but it has been now, literature has shown it just opposite, that the obese patients are not prone for hernia. Then intra-abdominal malignancies, and one very important point is the congenital preformed sac, that is the remnant of a patent or a patent processus vaginalis. We all know what this processus vaginalis is. The testes, when they are coming from the abdomen to the scrotum in their journey, they brings a sac of peritoneum. It obliterates at birth. If it fails to, then it's a preformed sac. inviting the intestine to come and lie in the scrotum. So this is the cause, very important cause. This diagram I have purposely taken from your book, Love and Belly, which shows the various sites of the hernia for remembering what are the types of hernia, what is the location. You can see this diagram from Belly and Love. So coming to what makes a hernia, there are three main components. One is the sac, another are the covering of the sac, and third are the contents of the sac. So remember three important points in hernia. Sac is a diverticulum of peritoneum consisting of mouth, neck, body, and fundus. These all things are important, and especially the mouth and neck of the hernial sac is most important in deciding about the emergency of the treatment of the hernia. Because if the neck or mouth is small, there are more chances of strangulation or obstruction or complication. So those hernias are to be treated on urgent basis. Coverings are the coverings of that part. It may be skins, subcutaneous tissue, the aponeurosis, cremaster, whatever are there. So depending on the site of the hernia, the covering, the layers of the wall will be the coverings of the sac, and contents. Just I will discuss in next slide. These are the contents which can come in the hernia. What are they? First, most important is the abdominal policeman. That is the omentum, which is always in a hurry to move anywhere. So remember this omentum. There may be intestine, or there may be a part of the circumference of the intestine. The whole intestine is not coming, but a part is coming, like somebody just puts out his hand out of a running train, not the whole person is coming out. So this is the thing. Then can you close that light, because this will be not visible. There's no need to focus. So moving from there, go back. Is it doing the control? So regarding the contents, no, not next. I want the previous slide. You have gone ahead. Yes. So this is very important. That is the Richter's hernia. Sometimes you get an MCQ. So it is the part of intestine, not the whole intestine. A portion of the bladder comes as a sliding hernia and a direct hernia, ovary with or without fallopian tube. One of a very senior teacher asked me here that is it really important to differentiate between a direct hernia or an indirect hernia? I will say partially yes, sir. Because in an indirect hernia, you will never get a bladder, but in indirect hernia, the bladder may coming. So if you can differentiate, then your definitely you can anticipate a few things which may be there, and you are careful avoiding injury. My professor used to tell me he has removed a gauze piece from the bladder of the patient who was operated for hernia. That means the surgeon, without knowing, opened the bladder while operating hernia, put a gauze piece, closed it, and forgot it. So things can happen, but if you are knowing, you will avoid ovary with or without fallopian tube. Another important thing is the Meckel's diverticulum, although a rarity, when present, it is known as the Litter's hernia. So Richter's hernia and Litter's hernia are two which are sometimes you can get even as a short note. Then what are the types of hernia? Very simple. There are hernias which are reducible. The contents come, contents goes. Irreducible hernia, contents come, they do not go. In between, there can be partially reducible or partially irreducible hernia. When hernia comes and stuck-ups refuses to go, the bowel lumen is compromised, that is an obstructed hernia. When the vascularity is also compromised along with the lumen, then at that time it's a strangulated hernia. There is one more term which comes in between, is the incarcerated hernia, and this term has often been misused for any of the strangulated hernia or obstructed hernia. Basically, this is a very specific term used for especially the colonic hernias, where this colon is obstructed by the fecal material. So this is incarcerated hernia. Then there can be inflamed hernia. Inflamed hernias can be of two types. They can be inflamed from inside, like a perforated appendix or a perforation, or inflamed from outside. If you see a large hernia neglected, the patient get infection, ulceration. So this is what the inflamed hernia is. Then coming to the examination, what are important points in the history? You have to check for the age, the occupation of the patient. Then we all know, because here I will be going little hurriedly, otherwise this can go long. So I have to cut it short. The complaints, the main three complaints are there. One is the pain, which is usually the dragging kind of pain toward the end of the day after a long day work. There will be a lump, so there will be a swelling while the patient will come, and there may be systemic symptoms like cough, urinary difficulties, or constipation. So you should look for. Another thing in the past history, which is very important, any previous operation, appendicectomy. So this appendicectomy can cause a direct hernia because of the nerve injury, which is the iliohypogastric nerve. If accidentally damaged, can give rise to a direct hernia. Then hernia on the other side, it is because the bilateral hernias are more common. If a patient has got one-sided hernia, he has got chances to develop hernia on the other side. Coming to the examination, again, examiner may ask a few questions. So patient is first examined in standing position, then in the supine position. So this you should remember. What points you will note? So on inspection, you have to note what is the size and shape of, whether it's rounded or it's oval. So that will tell you what is the position and extent, because the position is extent is very important to differentiate between a femoral hernia from an inguinal hernia. And the extent is because when you are asked what type of hernia it is, incomplete or complete. So that is one thing. Are there any visible peristalsis? Just to complete the list, it doesn't make much of the changes. Skin over the swelling. Our problem is our eye doesn't see what our brain doesn't know. So you should be knowing what you are looking for in skin changes. Most of the time, skin will be normal. There may be redness, there may be pigmentation, there may be atrophic areas, or there can be a previous scar of previous operation. So all these things, when you look upon, most of the time, you will find the skin is normal. What I have seen, our students find it difficult. Sir, everything is normal. So what should I say? You say, sir, the skin is normal. Then impulse on coughing. Two cardinal signs of an uncomplicated hernia are, number one, reducibility, two, cough impulse. So you have to check these two signs. Once you see these two signs, the diagnosis is 100% that it is nothing but hernia. Position of the penis in large hernia, it may be deviated. This is again theoretical aspect. Palpation, then you confirm the finding of the inspection, that is whether it's an inguinal or a femoral. So you know inguinals are above the inguinal ligament and medial to pubic tubercle, and opposite is for the femoral hernia. the very important test to differentiate in the large scrotal swelling from an inguinoscrotal swelling. Do not perform this test if it is an incomplete hernia. You know this is an inguinoscrotal swelling. There is no need to test the getting above the swelling. But for a large hydrocele, where you get confused with the hernia, the get above the swelling test is very, very important. Consistency, you can feel whether it's dewy or granular, when it's a momentum. If it's an elastic, it is enterocele. Relation of the swelling with the spermatic cord is also important. Impulse on coughing, you will feel, and whether the swelling is reducible. Remember here, patient is the best person to reduce his hernia. If you will ask him, he can lie down and show whether this reduce. He will show you how it reduces. Then there are 3 tests which are described classically in books for undergraduate level. Invagination test, nowadays it is not recommended. Second test is the ring occlusion test, which still is one of the most important tests between differentiating from an indirect to direct hernia. So you have to find a point, the mid-inguinal point, about half an inch above the inguinal ligament. First you reduce. Again, this test will be possible only in completely reducible hernia. Do not try this test if the hernia is irreducible. So reduce the hernia, press the deep ring, ask the patient to cough, stand up and cough, and then you will find if it's an indirect hernia, it will not come out. If it's a direct hernia, it will come out. Here, one more thing. See, examiner is observing anything and everything what you are doing. Always ask the patient to turn the head to the opposite side so he doesn't things on your face, and keep a piece of cloth over his mouth so the droplets doesn't come to you. Then Zeeman test is again more of a theoretical. This is 3-finger test, which you people must have read. Read it for the sake of reading and remembering. But percussion and auscultation again are theoretical to complete your examination. Examine testes and epididymis, spermatic cord. Examine the tone of abdominal musculature. For that, you have to either perform a head rise test or a leg raising test, and you will find beautiful bulges on the both sides of the abdomen, which we know as the Malgagny's bulge. The systemic examination is completed by examination of the chest and abdomen. And finally, what will be your complete diagnosis in a case of inguinal hernia? So you have to determine, after all what you have done, is hernia, you know this is a case of hernia, is hernia a right-sided hernia or a left-sided hernia or a bilateral hernia? Is hernia inguinal or femoral? This you will decide by the pubic tubercle and the inguinal ligament. Whether hernia is direct or indirect, this he will decide with the deep ring occlusion test. Whether it is reducible, irreducible, that you will know by reducing the content after patient lie down. Is it incomplete or complete? Whether it reaches to the bottom of the scrotum, it is complete. If not, it is incomplete. And what are the contents? So whether the intestine and or the omentum. So this, then how a final diagnosis you should tell, sir, my patient is having right, indirect, reducible, incomplete, indirect enterocele. So this is the complete diagnosis in a case of hernia. Okay, so with this, you have made the diagnosis. Now only two things remains for the examiner to ask you. Yes, one is how will you investigate this patient? So there are two types of investigation. One, when you want to confirm the diagnosis. Second is for the treatment of the patient. For confirming the diagnosis, uncomplicated hernia usually do not require any investigation. In case of doubt, there are three things which can be helpful. One is the ultrasound. Second, you also know, is the MRI. And third is a herniography. Most of the things, they are done unnecessarily. A clinically diagnosed hernia, you need not confirm that it's a hernia. So, but you remember these three, they have got specific indications for an undergraduate level. If you know, sir, these are the three, but we really require the one. One is ultrasound, second is the MRI, and third is the herniography. And finally, he will ask, okay, how will you treat? Sir, hernia is essentially surgical disease. You need to operate this patient. So when you need to operate these patients, there are two approaches. One is open hernia surgery. Second is the laparoscopic hernia surgery. Laparoscopic hernia surgery, again, two techniques. One is TAPP, that is the transabdominal pre-peritoneal approach. And second is TEP, that is totally extraperitoneal approach. The open hernia, there is herniotomy, which is done in young patients, children, or as a first step of any hernia operation. The two hernias operations are herniorrhaphy, which are again less practiced nowadays. Again, two important operations, Bassinis and the Scholdi's repair. And the nowadays, which is practiced, is a Prolene mesh repair, or we call Lichtenstein tension-free hernia repair. So if you remember all these, I am for sure all the examiners will vouch that they will give you distinction in a case of hernia. Thank you very much.
Thank you, sir. Thank you for bringing out the minimum required details for an undergraduate should know, and during their examination, sir, the clinical features, the types of hernias, very simple and elegant way of described the things. If students have got any query, you can ask him. Any questions from the floor? Yes. Remember, students, the hernia is the simplest case to present in the exam, but very difficult case to pass in the exam. Right? Even a simple mistake, if you make, for example, the indirect hernia will lie medial to inferior epigastric artery. The examiner will jump out of the chair and put big zero. So the basic you should not forget. Likewise, if a complicated case like obstructive jaundice or portal hypertension, it is difficult to present but very easy to pass. So SAR has come out with minimum required details of hernia so that you can easily understand and easily present in the exam. Thank you very much, sir.
Thank you, sir. Thank you.
Thank you, sir. Thank you, colleague chairpersons. So we have a 5 minutes break to set up the inauguration. So I request the chairpersons to get down, then we can set up. Gopi team. I request Norona, the master of ceremony and treasurer for Chennai ASI, to take over the inaugural session. Over to you, Dr. Norona.
Table in center table, center level.
back to give a lecture for the graduates. So that's very nice of him. We thank him. We also thank Dr. Govindaraj, who is our state president. He's been kind enough to come all the way from his place to participate in this continuing medical education program. We also thank Dr. Marudu Pandian, whom I have known for the last 4 or 5 years. I remember we went to Madurai. There was a lot of respect for us. I didn't realize it is for him. I was just an accompanying person with him. So he's got such a popularity in the south of Tamil Nadu. And Dr. Balamurugan for having coming all the way from Madurai to participate in this continuing medical education. And I also thank the stalwarts sitting in the front row who have come all the way from their practice to participate in the CME. There are too many people. My guru, Dr. Kuberan, my chiefs, Dr. Shruti Kamal, Dr. Ragmani, my MS colleagues, all of them are sitting here. So I thank every one of them for having come here to deliver and impart their knowledge to you. I also thank all the organizers, all those sponsors, and last but not the least, all of you participating students for making this function a good success. Thank you. Thank you so much.
All are requested to join in. Janana mana adinayak jaya he Bharat bhagya vidata. Jana jana
Check. Now we move on to the next academic session. We have the lecture series by eminent professors. We have 3 lectures, one on dermal swelling, especially head and neck and extremities by Shruti ma'am, benign disease by Dr. Shanti ma'am, MMC, and then on cancer stomach from Dr. Sudipta Apollo. Can I have the honor of having Professor Darwin sir, Professor Ragumani sir, Professor Kuberan sir to come to chair the session. Please come over the stage. அப்படியே இருக்கட்டும் அப்படியே அங்க வரலையே ஒன்னும் பிரச்சனை வரல பார்த்து கை பார்த்து தெரிஞ்சு
lecture. அப்படியே அந்த டேபிள் அங்க
The first lecture will be on dermal swelling, head and neck and extremities by our great teacher, Dr. V. Shruti Kamal.
பண்ணுங்க. PowerPoint work ஆகுதா? Then you can talk. No, can interact with the same. Yeah, that's all. Till then, you can inspire some.
I thank the, I think good morning or it's going to be afternoon now. And thank you very much for the organizers for giving me yet another opportunity to. Yeah, for giving me yet another opportunity to share my thoughts on this head and neck swellings. And usually this is very important actually as far as UGs are concerned, because 20 marks is given for the short cases, no? So where you can score a lot. I respected chairpersons sitting there, sir, patiently. I'll try to finish within 15 minutes. That is the allotted time. So regarding the dermal swellings or head and neck swellings, can I have the next slide? Next slide. Move பண்றீங்களா? Okay. The important short case that is kept for you is a dermoid cyst. What is this dermoid cyst? It's nothing but a cyst that is arising from the embryonic suture lines. And usually these are midline swellings. And I also will share with you the locations. Generally, they may keep an external angular dermoid or an internal angular dermoid. They come as a smooth, soft, non-tender swellings. And it is so small for you to do a fluctuation test. The Paget's test is what you do. You hold the swelling and press it at the summit. And so you see the other two fingers moving. And clinical examination, the skin is free. And also it's a subcutaneous swelling. The bony indentation that we get, when it is almost like a saucer, a cup and saucer you have, and you go to the edge of a saucer and run your hand through, that's the finger through. So that's the feeling we have, what is called the indentation. So next slide. Can I go to the next slide? Yeah. The other sites which they may ask you where it comes, you can get in the suprasternal notch, that is what we call the space of Burns. And also sometimes you can get in the sublingual and also preauricular and postauricular. These dermoid cysts and the sebaceous cysts, the differences they will ask. Can I have the next slide? Yeah. See, sometimes why do we take an X-ray skull or sometimes a CT also we will take, because we want to know whether there is a connection there. The indentation is so much to such an extent, it might have sort of weakened that bone and it may have an extradural connection. So when we have to this dermoid, you have what is called the tubulodermoid, sequestration dermoid, and also the teratomatous dermoid. The teratomatous dermoid will occur in the ovary. What is the difference between a sebaceous cyst and dermoid? This is a congenital one, that is an acquired one. That is because of the blockage of a duct that you have got. And the contents, here it is a toothpaste-like material. We may have vestigial remnants like hair follicles and sweat glands and hair follicles. And also the teratomatous dermoid may contain the teeth and all that. And a little about this implantation dermoid. This is an acquired problem. This is because of a prick injury that you get. And the epidermis gets buried inside. and that results in an inflammation and a cyst formation. Where are these sites very common? These are only in the hands and the toes, and also sometimes we do see in the men, when they shave against against the whatever the hair follicle, it gets buried inside, and we see sometimes this implantation that might in the face also. So the treatment overall for this is an excision which you do. Yeah. Next. Next, another important thing they keep is the sebaceous cyst as a short case they will give. The other name is called the ven. What is this actually? It is a retention cyst. It is not, there are so many sebaceous glands all over. When the duct gets blocked there, the pent-up secretion, the sebum collects and forms a cyst there. And what is this cyst? It's extremely foul smelling, yellowish in color, and it is very oily and very sticky. They may ask you there is a small worm that may be there, what we call the Demodex folliculorum, which you get. And the characteristics of this is it is always in the skin, and everywhere it is be free excepting at the punctum where it is attached. What is this punctum? It is nothing but the keratin, the black spot which you see is the keratin that blocks the duct. What are the complications of, what is the clinical feature? It is it can be molded actually. That we call as a putting, which we call. And what are the complications of a sebaceous cyst? Is an infection which can get, and also a Cox peculiar tumor. And it is nothing but it forms a mass, a fungating mass over the thing. Sometimes they can mistake it for a squamous cell cancer. And also sometimes the pent-up secretion forms a tubular structure, what we call as a sebaceous horn. They'll ask you, what is how do you manage a sebaceous cyst? A cyst that is not sort of infected, it's a clean case which comes, we make an elliptical incision around the punctum and remove the cyst fully. If it is an infected sebaceous cyst, under antibiotic cover, in any infection abscess has to be drained. So you have to do a drainage of that, and also try to scoop out all the wall of the sebaceous cyst completely. You would remove everything, debride everything, scoop out the wall, so that what we call the avulsion is the word which we use, avulsion of the sac which you have to do. And the chances of recurrence are always high because of an infected sebaceous known to recur. And next. The other things, if you come over to the scalp, you get a lot of bony swellings that we get, and these are nothing but osteomata. This osteomata will be from the outer table of the bone that you get. You can always get in the upper end of the long bones also. It's supposed to run in the families too. There's nothing need to be done. It can be left alone. And this is because this is a bony swelling which you'll get. You have to differentiate it from other metastatic disease which you can get. We have to know. Then of course, sebaceous adenoma is a firm swelling which you'll get. These are more common not only in the extremities, you can get in the scalp as well as in the scrotum. They are supposed to get what we call the idiopathic calcinosis of the cutis. And this is a sepsoid aneurysm which you get, an AV malformation which you get on the scalp. You can get is a pulsatile swelling. Can I have the next slide? Yeah. So the multiple metastatic nodules you can get. That is why when you get multiple nodules, please elicit the history and also find out whether the patient has got any internal malignancy. It may be a cutaneous manifestation of an internal malignancy. Similarly, in the parietal bone, if you are getting a bony, if you are getting a pulsatile swelling, think about a follicular cancer. If it is not an AV malformation that is there, a firm swelling and also pulsatile swelling, it always tends to go to the flat bones. You can see it in the frontal sinus. You can also see it in the clavicle. So a pulsatile swelling, always go examine the thyroid to find out whether it is a metastatic disease from there. Can I have the next? Yeah. So sometimes we have the preauricular sinus, which may get infected and it will become an abscess, and you will be able to see the multiple sinus openings you will be able to see, and also it can be bilateral also. It's a congenital defect which you get in the development of the auricle. Next. So sometimes do not forget some firm swellings on the face you may get. Very commonly you can get the facial lymph node. Look for the site of infection that is there. And also one of the differential diagnosis of the facial node is the what we call the abnormal, the parotid, what we call the accessory parotid gland enlargement. Next. When we come to the lip, we have what is called the mucosal lip and the cutaneous lip. Usually it doesn't come on the cutaneous lip, the aspect, it comes on the mucosal aspect, what we get, the mucocele, which is yet another retention cyst. Can I have the next slide? Yeah, it is a mucus cyst, what we call the retention cyst, which is nothing but accumulation. There are so many minor salivary glands which get blocked, and so you can see it's always sometimes when they try to bite the lip and constant irritation can result in that alignment of the teeth. They also not all right. They can get a retention cyst, and also you get similarly a huge cyst which you get in the floor of the mouth is the ranula. When it starts going between the mylohyoid and presents as a submandibular swelling, we call it as a plunging ranula. So it's mainly the problem is because of the sublingual gland that is there, and it not only you have to do marsupialize, but also you have to excise the sublingual gland to prevent the recurrence. Can I have the next slide? Next. When we come to the neck, we have the branchial cyst and a thyroglossal cyst. This branchial cyst develops from the vestigial remnants of the second branchial arch. When you get the same thing in a branchial cleft, you call it as a branchial fistula. This is lined by a squamous epithelium. It will come as a fluctuant swelling. It contains thick and turbid fluid. It will not be transilluminant. It is just found at the junction of the upper third and the middle third of the sternomastoid, and anteriorly. Ultrasound is what you do, and treatment is a complete excision. Then we have what is called the cystic hygroma, or you can even call as the hydrozele of the neck, they call it. It is cleared, it is sequestration of the lymph sacs that you get. And so you get a clear cystic swelling that comes with a single layer of epithelium with a mosaic appearance. And also sometimes it can be bilateral. They attain enormous size. They can extend into the supraclavicular fossa and into the upper chest also. They are very soft and mildly compressible and brilliantly transilluminant. Still, it can be a cystic hygroma, but when there is an infection and repeated infections will make it not transilluminant. The treatment is complete excision at an early stage. There are other methods of treatment like sclerotherapy and so on, but for you, you just tell us only about the, tell the examiners that it could be completely excised at an earlier stage before it becomes very big. So this tubulodermoid, which I was telling, is an example of the thyroglossal cyst is like that. It always comes in the midline, and it will move on protrusion of the tongue as well as the deglutition, and they become infected, and also they can rupture on the skin and presenting like what you call a discharging sign as it comes. And the positions are, it can be in the foramen cecum, the base of tongue, it can be suprahyoid, it can be subhyoid, at the level of the thyroid cartilage, at the level of the isthmus, it can go at the level of the cricoid cartilage also. So what is that? Because the hyoid bone, you know, it develops much later than the descent of the cyst. That is why we always see the thyroglossal duct going inside the hyoid bone. So it is not that it does not burrow. It is because of the fusion of the hyoid bone that takes at a later stage. So what should you do for this? Because there is a risk of infection as a complication, and sometimes you can get a papillary carcinoma, papillary carcinoma arising from a thyroglossal cyst. So with that, keep things in view, we always try to do a cyst trunk operation. But if you have a lesion like that in the foramen of cecum, because differential diagnosis of a lingual thyroid you may have, so that's why you should do an ultrasound of the neck to find out there is a thyroid gland existing or not before you do surgery. So this is a laryngocele. This is laryngocele is protrusion of the laryngeal mucosa, mucosal protrusion into the larynx that you can. This we commonly see in people who are glass blowers, and those people who play the trumpet, and people who are talking a lot. And how do we get it? It's a resonant swelling which you will get in the neck. It will be very soft, compressible. The only test that you do is you do the Valsalva maneuver. When you do that, the swelling becomes very, very prominent. The treatment again is excision. You can have an internal laryngocele or external laryngocele. External, that is visible outside. Internal, where the protrusion occurs inside the larynx. So we have what is called the subhyoid bursa. These bursas can occur everywhere, and one such thing is a subhyoid bursa. If you see the thyroglossal cyst that's vertically placed, the subhyoid bursa is transversely placed just below the hyoid bone. It can get infected, and so it becomes a subhyoid bursitis. May I have the next slide? So, okay, the treatment is excision of the laryngocele. Next. Yeah. Okay. And the carotid body tumor is yet another benign tumor. We can call it also as a paraganglioma. It arises from the chemoreceptors at the bifurcation of the carotid. It arises from the adventitious layer of the vessel. And you can nicely see the splaying of the carotid artery. The external and internal will be sort of displayed and splayed very well. And that sign is called the Lyre's sign. It will come so anteriorly, you will be able to visualize the pulsation itself. And it is a transversely mobile swelling, and the treatment is excision. It is very rare to turn into malignancy. When we come to the extremities, we have what is called the nail bed tumors or the glomus tumors. There will be always, so the glomus cell surrounded by the arteriovenous malformations there, and the treatment is excision. It will come as a subungual swelling, very painful swelling. So the treatment is excision following an MRI, which you do. And okay. Next, we come to the ganglion will be kept for you in the exam. It's nothing but a cystic swelling that occurs as in relation to your tendon sheath or a synovial sheath, or it may be from the joint capsule. It contains a gelatinous clear fluid. The common sites where you get is the dorsum of the wrist, near the scaphoid or the lagunate articulation. And also it is the pathogenesis is nothing but a cystic degeneration of the tendon sheath and the leakage of the synovial fluid through the joint capsule. Then I have the next slide. So actually, when you see it is a tensely cystic and fluctuant swelling, it will be mobile transversely. But when you put the muscle, the tendon into contraction, it has a restricted mobility, and you have to be aware what is the cause for recurrence is because people fail to understand that it communicates with the joint space, and also an excision is the treatment of choice. It always comes when the patient is using the wringing movements of the hand, like twisting movements in the hand, or some wear and tear of the hand can result in a ganglion. Then we have what is called as a compound Walmar ganglion. What is this one? This is actually because of the tuberculous tenosynovitis of the flexor tendons. It may be associated with rheumatoid arthritis. There is a cross fluctuation which you get because not only you have a swelling in the palm, you also have it in the wrist also. Antituberculous is what? Another thing is history of injury. You should always ask. Suppose somebody gets a very firm to hard swelling on the extremities in the arm or in the muscle and all that. History of injury. There may be a small fracture, maybe there. The osteoblast may come out and there will be a hematoma there. The whole thing gets calcified and you can get what is called the traumatic myositis ossificans progressiva. Then we have the neurofibroma. It is nothing but a benign tumor which arises from the connective tissue of the nerve sheath. It's a fusiform swelling which you have. The difference between lipoma and this one here, this is transversely mobile. That is perpendicular to the nerve sheath, it will be mobile, whereas parallelly it will be immobile. It is firm in consistency, and also the patient will look for caffeole spots over his body. We have what is called the neurofibromatosis 1 and neurofibroma 2. This is what we have, the von Reckling-Hausen's disease, which you get. And this neurofibromatosis 2 may have acoustic neurofibromatosis. Can we have the next slide? Then we have what is called the schwannoma. The schwannoma arises from the Schwann cells. It's also called as a neurilemoma, and also it will be lobulated, encapsulated, and it is common in the acoustic nerve, and it is ectodermal in origin. There, that is ectodermal and mesodermal as far as the neurofibroma is concerned. So you have the Anthony type A, where you have 2 rows of spindle cells with central acellular area, what called the verrucous body, and Anthony B is the acellular myeloid areas which you have. What is the complaint which the patient will have? Hyperesthesia, which are the nerves it can come in the neck from the vagus. Very commonly you get vagal schwannoma. It can come from hypoglossal nerve. Sometimes it can arise from the facial nerve also. That is why when a patient has facial Bell's palsy, should not just think only the other conditions. As a surgeon, one must look for a schwannoma arising from the facial nerve. The treatment is excision. The nerve can be preserved very well. So when we come to the lipoma, what is it? Lipoma, it is a tumor arising from the fat cells of the adult type. The yellow fat, which we call, it's a universal tumor. It is freely mobile. The slip sign. You hold on to your finger to the edge of a swelling. It will slip from your finger and it is mobile all around. Why does it slip like that? It is loosely packed in a pseudo capsule, and also some amount is fluid under the body temperature, and so it can move very freely. And multiple, you have 3 varieties in this. It can be a single encapsulated, the surface is lobular and the skin is free, and it will be multiple lipomatosis, which call adiposis dolorosa or Dercum's disease, or you can even call neurolipomatosis. There is some amount of pain over this. Then you have what is called the diffuse lipoma, which you call the pseudolipoma also. Next slide. Where are this is a very common question which is asked. What are the locations where you get? It can be in a subcutaneous plane, subfacial, intermuscular, subsynovial, intra-articular, perosteal, intraosseous. Within the bone also you can get. Next. Subgaleal, below the gallia aponeurotica, you can get extradural, it can go, and submucous and subserous. When you get this submucous in the intestine, it can cause an intussusception, where you have the telescoping of the proximal bowel into the distal bowel, and also you can have intraglandular. Sometimes it can come in the parotid, it can come in the pancreas, and many of these glands, it can come in any gland that is there. What is the complication? So it can be a saponification, it can be a calcification. It's a myxomatous degeneration that can come. I told you the intussusception which you get. Always don't say that lipoma turning malignant. We never use that word. You always say it is some kind of a de-differentiation into a malignant liposarcoma. So what is this? Sometimes you get rounded solid swellings in the body, and it would have been, the patient will say it's present from birth. This is the hamartoma which you get. It is nothing but a developmental malformations of tissues of that particular part where it has to be, but only thing is a very haphazard arrangement of the tissues that are there. These are benign, they never turn malignant, it has got no capsule, and you can be left alone like that. Nothing happens to that. But if the patient wants, you can excise it. Then we have what is called the vascular swelling, hemangioma. It is nothing but a congenital malformation that is occurring in the vessels. It can just involve the capillaries. If it is involved in the capillaries, you have the 3 varieties which you have. The salmon patch, which we call in the forehead, the port wine stain, which comes in the head and neck, strawberry angioma you can get. Then the cavernous is the venous hemangioma, or it can be an arterial AV malformation which you get. So this is what I told you, the salmon patch. Okay. What is the clinical finding? It will be soft, compressible, and you have to auscultate to find out if any pulsation is there. Whenever it is a congenital AV malformation which you get, there will be pulsation that you can be. You can get a bruit also. There can be a local gigantism. The venous, all dilated veins will be there, but distal limb ischemia will be there. Closer to the heart, the more cardiac problems the patient will have. The distally, more farther away from the heart, it is going to be an ischemic problem because of the hyperdynamic circulation from a high flow system into a low flow area. It is going, so you get all these findings. Okay. Then we have what is called the soft tissue tumors, which you call that. That is one of the very good soft tissue tumors to have because it rarely metastasizes. It is locally, it can come back again. There will be nodular protuberant swelling. It will be firm in consistency, very slow growing, and always we do wide excision because it has got a high chance of recurrence. And okay, that's it. And anything else? I think 15 minutes done. Extra, sir. I was expecting somebody to come because this is a very. Huh? Finished it.
Madam, all the students were spellbound by the vast experience of yours, very crisply and clearly put.
Thank you,
All the
sir.
exam points are there.
I'm sorry, I overshot my time because I expected somebody to come and tell me. Oh, thank you.
So my teacher, so very good surgeon also. Very, very benefit, very informative to all the students. Thank you, madam, and thank you all the chairperson. Let's move on to next. Benign breast disease. Move on to next, the brain breast disease, present by Professor as well as Director, Madras Medical College.
Same chairperson. Yeah. No, same. Dr. Shanti, no? Same three people. Moon pair.
Professor Sengutun, sir. Come on. Professor.
Professor Shanti.
Good morning to all. At the outset, I thank the organizers and ASI for giving me this opportunity. I am here to talk on benign breast diseases. Next slide, please. I think you can identify who is this. Yeah, I'll ask a last question with this. Next slide. So everybody knows that breast is a symbol of womanhood, and it is also a dynamic structure which undergoes constant changes throughout, from starting from menarche to menopause, even after that. So these cyclical changes, it differs from normalcy to disease. Next slide. The congenital defects may be developmental anomalies like development of absence of nipple, may be athelia, it can be a polythelia, or it can be a total lack of development of breast tissue, amastia to polymastia, or it is amasia when there is breast tissue is absent, wherein the nipple is alone present. Some pictures, next slide. These are some pictures depicting the congenital defects, okay, congenital malformation. Next. So now the new word is coined by Cardiff Breast Clinic by Hughes. It is all the benign breast diseases are termed as aberrations in the normal development and involution. ANDI, we shortly name it as. It is based on the changes which occurs in the following phases, like during the developmental phase between 15 to 25 years, when there is a development in the lobules, some changes occur. Some cyclical changes occur due to changes in the hormones, which is in the middle age between 15 to 50 years, and premenopausal and menopausal, some changes occurs between 35 to 55 years. Next. So the changes which are occurring is some fibrosis, cyst formation, papillomatosis, and also hyperplasia, which is more important amongst the all. Definition of hyperplasia is when there is more than 2 layers of cells in the lining of the ducts and acini, we call it as hyperplasia. It can be a atypical ductal hyperplasia or can be a lobular hyperplasia, of which the ductal hyperplasia is very important. And if it exceeds 2 millimeters, we call it as ductal carcinoma in situ. Usually all the breast diseases it presents as most 3 important clinical features is it can present as a lump, it can present as a pain, we call it as mastalgia, or it can be a nipple discharge. Next. So this is ANDI, we classify, it can be a normal process to aberration to a disease. Depending on the age, it can be a lobular developmental, can lead to aberration as a fibroadenoma, or it can become a disease when it is multiple fibroadenoma or a giant fibroadenoma like that. Or it can be a stromal developmental changes where it can lead to an hyperplasia or a gigantomastia, or a nipple, usually it becomes everted, sometimes inversion, congenital eversion or developmental eversion can occur. In the middle age group, it can be a cyclical changes mainly due to the hormones, where it presents mainly as a nodularity and pain. The pain may be excruciating when it becomes decapacitating and may mimic a disease. Involution is very important in the premenopausal and perimenopausal age, where there is lobular involution and ductal involution, where the cyst formation, nodularity, fibrosis, everything occurs, that leads to some changes, which may lead to pre-malignancy and malignancy. Next slide. This is depicting solid tumors and the cystic tumors. Next. So the classification of benign breast diseases is either non-inflammatory or inflammatory, according to the recent guidelines. Now either the solid tumors can be a fibroid. Commonly we encounter a fibroadenoma or a phyllodes tumor, a duct papilloma or hematomas. Cystic lesions can be a galactosele, a breast cyst, or a hematoma or a traumatic fat necrosis. Inflammatory lesions are most commonly in the puerperium, or it can be an acute inflammation abscess leading to in the puerperium, or it can be a chronic abscess or infection. And there may be other changes also. Solid lesions we classified into common things which we encounter and we are going to get in the exams are fibroadenoma, phyllodes tumor, duct papilloma. Rarely it can be a traumatic fat necrosis or a hematoma or hematoma. Common is fibroadenoma and phyllodes tumor. If it is available, we'll keep it as an example. Next. Now coming to fibroadenoma. Next. It's a benign encapsulated tumor occurring in young females. The commonest age group is 15 to 25 years. It is due to hyperplasia of a single lobule of the breast. It is common more in the Afro-Caribbean people, and it is considered under aberrations of normal development and involution. But the relative risk of fibroadenoma developing into malignancy is very, very less. If it is simple fibroid, it is less than 2. If it is a complex and some hyperplasia and histological changes occur, it can be between 3 to 4%. Next. The types on macroscopic either we now divide into, it can be a soft, more cellular. It can be more firm in consistency and maybe hard when there is more fibrous tissue. And we call it as giant fibroadenoma if it is more than 5 centimeter in size. The clinical features, it presents either as a lump. Usually it is a soft, encapsulated, freely mobile within the breast tissue. So what we call it as? Breast mouse. Usually it is so freely mobile, we call it as a breast mouse. And there is usually no lymphadenopathy, skin is not involved. Okay. So this is maybe a juvenile fibroadenoma or it can be a giant fibroadenoma. Usually the any assessment of the breast is called triple assessment. We do a clinical examination followed by imaging, followed by a histopathology. Same thing with ultrasonogram. It appears as a hyperechoic lesion. Rarely, if it is prolonged for many years, in adults, it is sometimes show in mammogram as macro calcifications. We call it as popcorn calcifications. Prolonged becoming changes occurring in the fibroadenoma may lead to calcification in a mammogram. Next. The treatment is usually reassurance if it is less than, the size is less than 3 centimeter and the patient is young and there is no other complications. We usually ask them to we reassure them, ask them to have a regular follow-up. But if they need, if the patient insists that I don't want any lesion in my breast, we may have to go for a excision and biopsy. In a giant fibroadenoma, because the size is a disparity is there and some cosmetic disappearance is there, we may have to go for a excision. That too, we use a submammary incision for it. The indications for surgery in a fibroadenoma are age more than 30 years. We have to evaluate and if needed, we have to go for a surgery. And size more than 4 centimeters, suspicious of malignancy in imaging and also by histopathology like FNAC if you do, and a strong family history of breast cancer and the patient's preference and cosmetic reasons. Next. Next, we go to the phyllodes tumor. You usually know that it is a huge lesion which appears as a bosselated surface with dilated veins. But the skin and the pectoralis fascia, everything is free. It is freely mobile within the, it occurs only in the breast tissue. Usually there is no lymph nodal enlargement in this also. Next. So there are some other names, synchronous names like cystosarcoma phylloids, serocystic disease, all these are the names for it. And I already told you, skin and chest are free. Sometimes ulceration occurs because of the pressure necrosis. What happens then is you do the probe test. There is a space between the skin and the lesion. So you can usually introduce, so differentiate between the carcinoma and the fibrocystic disease. Next. It is a on gross cut section. It has large cystic spaces with brownish cystic areas. On microscopy, leaf-like, that is what is called as phylloids. The leaf-like projections is the name given as phylloids tumor. It shows hypercellularity and pleomorphism. And depending on it, the cellularity and the mitosis, we divide them into different stages also. Investigation again is triple staging, the ultrasonogram, mammography, and FNAC to confirm the diagnosis. If needed, a core needle biopsy if there is a chance for malignant. Next. There may be a wide spectrum. Most of them are benign. 85% are benign. 15% may be largely aggressive, locally aggressive, or it can be a malignant form. So depending on the mitotic index and degree of pleomorphism, we divide them into, if it is benign, if it is less than 4 mitotic index, mitotic rate per hyperfield, 4 to 9 if it is borderline, and the malignant if it is more than 10 per hyperfield. Very rarely, if it is malignant, it may metastasize via the bloodstream also. Next. The treatment I already told, it's a wide local excision because the chances of recurrence is very high. We better give a good, if possible, to give clearance with a minimum of 2 centimeter with overlying skin and pectoralis muscle if needed, and we can do a reconstruction according to the need. But there may be some indications for mastectomy. We can use MRM as a thing, massive recurrence or malignant type. You need to go for a mastectomy if needed. If it is a malignant type, we may need to give a postoperative RT or chemo if needed. Next. Duct papilloma, which we usually encounter, it presents next. It usually presents as a discharge from the nipple. Next slide. Discharge from the nipple. It is usually within 1 centimeter. It can extend from the nipple up to 5 centimeter. Depending on the location, we can classify it as subareolar or peripheral like that. It can be. Usually if it is unilateral, rarely bilateral. Next. A bloodstained or serous sanguineous discharge will be there. And usually a pre-malignancy can be considered in a case of duct papilloma. The investigations are ductogram, mammogram, and MRI if needed, if you are suspecting something abnormal. The treatment is microductectomy with a tennis racket incision. We have to probe the duct already, and then with that probe, we inject a dye and then do a microductectomy. And then coming to the injuries, very rarely it is there. Hematoma turning into calcification and presenting as a mass. Next. Then traumatic macrophages, it may mimic a malignancy because it occurs due to a direct violence or indirect violence, and the ooze from the capillaries, they dissociate and make into fatty acids, over which calcification occurs and inflammatory reaction occurs, which makes them very hard in consistency and may mimic a malignancy. So it's one of the differential diagnoses we have to keep in mind. It's hard and non-tender, but it is non-progressive and non-recurrent. That's why you can differentiate from a malignancy. Skin tethering and nipple retraction may be also there like a malignancy, but it is not a progressive illness. Okay. So mammography if needed to rule out malignancy, and we can confirm by doing an FNAC itself. Surgical excision may be needed if it is huge and non-regressive. Next. Hematomas, madam has already told, it's not a very common disease. Very rarely it can present in as a fibroadenolipoma of the breast. Usually it is asymptomatic, no need to any treatment. But if it is big and if it is symptomatic, we may have to go for a surgical excision. So now coming to the cystic lesions. More solid lesions are very important for you. Cystic lesions for completion I'm including. It can be a simple breast cyst, a complex breast cyst, a galactosile, or fibrosis. This is the most common. Others are that. For you, this is enough. Next. Fluid containing cysts are called as fluid containing cavities, which are lined by epithelium in the breast. Usually that is diagnosed by, as usual, examination and ultrasonogram. If needed, we may have to go for a FNAC. Instead of that, we can even, if it is proved to be a simple cyst, we can aspirate and usually sometimes regresses. If there is a residual mass, even after aspiration or some solid component, it's a bloody discharge, then we may have to evaluate more. Next. What is complex breast cyst? Complex breast cyst is nothing but some solid component is there in the cyst wall. You call it as a complex breast cyst, which is more important compared to the simple breast cyst. Complex breast cyst needs more evaluation, and especially if it has a bloody aspirate, a residual mass is there or recurrence is there, we have to evaluate more. There may be chances of malignant component inside if it is a variable in nature in echogenicity also. Complicated breast cyst is nothing but if there is an infection occurring in a breast cyst, it is called as complicated breast cyst. It may need a course of antibiotics if needed. If it doesn't regress, we may have to evaluate more. Next. Galactosile. Nowadays, we don't see much, but very rarely we encounter. It is due to the obstruction of the ducts in the puerperium period. Within 6 weeks or so, it gets, if there's a block in the ducts, it appears as a mass, and it's due to inspissated and calcified and infected. It may lead to an abscess also, or it may remain as a antibiomol-like thing. We have to aspirate. Rarely we may need to go for an excision. Next. This is also fibrocystic disease. It is in the middle age group. There are some other synonym names are there. Next. The exact cause is due to changes in the hormones. It can be estrogen, progesterone, prolactin, or thyroid. All this plays a role in the development of it. Usually presents next. It usually presents as a nodularity or a mastalgia. People will come to us with severe pain, especially in the upper outer quadrant in the axillary talar veins with some nodularity because of the changes in or cystic lesions, some nodularity and pain they will come to. Next. Next. So it usually increases according to the age. In the premenopausal and perimenopausal, the incidence of fibrocystic disease is increased. It usually presents to us with a greenish discharge from the nipple. We commonly call it as fibrocystic disease, maybe one of the causes. Next. It's classified according to non-proliferative or proliferative with without atypia or proliferative with atypia. The most important is proliferative with atypia. It can be ductal. I already told this may the most important role. There's a chance for changing into a pre-malignancy, coming into malignancy. Next. The stages in the development of fibrocystic disease are stromal proliferation, adenosis, and cyst formation. Next. The treatment is medical. This is not actually very useful, but to reassure the patient and give some relief to the pain. Mastalgia can be relieved sometimes with all this evening primrose oil, vitamin E, tamoxifen, danazole, LHRS, agonist, and all. Some regression in the pain and nodularity may be there with the use of this. Next. Most important is reassurance and evaluation. Both are important. You have to evaluate if it is only fibrocystic disease, we can reassure them and ask them for lifestyle modification. If it is really alarming and the cyst is so big, we can go for an excision if needed. Next. Now coming to the inflammatory lesions. I'll just go. This is in young infants. Because of the accumulate changes in the hormones in the mother, there may be accumulation of some milk in the breast of the young ones, which people should not do anything. People sometimes may try to express and produce infection, and that is called witch mills. And if they try to express, it may lead to mastitis. The commonest cause next, Staphylococcus or Streptococcus may be the cause for it. This is in the adults appearing as mastitis. It can be a subareolar or intramammary or a retromammary. Retromammary commonly occurs in the tuberculosis of the breast. Clinical features, it appears as all signs of inflammation will be there, like tender, red, swollen. It can have prodromal symptoms like flu-like symptoms may be there. Ripple retraction may occur. Usually we treat them with the course of antibiotics, with compressions and breast support, analgesia to relieve the pain. They may, and if needed, if it is becoming an abscess, next slide. If it becomes an abscess, then we may have to interfere. Next. Next slide. It can be due to lactational period, it can be due to Staphylococcus or Streptococcus. In non-lactational, it can be bacteroids or anaerobic streptococci can play a role. Next. The clinical features, as I told already, localized inflammation and generalized prodromal symptoms. It appears. It can appear as a discharge or a nipple inversion also. We need a course of antibiotic. If they are not responding, repeated aspiration and support can help them. If they are not even responding to that, we may have to go for an incision and drainage. Next. Antibiotic, again, if you are giving antibiotics, sometimes the remnant may remain there, become calcified and present as a firm to hard nodule as an antibioma. Next. Tuberculosis is one of the important things we should have even anywhere in the body. Breast also it happens. It usually can be associated with pulmonary tuberculosis or cervical adenitis. It can present as a lump, which is ill-defined and irregular with discharge. It can have a sinus or a fistula. We treat with the anti-tuberculosis and we confirm the diagnosis and then treat with the anti-tuberculosis drugs. We may have to drain sometimes the cold abscess. Next, Monder's disease, it's given in the books. It is due to thrombophlebitis of the superficial veins of the breast. And when you raise the hands, it becomes more prominent and cord-like. Next. The picture depicting the Monder's disease. Next. It is usually due to lymphatic permeation and it may mimic the carcinoma of breast, but restriction of the arm movements and braziers may be needed to help them to relieve the pain, and refractory cases may very rarely need a surgical excision. Next. Ductectasia. This is more important. It is also called plasma cell mastitis. It is due to myoepithelial relaxation of the ducts, where the cells these squamated cells get accumulated and they may be present as a discharge. Next. So periductal mastitis can occur, fistula formation and abscess can occur, and chronic abscess, it can present as all these. It is commonly may be associated with smoking. This is a picture depicting the dilated duct which is clogged with the debris. Next. Usually greenish discharge may be there even in this periductal mastitis, slit-like retraction of the nipple, whereas in malignancy it is a circumferential retraction. Here it presents as a slit-like retraction. It can eventually become an abscess and fistula can occur. It's usually treated with antibiotics. If it is involving multiple, as a single duct, we said excision. If it is involving multiple ducts in the subaerial, we may have to go for a Hatfield's operation. Next. So these are the high-risk breast lesions. Proliferative disease without atypia, a complex fibroadenoma, papillomatosis, sclerosing lesions. Now we call it as a radial scar in the imaging, and proliferative breast disease with atypia is more important. Next. And this is benign breast disease are more common compared to the malignancy. 80% are only benign lesions, of which 30% may require evaluation and treatment. As I said, the presentation can be a lump, a discharge, or the screening is needed for it, and evaluation, triple assessment for any lesion. And some benign breast lesions can turn into malignancy, especially if it is associated with a abnormality in the imaging or histopathology or a family history. We need to be more vigilant and evaluate them more according to the need. Next.
Thanks to Professor Shanti for covering this topic.
Sir, I request the chairpersons to hand over the certificate to Dr. Shanti. Madam, take this. The last lecture in this session, the same chairpersons will continue. Dr. Sudipta Swain.
Thank you, sir. Good afternoon. We are running a bit late.
So I'll be speaking on carcinoma stomach, and for you, it actually I prepared for a little bit on postgraduate level, but be it postgraduate or undergraduate, the basics are same. So I'll be speaking on certain points which are relevant, important, and the controversies. The basic theory I won't be touching much. So how I present, like I'll be telling a case scenario, actually a real case, what we have done, an early carcinoma stomach and a late, like a advanced stage adenocarcinoma stomach. Next slide, please. So it is a common cancer, which more common in Asian countries like India. And we get at younger age group. Remember, Indian subcontinent and Asian people, the carcinoma stomach happens like 1 decade than the average age what happens in US or the Western countries. Multidisciplinary treatment approach. When you come to the treatment and management, remember, it is not just surgery. It is a multidisciplinary approach, including a gastroenterologist, a radiologist, a radiotherapist, a medical oncologist, and so on. So skills, everything has improved. The technology has improved. The approach to a carcinoma stomach also has changed over time. So this is a case one where a 42-year-old female housewife from Telangana with ECOG. Anybody knows what is ECOG? It is a performance status. So whenever you take a case, start presenting, like in this slide, the first line, the age of the patient, sex of the patient, what is the occupation, from where he has come, she has come, what is the performance status. All are relevant in a clinical practice and to plan for management. So, and then comes to the comorbid illness. This is the way we present in both specialty and in the postgraduate level. But at least it is same thing in your undergraduate level also. You should know what are the comorbid illness and what are the principal symptoms or the main symptom for which came is dog lacking upper abdominal pain for a short duration like 2 months. He never had history of recurrent abdominal pain or anything. No vomiting, early satiety. So whenever you get upper abdominal symptoms, the symptoms related to food, whether the pain is related to food or not, how it is relieved, what are the relieving factors, whether any other associated symptoms like vomiting, nausea, early satiety, fullness upper abdomen are associated with the presentation or not. Then the GI bleed, because be it a benign disease like a ulcer or a malignancy, there is a possibility that he may get or she might have got GI bleed. GI bleed can happen in 2 forms: vomiting of blood, that is called hematemesis, and passing blood in stool, which is called either hematochezia when it is frank blood, or altered blood, that is called melena. So this patient had melena, no vomiting, so no chance of hematemesis, and there is no relevant family history. Means whether any family member, be in maternal or paternal side, you have to mention to the patient, because whenever you say family, they always consider the paternal family. You also have to check whether any maternal side, because that is the genetic descent, whether any like cancer, it is not gastric cancer, other GI cancers like breast cancer, which are relevant to certain carcinoma syndromes, have to be asked and checked. Prior history, very important, whether he has undergone any surgery earlier. Next slide, please. So physical examination comes next. So pallor, which is very important, icterus, whether he has jaundice. Remember, when you are seeing a patient with icterus, avoid mentioning about pallor or no pallor, particularly in a deep jaundice, because it's very difficult to interpret. Lymphadenopathy, when you look into lymphadenopathy in a suspected carcinoma stomach or patient with upper GI symptoms, look into the peripheral lymph nodes like supraclavicular lymph nodes, the axillary lymph nodes. Then also look for any other, even the immunal, like a routine examination, you should look for the lymph nodes, and sometimes we get axillary lymph node in carcinoma stomach too. So coming to abdominal examination, you should see both in supine and standing, even in abdomen is not just hernia, because ascites is one, and a obese patient. When you have excessive fat in abdomen, and you want to exclude it from ascites, you have to see the standing position also. But most of the examination we complete in supine position. No distension, normal controlled abdomen, no palpable mass, organomegaly, and no free fluid. When you look for free fluid, it depends on the amount of free fluid what the patient has in abdomen. If the free fluid is minimal or like 200 or 300 ml, the examination is ausculto percussion, which is called pedal sign, or please go back. So, or you have to look for a shifting dullness where the fluid is significantly more than 500 ml. Digital rectal examination, do not forget in a suspected carcinoma stomach, you can get a Blumos cell, that is the drop metastasis into the pelvis, and other systems you have to mention. Patient laboratory investigation, I'll cut it short. It was normal, like both biochemical and hematological investigations were normal. Next slide, please. Next slide. Okay. So what is next? We have to confirm the diagnosis. Most of the carcinoma stomach patient may present with just dull-lacking abdominal pain, anemia, anorexia. This is the main group of patient will be presenting. So this patient has only presentation or the main complaint was dull-lacking upper abdominal pain with a short duration. So endoscopy reveals a small polypoid lesion at the mid-body of the stomach and antral gastritis, which is associated finding. Once you get a lesion in the stomach, you have to confirm the diagnosis with a biopsy. Biopsy came. So whenever you are describing a biopsy, you have to mention the differentiation also, which is important. I'll come into that why it is important. So it is a moderately differentiated adenocarcinoma. And next slide, please. Next slide. So management algorithm next comes. Once you know it is a moderately differentiated carcinoma, what is next? Your next plan will depend on the stage of the disease. So how to stage the disease? You have to do a radiological imaging. The image which is done for a carcinoma stomach is either a contrast enhanced CT scan of the abdomen or a PET CT, sometimes MRI. Then when to what? In your undergraduate level, it may be asked, or you may tell ultrasound of the abdomen, particularly in a condition like patient presents with ascites or known to have advanced disease, then only ultrasound is relevant. Otherwise, the investigation to stage the disease is always a contrast enhanced CT. If the patient has renal parameters abnormal or a chronic kidney disease, then you may opt for a MRI. PET CT is not routinely done for certain stages only. Next. So standard is contrast enhanced CT abdomen and chest, both IV contrast and oral contrast. The present oral contrast is a negative contrast either in the form of water or methyl cellulose. Next. The FDG PET CT, FDG is fluorodeoxyglucose, is for any patient. This is the present recommendation. Any patient with more than T2 or nodal disease has to undergo a PET CT, not routinely. Next. And like I told, when you differentiate, if you get a poorly differentiated tumor, you may have to do ISC. ISC means immunohistochemistry, because some of the poorly differentiated tumors are actually lymphomas or neuroendocrine tumors, which make 5% of the tumors other than adenocarcinoma. Next. So it was presented when you examine, there is a T1 lesion only, there are no nodes in the CT. What to do next? Next. So endo ultrasound, this is if it is a facility is available, you do an endo ultrasound whenever there is a T1 stage or T2 stage with no lymph nodes. We need to correctly whether that stage is T1 or T2, even T1, whether it is T1A or T1B. Next. So other use of endo, suppose you get a chance of somebody asks you do well in exam, they ask what are the other uses. The other uses, you can do FNA of the lymph node. You can aspirate the ascites, you can see the surrounding infiltration to the other organs. Next. So this is the workup of what we have discussed already, like when a patient you get in carcinoma stomach. What is new in this? Next. So new is the genetic testing. So there is a universal genetics testing is recommended for all carcinoma stomach who are presenting, that is MMR and MSI, and specifically at metastatic lesions, you have to do HER2 and PD-L1. Next. So multidisciplinary treatment, in brief, I'll do in 2 lines. Next, it should be a multidisciplinary means different departments allied to surgery, like a medical gastroenterologist, a radiologist, medical oncologist, a nurse, and a surgeon. Everybody should be there to discuss which way will be better to approach and manage the patient. Next. So every weekly or 2 weekly should be a MDT intensive. Next. So it, like I told, it forms a group of doctors. Next. Yeah, next. So this is the MDT which routinely happens in our weekly, like every Friday morning. Next. So this is the early gastric cancer, like T1 lesion, which endosono confirmed it to be T1A. So in early gastric cancer, what is early gastric cancer? Is actually a superficial gastric which involves mucosa and submucosa, irrelevant to lymph node metastasis. But it has been modified. I'll come into the next slide. So it is an intramucosal lesion, well differentiated type, which less than 2 centimeter. Like when you can do, what is EMR and ESD? EMR is endoscopic mucosal resection. ESD is endoscopic submucosal dissection. These are actually endoscopic methods to take out tumors which are T1 or early TB. Next, there is extended criteria. I'm not going into the details, but which can be treated with endoscopy, like EMR, endoscopic mucosal resection, and submucosal dissection. Next, this much is good enough. Why I told it has been modified. This is a definition which you are using from 1962, what has been told by Murakami and the Japanese Gastrointestinal Society, which has been modified in later in 2015. And it has been told that lesions which are limited to mucosa, even submucosa, minimally invasion to the submucosa, not the whole submucosa, that is up to 500 microns of the submucosa, and without lymph nodal metastasis, because the management is totally different when lymph node metastasis is there, when lymph node metastasis is not there. So we just knowing that early gastric cancer with lymph nodal metastasis, there is no meaning to it. Next. So what are the newer surgical options? The central gastrectomy, it is new. It is new to even the postgraduate people, and the local resection, sentinel lymph node biopsy. You just know what is, there is one term called sentinel lymph node biopsy, where endoscopic ICG green is injected to the tumor and the sentinel lymph node is taken along with the tumor. Next, surveillance after surgery, how you follow every 3 to 6 months for early gastric tumor, like routine examination and the physical findings. And you do endoscopy 6 monthly for a year, then yearly for 5 years. Next slide. Next. So this is another case scenario, like a 32-year female housewife from Bangladesh, good performance status, upper abdominal fullness, early satiety for 3 months, and melena for 2 days. That happened a month ago, and weight loss of 4 kg, 3 months. Weight loss is an important sign in advanced malignancy, and when you take weight loss, which is important, which is significant, 10% over 6 months or 5% over 3 months. So it is definitely more than 5% in 3 months. So it is a significant weight loss. Patient has no relevant family history. Hemoglobin is 9.3. So endoscopy shows a large growth in the proximal body of the stomach, what we can see, and moderately differentiated adenocarcinoma biopsy. Next. So here, this is a advanced lesion, significant lymph nodal metastasis expected, large lesion. So we went for PET CT, where you see a small, this is additional finding other than the CT finding what you got, like lymph nodal metastasis with large growth, a small nodule over the parietal wall. So that is why we do a PET CT. The difference between a CT and PET CT is mainly to stage the disease in the abdomen. PET CT is to stage whether the patient has any occult metastasis, like a smaller nodule anywhere in the peritoneum away from the regional nodes and the growth, or extra abdominal region, because that becomes an advanced stage. Patient has to be put in multidisciplinary treatment. It is not just surgery. This type of patient has to go through the chemotherapy, then surgery, rather than going through directly surgery. Sometime radiation, I'll tell where the radiation is important. Diagnostic and staging laparoscopy. Even this patient goes for chemotherapy, the patient has to go for a diagnostic laparoscopy because we have a suspected nodule. Even if the nodule is not there, in 20% or to 30% of patient, if you have a lesion which is more than T3 or nodal positive disease, you may get peritoneal nodules which are not in CT scan or in PET CT also. Even the PET CT is not the final thing to tell that there is no other peritoneal metastasis. You have to do a diagnostic laparoscopy before sending patient for chemotherapy. This is a standard protocol which need to be followed. Then what else you can do in diagnostic and staging? What are the things you see? Next. When and why? It is routinely done for any patient who have a T2 tumor or N+ tumors. Before sending for chemotherapy, biopsy of the metastatic lesions if possible. If you get lesions in a young fit patient like this, still we can treat the patient with curative intent, if provided that peritoneal nodules are limited. So that is how it is called PCI. Just know PCI means peritoneal carcinomatosis index, means the amount of peritoneal disease to be classified. Peritoneal was is a new thing where if the peritoneal was while doing a diagnostic laparoscopy becomes positive with cytology or cell block, then it is a advanced disease. It is a metastatic disease. Even though you are not getting anything in the peritoneum, neither by CT or any visible nodule in the diagnostic laparoscopy. Next. So this is the finding. Last T4A lesion. You have to remember a bit about T and N. T4A means the surface serosa is involved and the tumor is seen on the surface over the mid and proximal junction. Regional lymph nodes were seen. Few peritoneal nodules were seen and the peritoneal was negative. Next. Next. This is a standard protocol. Just remember the plot regimen. Plot regimen means 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel, which are given 4 cycles before surgery and 4 cycles after surgery. Perioperative chemotherapy as per the following the same similar to what we got in MAGIC trial. So this 4 cycles before, 4 cycles after. This much you remember. Plot regimen. Next. Next. So when you do radiation, radiation is given only when you have preoperatively, when the patient is unfit for surgery, or you have a very high grade lesion with significant lymph nodal border. Or next, post surgery. Next. Post surgery when you have a microscopic margin positive or you couldn't take out the whole tumor. Next. So whenever you do a neoadjuvant like 4 cycles of chemotherapy, then you have to follow it with either CT or PET CT. It's not mandatory to have a PET CT after doing a neoadjuvant therapy. But if you're doing a CT, CT includes chest, abdomen, and pelvis. Tumor marker in stomach, there are no specific tumor markers. But if somebody asks in examination, CA 125, CA 19, and CEA, these are the things which is done in carcinoma stomach, but these are very, very non-specific tumor markers for stomach. 3 to 6 weeks waiting time before surgery. Next. Principles of surgery, like these few lines are very important. Remember, diagnostic laparoscopy, either by then you follow it by the with laparoscopic surgery or open surgery. Both are similar. Laparoscopy has early recovery, short hospital stay, less bloodless, but the outcome is same. R0 resection, remember 2 words, R0, R1 and R2. R0 is when you are microscopically cleared. R1 is microscopically positive. R2 is when macroscopically you are leaving the tumor. So 16 nodes minimum to be taken. Routine splenectomy is not done. Palliative gastrectomy, the term somebody may ask, what is palliative gastrectomy? Palliative gastrectomy, you know the disease is advanced. You are not operating on a curative intent, but you are taking out the stomach with the tumor. This is done only in a specific condition called uncontrolled bleeding. Not just bleeding. If the hemoglobin of 9.3 is not a candidate for palliative gastrectomy, mentioning that it is anemic and bleeding. Uncontrolled bleeding is the only indication for palliative gastrectomy, nothing else. Even for obstruction, we can do a stent and relieve it, and palliative gastrectomy is not necessary. FGA for total gastrectomy, and minimal invasive approach. Laparoscopy is not meant for high grade tumors. Next.
Sir.
Next.
Sir, thank you for your nice presentation, sir. Thank you.
Okay, I'll just finish last slide, sir, in 2 minutes.
Okay.
Go back next. Next. So this, go back. Lymphadenectomy, just this is the reconstruction. Just look at it like how you reconstruct with a D2 like a distal gastrectomy or a subtotal gastrectomy and a total gastrectomy. Next. Go into the slides fast. Go fast. The last summary you bring. I am not going into do this discussion. Just summary. Go back. So a multidisciplinary approach for all gastric cancer treatment. Selected early gastric cancer can be treated with like endoscopic treatment. Just remember that. D2 gastrectomy or a lymph nodal dissection where you have to take 16 nodes and certain stations are important. D3 dissection only for specific. Just know this, what is D2 and D3, that is good enough for you. Vasectomy or romentectomy is done for T4A tumors, not for all. And multi-organ dissection can be done in carcinoma stomach. Just remember cytoreductive surgery and HIPEC are one term which is used for patient who has limited metastasis. Thank you.
Thank you, sir, for your excellent lecture.
I request the chairpersons to hand over the certificate to Dr. Swain. And request Dr. Kuberan to give the certificate to Dr. Sengotoan. We start with the long case on multinodular goiter, which will be convener will be Dr. Sai Krishna Vittal, and the examiners will be Dr. P. S. Sarvanan from Meenakshi Medical College, Dr. Anandi from Stanley Medical College, and Dr. Marudha Pandian from Madurai, our EC member of the National ASI. Come. The presenters are from Chengalpet Medical College.
Good morning, everyone.
Kindly introduce yourself, ma. You are from Chengalpet Medical College, is it?
Shruti. I'm Sonali, sir. We are
Okay.
final year MBBS students.
Final year.
Yes.
Okay then.
Next. A 19-year-old female patient, Mrs. Karanya, coming from Chengalpattu with the chief complaint of swelling in front of the neck for past 8 months. History of presenting illness. Patient was apparently normal 8 months back after she noticed a swelling in front of the neck, mostly on the left side, which was insidious in onset, progressively increasing size and resulting in the current size. No issue of pain over the swelling, or no issue of pressure symptoms like change in voice, difficulty in breathing, difficulty in swallowing, or cough or stridor. No issue of hyper or hyperthyroidism, and no issue of any malignancy features like bone pain, headache, or hemoptysis, or no issue of fever. And comorbid history, no issue of any comorbid illness. Past history, no issue of any previous surgery or medical illness in the past. No issue of irradiation to neck in childhood. No issue of allergy. Menstrual history, attained menarche at 13 years of age. Regular cycles for every 20 days. It lasts for 4 days. Last menstrual period was 5/1/2023. Family history, no issue of thyroid disease or malignancy in the family. Personal history, consumes mixed diet. No issue of consumption of alcohol, tobacco in any form. Normal bowel and bladder habits and normal sleep pattern. Summary, a 19-year-old female patient, Mrs. Saranya, coming from Chengalpattu, came with complaint of swelling in front of the neck on left side for past 8 months with no issues suggestive of hypo or hyperthyroidism, malignancy or any pressure symptoms. It's a case of thyroid swelling for further evaluation.
Okay.
Ask the examiner to ask some query.
So you said there is no issue of pain in the swelling. When do you have painful thyroid swelling or
Sir.
pain in thyroid diseases?
Sir, in thyroiditis or in any hemorrhage and anaplastic carcinoma, which is infiltrating the nerve.
What is more common?
More common is thyroiditis. Thyroid.
Thyroiditis is more common. Anaplastic carcinoma is very rare. So I don't think you should unnecessarily commit. Colleague?
You said no issue of any dyspnea, dysphagia and all. When do you have dyspnea in thyroid problem?
Sir, we can have dyspnea in long-standing multinodular goiter or in secondary thyrotoxicosis when cardio features are involved, or in retrosternal goiter we can have dyspnea, or any carcinoma which is infiltrating trachea we can have dyspnea.
Good, excellent. Nice answer. You said exposure to radiation will precipitate what type of malignancy in thyroid?
Papillary carcinoma,
Long-standing MNG?
follicular carcinoma.
Sure.
Yes, sir.
Long-standing Hashimoto's thyroiditis?
It can transform into lymphomas or papillary carcinoma.
Good. Go ahead.
What is the significance of family history?
Ma'am, family history for medullary carcinoma, we are asking family history.
Apart from that?
Ma'am, any other like pancreatic carcinomas and
As a
other
part of?
gastric
As a part of multiple endocrine?
I think you answered very well to all the questions, tricky questions posed by our colleague examiners. Please carry on. I don't think we have much time.
Yes. General examination. The patient was conscious and oriented, moderately built and nourished. There was a hair febrile. Hydration is adequate. There is no pallor, icterus, cyanosis, pedal anymore, generalized lymphodenopathy. Vitals. BP is 110 by 70 mm of mercury in right arm in sitting position. Pulse rate is 82 per minute. A normal volume, regular rhythm. No radio or radiofemoral delay. Respiratory rate is 14 per minute. Temperature is normal. Local examination of the neck.
What is
After
the
obtaining informed consent, exposed from Zipiston.
What are the methods to examine the thyroid? No, you told the local examination. No. In this case, what are the method you want to go for examination?
Sir, we can do Leahy's method, sir.
Okay.
In which we have to, if you want to palpate the right lobe, we have to press over the with the right hand with the opposite side and palpate the opposite lobes.
What other methods?
Pemberton's method has been used, sir. This method is used in case of retrosternal goiter, where the patient is asked to raise both of his hands close to his ears. And if there is any cyanosis over the face, it's Pemberton's method.
One of the most important things to remember when you're doing examination of the thyroid is you have to examine from the front and from behind. That examination from behind is a very important component. That is something which you should bear in mind. Okay. You mentioned something about Pemberton. What did you say? What happens when you raise your arms?
When raise arms, like face, we can note cyanosis.
Why should you get cyanosis?
Dilatation of veins.
Why should you get dilatation of the veins?
Because there is compression over the SVC, sir.
SVC. So what happens because of that?
Because of that dilatation of the veins and congestion occurs.
So what happens when you raise your arms, a large retrosternal goiter may narrow the thoracic inlet, you are right, compression of SVC, but the more important thing is it obstruct the venous drainage from the head and neck. So you will have facial congestion, redness, and cyanosis. Okay, carry on.
Local examination of the neck. After obtained informed consent, exposed from symphysis mentum to infraclavicular region and patient examined.
Can we have the slide back? Go back, please. Yeah.
Inspection, a single swelling of size 3 × 2 centimeters seen in front of neck, which is slightly to left of midline, hemispherical in shape, surface appears normal, skin over the swelling appears normal, extent of swelling 1 centimeter below upper border of the thyroid cartilage, 2 centimeter above sternal notch, and 0.5 centimeter to left of midline up to anterior border of sternocleidomastoid. Swelling moves with deglutition, does not move with protrusion of tongue. Lower border of the swelling is visible. Trachea appears to be in midline. No visible pulsation, no scars or sinus noted, no dilated veins noted. On palpation, no warmth or no tenderness. A single swelling of size 3 × 2 centimeter in front of the neck in left lobe of thyroid with multiple nodule is palpable. Surface of swelling is bosulated, firm in consistency, margins are regular and well defined. Inspectory findings on the extent of the swelling is confirmed. Next slide. Lower border of the swelling is palpable. Trachea confirmed to be in midline. Skin over the swelling is normal. No palpable thrill. No cervical lymphadenopathy. Carotid pulsation is felt. Percussion. No retrosternal dullness. Auscultation. No bruit. Next slide.
One moment. I think my colleague wants to ask something.
Yes. You said the multiple nodules confined to one lobe or involving both lobes?
Confined to one lobe.
So right lobe is normal.
Yes, sir.
Normally thyroid will be palpable or not?
Not palpable, sir.
Yes. But there are no nodules in the right lobe. All nodules are confined to left lobe alone.
You are able to palpate the right lobe.
No, ma'am.
So only the left lobe you are palpating with the multiple nodules.
Yes, ma'am.
Okay. What was the consistency of the nodule? You have not mentioned.
Consistent,
Firm.
firm and consistent.
All the nodules are firm.
Yes, ma'am.
Okay.
You said on percussion retrosternal region.
Yes, ma'am.
Why should you percuss?
So retrosternal goiter maybe.
In this case, you have mentioned it is 2 centimeter above the supraclavicular.
Yes, sir. Sir.
Lower border is well seen.
Yes, sir.
Then how?
Sir, in case of primary cases, there might be ectopic thyroid might be present.
Ectopic thyroid. Apart from this thyroid.
Can you diagnose ectopic thyroid with clinical examination? Can you diagnose ectopic thyroid by clinical examination and percussion? You must be a genius if you had to do it. You mentioned about carotid pulsation felt. It's also felt in me. It's also felt in him. What do you understand or what are you?
Common carotid.
Sure.
Yes, sir.
Always remember, any artery anywhere in the body, if you want to, you always palpate against a bone, whether it's popliteal or thing. Remember that. You can only palpate a vessel against a bone. Okay.
So in this case, I don't think percussion to find out the retrosternal extension. Since you have mentioned it is 2 centimeter above the suprasternal notch.
You said the swelling is moving with deglutition. Why does it move?
Because thyroid gland is enclosed by pretracheal fascia. and the pretracheal fascia is attached to the hyoid bone. And the posterior condensation of pretracheal fascia is a Berry's ligament, which is attached to the cricoid cartilage. During swallowing, the inferior constrictor muscle, namely thyropharyngeus and cricopharyngeus, have been attached to the cricoid and thyroid cartilage, so it moves with deglutition.
That is one reason.
And isthmus is also attached to the tracheal rings directly, so that is the one.
This is what we said last week in your college, you know.
Go ahead.
Next.
What are the other swellings which will move with deglutition?
Thyroglossal cyst, subaortic bursitis, pretracheal lymph nodes.
Anything,
Pleuritic
yeah,
lymph nodes.
anything which is enclosed
Enclosed
within the
pretracheal
pretracheal fascia will lymph node. So thyroid swelling, thyroglossal cyst, dermoid within the pretracheal fascia, lymph node. Remember all that. Okay.
Having mentioned thyroglossal cyst, what is the commonest location of thyroglossal cyst? Midline or right?
Infrared position is the most.
Left or right or
Right
center.
or left?
We are not talking politics here.
Left side.
Yes, exactly. Go ahead.
You mentioned about something about Bruvi. What is the significance in auscultation?
Bruvi, it is like if there is any
Speak in the mic, please, for the benefit of all of us.
Is auscultatory finding to find whether the vessel is flowing through a narrow
No, and
vessel.
I didn't ask the definition of a Bruvi. I asked what is the significance of saying no Bruvi. Okay.
Vascularity.
In this patient, in this case, why?
It's a thyrotoxicosis is present.
Yes. So where will you see?
In the upper pole of the thyroid.
Why will you see in the upper pole?
Sir, because of superior thyroid vessel.
Yes, the superior thyroid artery carries the bulk of the flow. It's a continuation, direct branch of the carotid artery. So in hyperthyroidism, thyroid toxicosis, there may be increased flow. You may hear a Bruvi. Okay, this is the answer. Okay, go ahead.
there is no eye sign suggestive of thyrotoxicosis, spine normal, cranium is normal, systemic examination, CVS S1 S2 heard, no murmur, RS normal vesicular breath sounds, no added sounds, abdomen soft and non-tender, CNS, no focal neurological deficit. Diagnosis. It is a case of multinodular goiter of left lobe of thyroid, clinically in euthyroid state for further evaluation.
I will stop clinically in use thyroid. I won't say for further evaluation. That is understood. Any question?
Non-malignant. You can add non-malignant also.
No.
What are the features to say it is not a malignant one? I am
Sir.
saying it is malignant.
Why do you say this patient is not?
Sir, I will start from history. There is no history suggestive of any malignancy features. And
What is the history suggestive of malignancy features?
sir,
In-
no, no issue of loss of weight or loss of appetite. No issue
that,
of
that can come even in loss of weight can come in toxic features. So that's not history suggestive of malignancy.
no issue of bone pain. No issue of headache. No
Headache. Why headache in malignancy?
Sir,
I think that's wrong. Don't say for history suggested other things.
no issue of any palpable neck.
No rapid increase in size.
Ah.
No pressure symptoms like dysphagia, dyspnea. On examination, firm in consistency. Intrinsic mobility freely possible. Carotid is equally felt on both sides. No cervical lymph nodes palpable. These are the findings to say that it is not a.
Not headache. Okay. Don't
Right.
give us headache, please.
Okay, how do you want to proceed in this patient?
Ma'am,
Investigations have to be.
Yeah.
Uh,
Which is the first investigation you like to do?
thyroid function test,
Okay.
followed by ultrasound,
Among the thyroid function tests, which is the most significant one you are going to choose?
TSH level.
What is the normal TSH level?
0.3 to
3.3. Come out with the units,
international units per ml.
milli international units. Okay, right, TSH is done, TSH is normal. Now what are you going to do?
Ma'am, 3 diagnoses, anatomical diagnosis, physiological diagnosis, and pathological diagnosis.
Okay. Okay.
So
Ah.
thyroid function test followed by USG neck,
Ah.
and we'll do FNAC.
What are the findings? You will get it in ultrasound thyroid.
Sir, in ultrasound, we can know it is whether it is a benign or malignant lesion, we can differentiate, sir. Like it is solid or cystic, echogenicity, any it is taller or wider or taller, vascularity can be seen, any calcifications, margins, site and size can be assessed.
So the exact anatomical extent you can identify. Those nodules which are not palpable in the opposite lobe. You said the right lobe is normal. If there are any nodules in the opposite lobe that can be picked up by doing an ultrasound, there are some features of malignancy which can be detected. And then lastly, any nodes, if at all there, that can be picked up. And ultrasound guided biopsy sometimes may be done with the use of ultrasound, right?
Just to complete, nowadays there's a standardized method of reporting ultrasound of the neck. It's called the thyroid system. Thyroid, just like BIRADS for mammography, you have the thyroid system where you have 1, 2. 1 is definitely benign, 2 is not suspicious, 3 mild suspicious, 4 moderately, 5 highly suspicious. Okay, this is how you grade. I have been told by the organizers that we need to wind up soon. You have done ultrasound. That it says this is the only nodule, no other nodules elsewhere. It's a solid swelling, no cervical lymphadenopathy, nothing suspicious in the ultrasound. What will you do next?
FNAC will.
FNAC. How will you do that? Have you ever seen that FNAC being done? No. So tell me.
24 gauge needle is taken, sir. And with the
Under what anesthesia, ma? Under what anesthesia?
local anesthesia.
This is falling into the trap. Okay. FNAC is usually done without anesthesia. No anesthesia is going to be given. Okay. That's the reason why you use a fine needle.
Okay.
Okay. When you're going to do a biopsy anywhere else, like a true cut biopsy, you require a local anesthesia, right? What are the things which cannot be diagnosed with an FNAC in thyroid disease?
Follicular carcinoma and follicular adenoma cannot be.
So what is required?
Frozen section has been required.
Okay. Okay. Having diagnosed a multinodular, it's a nodular goiter. Now what are you going to do?
Huh?
What are you going to do for this patient?
We can do surgery, ma'am.
What surgery? Gastrectomy?
So it's a total thyroidectomy.
Why total thyroidectomy?
Because of recurrence is more. So. And it can also involve the
Biopsy reported as benign pathology.
Yeah.
Confined to left lobe. Right lobe is absolutely normal. You want to have total thyroidectomy to be done.
hemithyroidectomy.
Why
can be
suddenly
done.
changing?
With the patient consent.
What is hemithyroidectomy?
Hemithyroidectomy involves removal of the one lobe with the isthmus.
That's all.
Yes.
And slice of opposite lobe also. Why should you remove the isthmus and slice of opposite lobe? Why should you remove the isthmus? The lesion is in the left lobe. You are doing removal of the left lobe. You said I will also remove isthmus. Why should you remove the isthmus? If you don't know, I will tell quickly. Yes or no? Two reasons. The isthmus and the opposite lobe junction, you call it as isthmocolumnar junction, which is the commonest site of adenoma formation. By knocking down the isthmus and the slice of opposite lobe, you are preventing the occurrence of adenoma formation. Number two, if you do lobectomy alone, leaving behind the isthmus, it will go for compensatory hypertrophy, which will give an unsightly appearance. For these two reasons, you should always remove the isthmus and slice of opposite lobe, right?
What will happen if you don't do a surgery in this patient? If you are going to leave alone? What are the problems your patient can go through?
It can progress into follicular carcinoma.
Okay. Very good. Then
And it can cause secondary thyrotoxicity.
any other problems can happen?
Pressure symptoms like dyspnea, long standing. It can.
After doing hemithyroidectomy, to which bucket you will dispose the specimen? Green, yellow, red?
Sir, yellow. Yellow, sir.
Yellow.
Anatomical way.
You like yellow? You?
Colorless.
Sir, we have to send for histopathology examination.
Exactly. Excellent answer. Give her a big round of applause.
Histopathological examination.
You should never dispose the specimen. It should be sent for biopsy again.
Not only for thyroid, for anything which you remove, should be sent for histopathology. I think we are running short of
Surprisingly reported as papillary carcinoma. What will happen?
We have to Total thyroidectomy, completion total thyroidectomy after 4
Yes.
weeks.
I think they have done reasonably well for undergrad.
If a total thyroidectomy has been done, how do you follow up the patient? What do you want to do? Let it be a benign one, a multinodular goiter. You have done a total thyroidectomy. Your patient comes after some days with the report saying that this has been done. Now, what are you going to give as a prescription?
An antibody has to be.
It's a benign. Huh?
Thyroxine levels can be assessed.
Why you want to estimate thyroxine level now? Okay. You've done the
Thyroid, if we done total thyroidectomy, then we can give thyroid supplementation.
thyroid supplement. When will you say it's supplement?
Ma'am,
When you have a inherent hormone which is going to be produced in your body, when you give an additional, you call it as a supplement. Here there is no gland. So what is it called as?
substitute.
Replacement or substitution. Okay.
Last question.
I think last question to Professor Marudhupandian.
What are the two important structures you will look into while doing thyroid surgery?
Parathyroid
Exactly.
One,
and
what now?
recurrent lension now.
Exactly.
If possible, extra, you can also mention external branch. But I have to say, you've done a wonderful job. Give them a big hand. Done very well.
I request Dr. Sai Krishna to give the certificate to the two presenters.
All of you come.
Yeah. And come. We welcome Dr. Balamurugan to the stage, and Dr. Balamurugan will be giving the certificate to the convener and the three examiners. Dr. Sai Vittal. Dr. Saravanan. Dr. Marudhupandian and Dr. Anandi. Okay. The next will be a lecture on hyperparathyroidism by Dr. Sai Krishna Vittal. I request Dr. Marudhupandian to continue in the chair. Dr. Balamurugan also. And Dr. Balamurugan also will be in the chair.
ரெண்டு மைக் கொடுத்தீங்க. Good afternoon all. I have been advised to rush up and be as brief as possible. So I'll just try to highlight some concepts. This is something you will not get in your clinical case. This is probably a question in your theory paper. It's always nice to know about parathyroidism. Next slide, please. Before I go any further, I'd like to express my gratitude to my father, Professor Vittal, who is not only my father, but my teacher, mentor, and guide. Next slide, please. Next slide, please. So what is the definition of hyperparathyroidism? All it means is there is increased synthesis and secretion of PTH, and the calcium levels can either be normal, low, or high, depending upon a variety of factors and renal function. Accordingly, they may be called primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. I am going to talk only about primary hyperparathyroidism today. Next slide, please. So what is primary hyperparathyroidism? Next slide. Next. Whenever the calcium level becomes high, like any other endocrine gland, there's a feedback inhibition. So when the calcium level becomes high, the PTH levels should normally be suppressed. But in primary hyperparathyroidism, there is inappropriate elevation of PTH in the presence of hypercalcemia. So the calcium becomes high. In spite of it, there's autonomous secretion of PTH, and that is primary hyperparathyroidism. Next one. So one of the things you have to rule out is hypocalciuria, because there's a condition called familial hypocalciuric hypercalcemia. I will not go into the details, but you have to rule out this condition because this is a benign condition and does not require further management. Next slide. Please remember, the commonest cause of hypercalcemia in an outpatient setting is primary hyperparathyroidism. And the commonest cause of hypercalcemia in a hospitalized patient is malignancy. This may be due to secondary bone deposit. This may be due to hematological malignancies like multiple myeloma, or this may be due to certain malignancies causing humoral secretion, paraneoplastic syndromes, releasing PTH-like substance and causing hypercalcemia. Next slide. So a few words about the surgical anatomy. The superior parathyroids are 2 in number. They arise from the 4th pharyngeal pouch. Next one, the inferior parathyroids along with the thymus arise from the 3rd pharyngeal pouch. Next, so normally you should have 4 parathyroids. In 5 or 10% of the patients, you may have more than 4 when they are called supernumerary parathyroids. Next one. In addition, not only you have extra glands, the glands may be found in ectopic situation. Roughly 10 to 15% of parathyroids may be ectopic in nature. Next slide. This is just to show a diagrammatic representation. This is the 3rd pouch from where the inferior parathyroid along with the thymus, and this is the 4th pouch where the superior parathyroid. Please note the inferior parathyroid traverse a longer distance, and therefore they are more likely to be ectopic in nature when compared to the superior parathyroid. Next slide. So pathologically, if you take primary hyperparathyroidism, next slide, can be adenoma, can be hyperplasia, or rarely carcinoma. Next slide. So adenomas, if you take, they constitute 80 to 85%. Usually it's a single adenoma. In 2 to 10% of the patients, you may have a double adenoma. Next slide. Diffuse hyperplasia. When you mean diffuse hyperplasia, you want to tell me that all 4 glands are involved, usually constitute 15% of all cases of primary hyperparathyroidism. 75% are sporadic, remaining 25% may be familial. You should rule out MEN syndromes when you're thinking in terms of familial variety. Next slide, please. Parathyroid carcinoma. Next slide. Is very, very rare. Usually constitute only 1% of the case. Next slide, please. Next one. Whenever there is a palpable neck swelling and hypercalcemia, think about the possibility of a parathyroid carcinoma. Next slide. So coming to the pathophysiology. Next slide. The PTH or parathormone acts on 3 target organs. Number 1, the bone. Number 2, the kidney. And number 3, the intestine. What does it do to the bone? It causes bone reabsorption, osteoclast activation, resorption of the bone, demineralization occurs, and therefore the calcium increases. What does it do to the kidney? It promotes the reabsorption of calcium in the kidney. What else does it do in the kidney? It activates the vitamin D. The 25 hydroxy vitamin D is activated to 125 vitamin D. And what does this 125 vitamin D3 do? It promotes absorption of calcium in the intestine. Because of all the, next slide, what happens? You get, next slide, you get hypercalcemia. And the calcium levels are so high that the calcium leaks into the urine. So you get hypercalciuria. Next slide. The PTH not only promotes reabsorption of calcium, it also inhibits the reabsorption of phosphate. So phosphate leaks into the urine, you get phosphaturia. Because phosphate leaks into the urine, the blood level of phosphate comes down and you have hypophosphatemia. Next slide. It also inhibits bicarbonate. So bicarbonate leaks into the urine. So what happens when you lose bicarb? You get acidosis. And Bicarb is a negatively charged ion. To maintain electrical neutrality, chloride is reabsorbed. So you get high chloride. So you get a condition called hyperchloremic acidosis. So these are the biochemical abnormalities seen in hyperparathyroidism. You don't need to memorize. I learned this 15 years ago and I have not forgotten, because once you understand, you don't need to memorize at all. It will be there for lifelong. Next slide. So when do you suspect primary hyperparathyroidism? Clinical presentation. Next slide. When you do a routine biochemical screening, the patient may be asymptomatic. You do routine biochemical screening, you may pick up a case of asymptomatic hyperparathyroidism. Next slide. Next slide. So what is the clinical presentation? I'll be very, very, it can act on the bone. What happens? You may have bone pain, you may have fractures. I'll explain a little later in the next slide. You may have nephrolithiasis or nephrocalcinosis. You may have pancreatitis or peptic ulcer, neuropsychiatric symptoms. Sometimes the patient may present with severe fatigue. Sometimes you may have pseudo-gout or hypertension. This is what you must have heard read in the Bailey and Love. It says patients with PHPT may have bones, stones, abdominal growth, psychic moans. In addition, I'll add fatigue overtones. Next slide, please. So how will you diagnose? Next slide, please. What are the investigations? The cornerstone in the diagnosis is PTH and serum calcium. You have increase in the PTH, increase in the serum calcium. The phosphate levels should be low. Sometimes they can be normal. Next slide. You will do a 24 hours urinary calcium or a calcium creatinine ratio to exclude familial hypocalciuric hypercalcemia. I don't think we need to elaborate further. Next slide. When you're suspecting bone disease, you do serum alkaline phosphatase. In the olden days, we used to do what is called a skeletal survey, because there used to be osteopenia, there used to be subperiosteal reabsorption of the bones. Nowadays, it is very convenient if you do a DEXA scan, that will pick up your osteopenia and osteoporosis. Next slide. This is a typical feature of what is called osteitis fibrosa cystica. So what happens when there's increased PTH? There is bone reabsorption. What happens because of the subperiosteal bone resorption? You get cystic spaces and there is some inflammation on the bone with fibrosis. This is what is called osteitis fibrosa cystica, otherwise called von Recklinghausen disease of the bone. Sometimes hemoserine pigments may be scattered, and that's why they are also called brown tumor. Next slide, please. These are other similar lesions in other patients. Next slide, please. This is a patient who had entire left side replaced. This patient had a left hemipelvectomy because of primary hyperparathyroidism. Next slide. So what is the management of PHPT? The management is, if you really want to cure the patient, it is surgical. So parathyroidectomy is the only curative treatment for primary hyperparathyroidism. Next slide. So I told you there are 4 glands. So you want to know which one of the 4, or whether it's one gland or multiple glands. And I told you 10 to 15%, you can have ectopic glands. And that is why nowadays it has become mandatory to do a localization study before you embark upon surgical intervention. Next slide. So what are the common tests you do? An ultrasound scan is a good tool. You can also pick up thyroid abnormalities. Next one, a sesame bee. What is sesame bee? What is the sesame bee compound? It is nothing but the cationic, lipophilic, isonitrile derivative. When you inject sesame bee IV, it is taken up both by the thyroid and parathyroid, but it's washed away early from the parathyroid. So if you take late images, it can pick up your parathyroid, especially your parathyroid adenoma. So if you look at the first picture above, it's taken after 20 minutes. Both the thyroid and parathyroid are highlighted. If you look at the picture down, only after 2 hours, it's only the parathyroid is highlighted. Next slide. A sesame bee is a functional scan. If you want more anatomy, you combine it with a SPECT scan, which is called a sesame bee SPECT CT. Next slide. These are the other localization tests you can use: CT scan, MRI, 4D CT and colon PET. You can read up in the books if you want to. Next slide. To quote Ralph Emerson, people see what they are prepared to see. As I told you, it is very difficult sometimes to identify parathyroid, and sometimes they can be ectopic. So you should be well armed, well prepared before you embark on surgical intervention. Next slide. So just to recap before intervention, the superior parathyroid, as I told you, arises from the fourth pharyngeal cord. They are more constant in position. If you take at the plane, if you take the plane of the superior parathyroid, they are posteriorly placed when compared to the recurrent laryngeal nerve. Next slide. Superior parathyroid, if you want to search for an ectopic superior parathyroid, you look in a posterior plane. It might be behind the esophagus, beside the tracheoesophageal groove, or in the posterior mediastinum. Next slide. Inferior parathyroids arise from the third pouch along with the thymus. Because they traverse a longer distance, they are more likely to be variable. Usually, if you look at the plane of the recurrent laryngeal nerve, they are ventral. This is what I wanted to say here. This is the recurrent laryngeal nerve. The inferior parathyroid is ventral or anterior, and the superior parathyroid is posterior to the recurrent laryngeal nerve. Next slide. When you want to search for ectopic inferior parathyroid, you search for it in the anterior plane. If it's not present in the normal side, look for it in the thymus, thyrothymic ligament, anterior mediastinum. These are the normal places. Sometimes it may not descend and may even be found at the level of the hyoid bone. Next slide. This is to show you a ectopic inferior parathyroid, which we operated a year ago. It was found in the chest anterior to the ascending aorta. Next slide. This is the same patient, seminary SPECT CT. Next slide. This is what we operated a few months ago, where the parathyroid was found in the superior mediastinum. Next slide. To quote Edward Churchill, a famous American surgeon of the 1930s, what did he say? The success of parathyroid surgery must lie in the ability of the surgeon to know a parathyroid gland when he saw it. So you should know how a parathyroid looks like. To know the distribution of the gland, which means you should know what are the ectopic sites, where they hide, and also be delicate enough in technique to be able to use this knowledge. He mentioned this nearly a century ago, and what he has told then is still valid now. Next slide. So before I end, what are the surgical options? One, you can do what is called bilateral neck exploration. Otherwise, you can do what is called focus approach. Next slide. So what is bilateral or the standard 4-gland exploration? You open the neck, you retract the thyroid, you have a look at all the 4 parathyroids and remove what you think is the abnormal one. Next one. These are some images with a large left inferior parathyroid adenoma, the right one. Next one. Next slide. What is focused parathyroidectomy? If you go back a few slides before, I said pathologically around 85% of primary hyperparathyroidism may be due to a single gland. Nowadays, we have preoperative localization tests to identify the single gland. So there's a rationale why unnecessarily explore all 4 and risk damage to the recurrent laryngeal nerves or cause hypocalcemia. So there's a group which does what is called focused parathyroidectomy, where preoperatively you localize the gland and try to remove only that gland. Next slide, please. This is what I meant by focused parathyroidectomy. Next slide, please. So to recapitulate, next point, primary hyperparathyroidism is an inappropriate elevation of pH in the presence of hypercalcemia. Next point, you should rule out familial hypocalciuric hypercalcemia because this is a benign condition which doesn't need any management. Next, you should be aware of the biochemical abnormalities. Once you are aware of the biochemical abnormalities, it becomes easier to make a laboratory diagnosis of PHPT. Next slide. Of course, the cornerstone of diagnosis is increase in the PTH and increase in serum calcium. These are 2 important things. Next slide. Preoperative localization tests are the norm nowadays. The 2 common tests which you do are an ultrasound scan and a cystometry scan. Next slide. Surgery is the cornerstone of treatment. Next slide. And your options are bilateral neck exploration or standard four-gland exploration or focused parathyroidectomy. Thank you one and all for giving me a opportunity. Sorry, I had to run. Thank you.
So excellent presentation. Congratulations.
Okay, we move on to the next session as we exchange the pleasantries. Yes, sir, please. Sir, mic on ladka. Yes, sir.
See, one of my case had 206 PTH level, normal being 20. After localization, it was found to be the right inferior parathyroid adenoma. I did focused parathyroidectomy. Immediately next day, the parathormone level was too low than the normal. What happened to the other three glands? Why there is low value of parathyroid?
Can we have the next Meenakshi Medical College team?
What Professor Mardu Pandyan is trying to tell me is, why have you forgotten to tell this point? So, see, when one of the glands is hyperactive, it suppresses the remaining three glands. So when you remove this gland, there will be a transient phase of hypocalcemia because the other three glands take some time to start functioning. The way example I tell my patient is, when a rowdy comes into the road, all the other people go inside the room and lock their doors. Once the rowdy goes out, slowly they come out. Similarly, once you remove the rogue parathyroid, the remaining parathyroids start to function independently after 1 or 2 days. For a transient period, the PTH levels may drop, so the calcium level may drop. So you may have to give temporary calcium supplementation. Am I right, sir?
Thank you, sir. Thank you for bringing out this very important point. Now we move on to the next session. Can I have the honor of having Professor Vijayalakshmi ma'am from Stanley Medical College, Professor Malarvedi ma'am from Chengalpattu Medical College, Ramdas sir, Professor Ramdas sir from Chengalpattu Medical College, sir. Balamurugan sir, we request you to remain as the convener. Professor Saravanan sir from Meenakshi Medical College, please come up to the stage, sir. Thank you very much. Now we have the next clinical case presentation, short case. Candidates, please bear with us. It will be 15 minutes each. We move on to the carcinoma penis to be presented by students from Meenakshi Medical College. Thank you. Thank you. Thank you for cheering up. Then I recommend the ACS Medical College team to kindly upload the PowerPoint. ACS Medical College students, are you here? Yes, please come and load your PowerPoint for the next case. Come. Good luck to you.
Chandrasekhar, Chairman, last thyroid case, the session ends without a discussion of the management because of the lack of time. Can I go directly to management or can I go to clinical examination? So students are requested to present positive finding. What is your final diagnosis?
History and local examination.
Good afternoon, everyone. Next slide. A 65-year-old gentleman from rural Tamil Nadu who belongs to low socioeconomic status came with complaints of ulcer in tip of penis for the past 8 months. History of presenting illness. The patient was.
You need not present everything. You just say positive history, positive finding, and your diagnosis.
The ulcer. He noticed the ulcer on prepuce involving the glans penis. The ulcer was insidious in onset and gradually progressed to attend the present site. It is painless. It is associated with blood tinged, scanty, foul smelling distress.
You go to next slide. It is ulcer. Ulcer. Okay. Next.
He is unable to retract his foreskin. No other, there is no history of fever, burning, premature. No other significant positive effect. Next. And it's a known case of diabetes for the past 20 years and on regular medication.
Local examination.
Local exam.
Summary.
65-year-old, known diabetic and smoker for 20 years, complaint of ulcer. Tip of the penis for past 8 months and unable to retract foreskin for past 1 month. The ulcer was insidious onset and gradual progressive in size. It was associated with intermittent blood distant foul smelling discharge. There is no history suggestive of distant metastasis.
In summary, you mentioned no evidence of distal metastasis. What about your regional node?
So there was no regional node involvement, sir.
Okay, what is your diagnosis?
Sir, it is a carcinoma of penis of grade T1, N0 and M0, sir.
With the history, what is your diagnosis?
So just it is an ulcer, sir. Just
So
it is an ulcer.
Non-healing ulcer.
Yes, it is a non-healing ulcer, sir.
Did you think about malignancy?
Yes, sir. I thought, yes, ma'am. I thought about malignancy, ma'am.
What made you think it could be
Ma'am,
malignant?
first of all, age, which made me think about, ma'am. And there was a bloody discharge from, and there is a, first of all, it is a non-healing ulcer, ma'am. And there was also a history of diabetes, which may also lead to the balanopostasis and lead to the penile cancer, ma'am. And history of multiple sexual partner, which made me think of human papilloma virus and leading to cancer.
Pertaining to this case, you always tell about this patient.
So, and inability to retract the foreskin, ma'am.
So
phimosis.
Phimosis in an elderly with ulcer and foul smelling discharge, it should always ring in your mind. Okay, good. Then proceed. Proceed with the examination.
Local examination. So there is a single irregular shaped ulceroproliferative lesion involving the whole of the gland penis of size 3×3. The ulcer margin is irregular, the edge is everted, the floor of the ulcer is covered with the necrotic unhealthy granulation tissue, and the rest of the genitalia, it was normal. On palpation, the base was confirmed to be inturated, and local temperature was normal, and no inguinal lymph nodes were palpable.
What important point you have missed? The base of the growth is indurated. Where else will you check for induration? You have to tell up to the induration goes up to whether it extends to the shaft or not, because it decides the treatment.
Okay, next slide.
Digital rectal examination found to be normal, sir. Systemic examination, no abnormalities were detected.
So except for the penile ulceroproliferative growth, confined to the glands and then the extension?
Only the prepuce, ma'am, glands and prepuce.
Glands and prepuce. Stops short of the coronal sulcus.
Yes, ma'am. Not beyond that.
No induration or edema of the shaft.
No, ma'am.
Nowhere else you found any other lesion?
No, ma'am.
So what is your TNM staging or Jackson's? Which one you're going to tell?
Ma'am, Jackson's staging 1, ma'am, and TNM T1, N0 and M0, ma'am.
What are the lymph nodes you'll palpate?
Ma'am, superficial inguinal lymph nodes, ma'am, and iliac, external iliac lymph nodes, ma'am.
When do you get superficial? When do you get iliac? When do you expect the iliac nodes to be palpable in a CAPNS? Is it normally palpable?
No, ma'am, it is not normally palpable. T4.
So how is the progress from superficial?
Ma'am,
How does it go?
superficial, it goes into deep, then it goes into external iliac, internal iliac, obturator, then it goes.
So when the growth is beyond the glands and the prepuce, then when there's an extensive growth, you expect extensive lymph node enlargement.
You summarize your positive history, positive finding, then diagnosis. Summarize. just summarize.
What are the points in favor of your diagnosis?
Based on history, first of all, age more than 65 years, sir. And this is a non-healing ulceroproliferative lesion and foul-smelling discharge. And it was a blood-tinged discharge and inability to retract the foreskin, sir. And on the examination, it was a finding of malignant ulcer, like the margins were irregular and edges were raised and everted, and the base where it is inturated base, and it bleeds on touch also.
Very good.
Nodal examination. Note.
Nodal examination was done, sir, but it was not palpable.
For positive finding is approximately around 1 centimeter lesion in the glans penis without any nodal involvement. How to approach?
Sir, first of all, I will go with the edge wedge biopsy for confirmation, sir, for histopathology. Next, I will, if
The patient has got acquired phimosis. How will you do edge wedge biopsy?
You told
Inability to retract the prepuce, you have told. How will you do edge wedge biopsy when there is inability, when there is acquired phimosis?
in the presence of phimosis, how you inspect, examine the ulcer?
In other words, what is phimosis?
They'll do circumcision, then
What is phimosis?
inability to retract the prepuce of the foreskin.
Okay, so you're unable to retract, so you cannot completely see the growth.
Where is the ulcer? Is it in the superficial skin or in the glans penis?
In the glands.
Glans penis, how can you inspect? In the presence of phimosis, it won't see. How can you describe all the findings?
You can inspect the extent of the ulcer by doing dorsal slit examination. Inside, you slit the dorsal skin, thereby exposing the growth, right? Then only we can do edge wedge biopsy.
In the presence of phimosis, sometimes it is possible to retract. If it is retract, you can examine. Otherwise, you should do dorsal slit. What is dorsal slit means? Dividing of the superficial skin in the dorsum. Then only you have to examine the other details. First point you should know, in the presence of phimosis, we can't examine unless we do dorsal slit. So, okay, you have done dorsal slit, you examine whatever findings. How you will take biopsy?
From the
Where will you take the biopsy?
with the normal tissue and at the periphery with the normal tissue.
What is called name of the biopsy?
Wedge biopsy.
Wedge biopsy.
What is the next investigation you will do?
the next, if the lymph nodes were palpable, I would have gone for FNAC, sir. But
What about staging? Won't you stage your tumor?
yes, sir.
How will you do the staging of the tumor?
Ma'am, CT, MRI.
CT or MRI?
MRI, ma'am, MRI. MRI with contrast enhanced or with artificial erection with intracorporeal injection of prostaglandin E1, ma'am.
Why, doctor? It is a ulcer in the glans penis. You done dorsal slit, you examine inspection palpation. What additional information you will gain in the MRI?
We can see whether that Buck's fascia, if it is any breaches there or not, we can see, sir. And tunica albuginea, we can
The
see.
Buck's fascia only seen in the shaft of the penis, not in the glans. It is a superficial ulcer. You examined palpation and inspection. I think you won't get any additional point in MR. It is not involved the shaft. only confined to glans penis, no corona sulcus involvement. So MRI is, it will not give any additional point to you. Okay, if there is a suppose palpable lymph node, you will take FNAC. What is your interpretation? If it is positive, if it is negative?
Sir, if the FNAC is positive, I'll go for bilateral ilioinguinal block, sir.
You are taking FNAC from one side, suppose in right side. If it is positive, what is your interpretation?
What do you mean by?
What do you mean? If it is positive, what is your conclusion? What is interpretation?
It is metastasis to the ipsilateral lymph. It is metastasis to the ipsilateral lymph node.
It is nodal metastasis. What it indicates is carcinomatous cell spread from primary penile cancer to regional inguinal node. Okay, it is negative.
It is confined to penis or
It is positive, it indicates regional metastasis. If it is negative, what is your interpretation?
it didn't metastasize to the nodal.
If it is positive, it indicates nodal metastasis. If the FNAC is negative, what other things you can think of? Most commonly, it is due to infection. Okay, it is due to reactive lymphadenitis, right?
Another one point, oncological point I want to emphasize is, if it is positive, you have taken as positive. It is negative, it will not be negative. That means, if it is positive, you have taken as positive. Negative means there may be a positive or negative. Reason is, in cancer cell deposit in regional node is initially multifocal. If you prick a needle into the node, sometimes it may take cancerous cells in the focus. Sometimes if you inject in the non-focus normal tissue, it may come as negative. In simply, not only in CAPs, everywhere FNAC is positive, it concluded it is positive. Negative means not real negative.
What is the sentinel lymph node called as?
Cabana's lymph node, sir.
Where is it located?
Sir, it is present superior and medial to the junction of femoral vein and saphenous vein, sir.
What that group is called as what?
Placket group of lymph.
Superomedial group of lymph nodes, the node of Cabana.
Sentinel node concept, is it reliable in cancer penis? Now we are practicing sentinel node concept in cancer penis management.
No, sir, we have modified other two methods are available, sir.
A sentinel node concept is proven in cancer breast. We are taking it sentinel node in axilla. If it is positive, we will do axillary dissection, otherwise it will come out. That is practiced in cancer breast. In cancer penis, sentinel node concept is historical. Now we are not routinely doing. First point you should understand, it is a theoretical point. Practically, we are not doing sentinel node in cancer penis. Next question is, how can we assess the nodal involvement? We have to know whether regional node is involved or not. How can you assess? Sentinel node is not reliable. For FNAC also not reliable. First point you should understand, all palpable node are not metastatic. All metastatic node are not palpable. So once palpable, you will take FNAC. In FNAC, it is positive. You will take as positive, negative, it is meaningless. So FNAC not useful. Sentinel node not useful. How can you assess or find out whether node is involved or not?
We can go for LNMRI, sir. Nanoparticle technology.
You don't go genetic level, basic clinical surgical practice. Right. Anywhere you treating oncology, what is primary surgery is treating the primary cancer as well as regional node. Regional dissection, you should not do unnecessarily unless node is involved. So cancer penis, primary lesion in the glans penis. We don't know regional node is involved or not. How can you correctly assess regional node is involved or not?
So that modified Catalonis technique.
What you say is partially correct.
Or contralateral, so I mean, superficial inguinal node dissection alone.
Yes. That is.
And we'll go for histopathological exam. Frozen biopsy we'll censor.
In anywhere in lymphatic area to find out whether involved or not, we will do selective dissection. That is called in inguinal area, superficial inguinal dissection is the selective lymph node dissection. Inguinal dissection is the superficial node as well as deep node. Ilioinguinal block dissection is superficial inguinal node, deep inguinal node, and pelvic node. So superficial inguinal dissection is the diagnostic as well as therapeutic. If it is positive, what will you do? Negative, what will you do? By process section.
If it is positive, I'll go for bilateral ilioinguinal node block dissection. So that is dressless classical method I'll go, sir.
No, doctor, if it is positive, first we will tell same side to complete with ilioinguinal block dissection. Opposite side, you need not do ilioinguinal block dissection. You will do trial superficial inguinal dissection only. Conclusion is one side is positive, you will do complete comprehensive ilioinguinal block dissection of the involved side. Opposite side, just superficial block dissection. Provided the regional node is within 6 months of the primary diagnosis. Suppose if you completed primary surgery, then late recurrence of the regional node, if it is more than 6 months, you need not do opposite side. How will you treat primary?
How will you treat the primary tumor, local tumor?
Sir, if it is confined only to the glands,
One single answer. For this case, what will you do?
sir, partial penectomy, sir. Penectomy, sir, penectomy.
What is partial penectomy?
The last information to do partial penectomy, how much it should be distance from the root of the penis? When will you do total penectomy? When will you do partial penectomy?
Sir, partial only up to distal shaft. If it is involved, we can go for a partial penectomy. If it is proximal, if it is corner, we'll go for total penectomy.
Distal proximal, how can you say? Size of the penis is individual instinct. It varies from individual to individual. How can you say?
A stump of how
While
much?
doing partial penectomy, we should leave at least 2 centimeter.
2
to
centimeter.
take with 2 centimeter of normal involvement. If the normal involvement leaves a comfortable amount of penis so that the patient can stand and urinate, we can do partial penectomy. If the
What is comfortable size of the penis?
the patient
That
can
is
stand.
not adequate stump. The stump should be minimum 2 centimeter. Aim of the amputated penis is two. One is sexual function, another one is voiding. For both purpose, it will get minimum 2 centimeter. Okay. For clinical examination, how can you assess? You will leave 2 centimeter. How many distance from the root of the penis to the proximal part of the ulcer?
2 centimeter.
No, doctor, you have to give clearance of 2 centimeter.
You have to give clearance of from the tumor 2 centimeter with 2 centimeter stump. So from the root of the penis, how much centimeter normal skin should be there? You can understand my question. You should excise the tumor with 2 centimeter margin.
Yes.
Tumor clearance 2 centimeter. And distal stump, how much centimeter? Stump
2 centimeter.
2 centimeter. So how much it should be there?
Not more, doctor. For cutting and suturing, you will take another 2 centimeter. So minimum 6 centimeter, if proximal edge is away from the root of the penis, 5 to 6 centimeter, you will select partial penectomy, otherwise you will give to total penectomy. Okay, time is delay, we completed. Congratulations for your percentage. Thank you.
But nowadays they say 2 centimeters, not strictly, you cannot give clearance. Clearance of 2
I
centimeters.
request Dr. Balamurgan to hand over the certificates to the presenters. And Dr. Balamurgan will also hand over the certificate to the other 2 examiners, Dr. Vijay Lakshmi and Dr. Ramdas.
Just for the students, one announcement. There will be a quiz program. Today we'll have the preliminary quiz. That means 10 candidates will be selected from the number of people who appear. And tomorrow will be the final rounds. Those who want to appear for the quiz, kindly give your names to the reception. So today is the preliminary round. Tomorrow is the final round. 10 candidates will be selected and the prize money is 10,000 rupees.
We'll have a short lunch break. Finish as quickly as possible within the next 15 to 20 minutes and come back.
Most of them already finished. Dear friends, hello. Those who finish your lunch, please come and get assembled. We'll start the next session in next 10 minutes. The first talk about the absurdity chant is by Raja Bhagan.
Okay. Sonali, yes, thank you, thank you.
Now we move on to the next session. Thyroid. The first one is the Vijay sir. Our connector. Medical College. I request Abraham sir and Sagaim sir also to come up to the stage, please. Share பண்ணுங்க.
Good afternoon, everybody. I thank ASI Chennai City Chapter for giving me an opportunity to talk on solitary nodule thyroid. Anatomically, the nodules and the thyroid diseases can be either it could be a solitary nodule, or if there is a generalized enlargement of gland, it could be a diffuse goiter, or if there are multiple nodules, then it could be a multinodular goiter. Our interest is, my topic of presentation today is going to be solitary nodule thyroid. Why you should have interest in solitary nodule thyroid? The chances of it being a neoplasm is much higher than in the case of diffuse goiter or in a multinodular goiter. That is why always clinicians and surgeons show interest on talking on solitary nodules, most often sick topic. What do you mean by definition of solitary nodule thyroid? Solitary, as it implies, it is single. Any nodule which is clinically single, you can call it as a discrete nodule. Clinically, it should be a discrete nodule.
But the common thing which we see is a dominant nodule. What do you mean by the literal definition? When it is a dominant nodule, what does it mean? There are nodules which are not showing up. What is our interest today is going to be the solitary nodule, discrete swelling in an otherwise impalpable gland. So the next one, which I said is a dominant nodule. My topic is going to be restricted to that. About 70% of the discrete swellings are clinically isolated and 30% are dominant. So next slide. Functionally, if you take a solitary nodule thyroid, it could be either euthyroid or it could be toxic. So by TFT can reveal that. Pathologically, you subject them to a fine needle aspiration cytology. This is going to be guiding us in management. It could be a colloid or it could be inflammatory thyroiditis. It could be a benign lesion or a malignant lesion. What decides the management is your FNAC. Whether going to leave it like that or are we going to, it's a crucial point, like anywhere. Pathology is the crucial point for a surgeon to take a decision. This is the crucial one. Why are diseases of thyroid more common in women? Women have physiological stress during menstruation, pregnancy, lactation, menarche. So the diseases are more common. And second thing, estrogen receptors are located in the thyroid follicular cells, which take them to make the woman more prone for thyroid disorders. And nodules which you see clinically could be colloid, which is not of much worry to us. Worry starts when it is cellular. Cellular, there is a very high chance of that lesion being a neoplasm. Next slide. Cystic degeneration, hemorrhage, and calcifications do occur. That is why a hard nodule in thyroid need not be malignant. As we always teach our students, any hard nodule could be malignant. It is not a case in thyroid because a tense cyst can be hard. Similarly, a calcified, degenerated nodule, which is gone for a dystrophic calcification, could be hard. History, what are the things you elicit? Just note this, but I generally teach my students in a way, you have a swelling in the region of thyroid. What is that you ask a patient in any swelling in general, more specially to thyroid? Suppose if you have got a nodule in thyroid, I just say them, what are the symptoms in relation to the swelling? Or in this case, goiter, locally. Then, what is its effect on the locoregional area? For example, the nearby organs are the muscles, trachea, vessels, nerves. So what is the effect of that particular swelling on the thyroid or the goiter on the locoregional area? And third, what is its systemic effects? What do you mean by that? You have a follicular carcinoma, it is producing a metastasis. You have a metastasis in the skull. So what is the systemic effects? You just look for systemic effects. And second, and the other thing is, thyroid being an endocrine organ, does it produce any functional disturbance? Hypothyroid, hyperthyroid. And do you have any clue to etiology? For example, thyroiditis can present as fever, or a recent increase in size could be a hemorrhage into an already existing goiter. So, in general, what are things you ask? Is it related to swelling? Is it related to locoregional effects of the goiter? Is it related to the systemic effects of the goiter? Is it related to the functional disturbance, hyperfunction or hyperfunction, or related to etiology? If you apply this principle to any swelling, you will be able to cleanly get into the history of present illness. So there are some relevance which you want to stress here is hoarseness, which is specific. If you have pain, which is to a certain extent moderate, could be due to thyroiditis, malignancy, more so in anaplastic. Pain is not a feature of differentiated cancer, could be due to lymphoma and anaplastic cancer, hemorrhage, and hoarseness. Recurrent angina involvement almost signifies malignancy. Dyspnea and choking, you have non-occlusive cough. There is a cough which is not producing an obstruction. What do you consider malignancy on history? Suppose you have a family history of cancer. You know that papillary cancers run in families, and you have your medullary carcinomas also can be genetic. So I don't want to get 15 minutes time. I cannot get into much details of history and exposure to irradiation. Anybody who is exposed either as a therapeutic reason or for diagnostic or high-end radiations can cause, repeated radiation can cause, more so if it happens in a younger age group. And most commonly, the patients are euthyroid in SNT. Next slide. Nodules, visible nodules should be large. Sometimes not visible. You can just go and palpate a nodule. Some nodules are palpable. Generally, they are smooth. Generally, if you palpate nodule in the other lobe, automatically it becomes a clinical multinodular goiter. And they move with deglutition, and consistency can depend upon the swelling in question, whether you have a calcified nodule or you have a malignancy. Don't have the idea that thyroid malignancy will be hard. Papillary carcinoma can present and exist for years without producing any problem. So you can have a postmortem diagnosis of papillary CA thyroid, patient would have died due to some other cause. And when you have a painful nodule which is rapidly enlarging, suspect hemorrhage into an already existing goiter. Pain is not a feature of differentiated thyroid cancer. It is a feature of anaplastic carcinoma which is infiltrating, or a malignancy which is converting it into anaplastic, infiltrating on other things. Next slide. So why should you worry about, SNT is a topic, why should I worry about? The chances of it being malignant is relatively high. How will you pick up such malignancy? When you suspect malignancy, when a SNT occurs in a person who is less than 15 years, generally malignancy is not common in children. There is an exception here. Thyroid malignancy is more common in children who are 15 years. SNT in a child, be careful. And anybody more than 40, 50 years of age, SNT, be careful. And the size is larger, again, be careful. And more common. Males, thyroid diseases are 3 times common in female. But whereas if a SNT occurs in a male, be doubly careful, especially if it is cellular, must be very, very careful. And radiation exposure, either as occupation or treatment, family history. And on this slide, nobody does a thyroid scan nowadays, especially for differentiating a functional status of a nodule in a toxic nodule, whether a nodule is hyperfunctioning or internodular tissue is hyperfunctioning. But this slide altered because not all cold nodules are malignant. Only 15 to 20% could be malignant. And also remember, at least 5% of the hot nodules are malignant. So you should be careful at both ends to make it perfect. It's more relevant to a postgraduate rather than an undergraduate. Next slide. This is the rule of 12. It's all given in Bailey and Love. I have just taken all these things from a standard textbook, Bailey and Love. This states any isolated or a discrete swelling could be 24%, rule of 12, multiples of 12. This could be 24% solid, 12% cystic, and 48% in male and female. And similarly, this thing, I just go through that. I don't want to waste time. I want to get into the next slide. What are the investigations? Ask me if I sit in my clinic and somebody comes with a nodule in the thyroid, the first investigation anybody would do probably is ultrasound. Why? I want to fix whether I am dealing with a true solid nodule or I am dealing with the MNG, which is not clinically relevant, clinically palpable. So that will give you you can do malignant assessment on ultrasound, thyroid function tests, and circulating antibodies to fix thyroiditis. And FNAC and Bethesda classification, Bethesda grading will help you the decision on management. And CT scan is done only in patients who have large goiter when there is compression symptoms, lower limit is not seen. When you suspect malignancy by ultrasound, you just want to encasement of vessels you suspect or anaplastic carcinoma, you do a CT scan. Otherwise, routine CT scan is not indicated. Next. What are the ultrasound criteria? The slide orientation is not proper. Sorry for that. And when you have a lesion in ultrasound, which is taller than wider lesion, be careful. You have internal vascularity, be careful. Irregular margins or capsular affection, be careful. Hypoechoic nodule or heterogeneous hypoechoic nodule, or you have microcalcifications, which is less than 5 millimeter multiple. When you have and you have nodes in the neck, you be careful when you have got these ultrasound features, because 3% of the population has got thyroid swelling or goiter. If you suspect everybody into thyroidectomy, probably operating 3 to 4% of the population for a thyroid neoplasm, thyroid disease. So how you choose to operate? What are the indications? So you do ultrasound. Next, go for FNAC. FNAC is highly sensitive and specific. Everything is diagnosable except follicular neoplasm, which could be malignancy or benign, which is capsular and angio invasion. So that cannot be read by FNAC because FNAC is cytology. Their capsular and angio invasion requires histology, for which need to do a biopsy. And second thing, especially when you have ideally done an ultrasound guided FNAC, and as I said, FNAC cannot differentiate a follicular. You can't do open biopsy to diagnose. The biopsy minimum possible in thyroid is hemithyroidectomy. Next slide. This is the Bethesda grading system, which grades thyroid into Thai 1, 2, 3, 4, 5, and 6. Go from below. The sixth one is Thai 6 is your malignancy. All papillary, medullary, anaplastic, all these come under this. Thai 5 is suspicious of malignancy is Thai 5. Malignancy is suspicious of malignancy. Thai 4 is follicular neoplasm or suspicious. Thai 3 is atypia. Thai 2 is benign. So this system of grading helps us in management. I'll come to it on the next 2 slides. Next slide. And this is thyroid imaging and reporting data system. This helps like what you have done. Originally, it was run for BIRADS, all of you know, breast imaging, reading that reporting system, report and the same grade we are doing on thyroid also. This helps us to grade thyroid on the basis of image. And then combined with Bethesda, you are able to save a lot of patients with thyroidectomies, otherwise not warranted. Next slide. So this is based on this, I have told you, this is Bethesda. When you have done a solid nodule thyroid, you have done a FNAC. The FNAC report comes as malignant, straight away you are going to forget this near total thyroidectomy. When it comes as suspicious of malignancy, even in our setup, we have to do only total thyroidectomy. There is one question, can we do a frozen section if facilities are available? Yes, but frozen section itself is not that very useful according to studies. So people don't rely on frozen section and do nowadays, and majority are done only. Total thyroidectomy instead is better. When you suspect follicular neoplasm or suspicious, you can do hemithyroidectomy. That is also majority of the surgeons, especially we practice in a suburban or a rural setup, it is difficult. And the benign, you take it straight away into, suppose if it comes as benign, cyst you aspirate. If you reaccumulates, you repeat that and you can go. Any cyst which reaccumulates repeatedly, you need to be careful with that. You may have to do surgery. Similarly, colloid nodule, majority of the time, if a pathologist gives it as colloid nodule, you may not have to do surgery on those patients, and reassure them and observe. When it is non-diagnostic, you just straight away observe these patients. The message is do ultrasound, look for signs of ominous signs on ultrasound. If they are not there, the size list, observe, ask the patient to come three months later, interval ultrasound, and you have a suspicion, you can subject them to straight away FNAC. In foreign countries, they don't subject the patient straight away to FNAC. Ultrasound kinds are stronger, but in our setup, we always do FNAC to safeguard ourselves. And then on the basis of FNAC, you decide, except for follicular neoplasm, you may have to do a hemithyroidectomy to conclude. Next slide. So, and this is, I've taken this from Bailey and Love because no book can give you better than Bailey and Love. My teachers have taught me what are the indications for thyroid. They used to say 3CT. What are the 3C stands for? One stands for cosmesis, another stands for compression, third stands for carcinoma, and the fourth stands for toxicity. So triple CT is easy way to remember. Any thyroid the patient wants for cosmesis, do it. Patient has got compression, do a thyroidectomy. The patient has got a carcinoma by FNAC, do it. Or if you have a toxic feature, do it. Patient's wishes. Sometimes you have a patient who is fearing, who would want to get thyroidectomy. You can't say because your FNAC is also not foolproof. So we can't be sure. They are very anxious, very, very rare. You can convince them if you are strong enough to have evidence. So FNAC positive, try 3 to 5. These are follicular neoplasms to malignancy, and your clinical suspicion is strong. The radiology in FNAC is not conclusive. Sometimes it may be indicated. There are some red flag sign. The age is very young or very old, be careful. Male sex with SND, be careful. hard texture to certain extent, not always, fixity to the surrounding structures. Any solid nodule with recurrent nerve palsy, again be careful. We are probably dealing with a case of malignancy. Lymph nodes could be lateral aberrant thyroid, as you know. Any cyst which is recurring after aspiration, probably these are indications for doing surgery. Next slide. And what is a surgery? The minimum surgery possible in thyroid is semithyroidectomy. The next surgery is total thyroidectomy. What is semithyroidectomy? As isthmus is always removed. So do a one lobe on isthmus is semithyroidectomy. The lobectomy, which is conventionally written in some of the textbooks, nothing other than a lobectomy, other than a semithyroidectomy. Nobody does one lobe and leave isthmus. So other one is isthmusectomy is done only in cases of compression in anaplastic cancer or sometimes lymphoma. You need to do a decompression, isthmusectomy done. Subtotal, better you forget. Sometimes we do incidentally subtotal. How? You have a lesion on one side, you go and operate that side along with the isthmus. On the other side, you have a thyroid, which is very closely, intimately related to recurrent nerve. You need to preserve some gland for the sake of preservation of parathyroid, which is very dangerous and very troublesome side effect of a thyroidectomy is hypoparathyroidism. Once you see a patient, lifelong, you will start shriveling because you don't want to produce hypoparathyroid. So for that reason, but better you say two things, either hemithyroidectomy or total thyroidectomy. Even our total thyroidectomies may land up as near total sometimes because of fear of saving nerves and parathyroids. The Dunhill procedure is one where you do total lobectomy on the involved side, isthmusectomy and subtotal lobectomy on the other side in an attempt to prevent hypoparathyroidism. Next. And all total and near total thyroidectomies require thyroid replacement therapy post-operatively. It is better to do total thyroidectomy. It is so difficult to re-enter the neck and do a repeat thyroid, which is not that easy. So it is better to do total thyroidectomy in young patients. Subtotal thyroidectomy again exposes the neck, recurrent exploration of increasing damage to recurrent laryngeal nerve and to parathyroids. It's better to do. So what we have evolved now is either to do a hemithyroidectomy, clean cut case, or it could be doing a total thyroidectomy. I think majority of teachers concur on that. Next. I think the time is short. I just need to speak only 15 minutes. Thank you. If you have any questions, I'm very happy to share it. Thanks a lot.
Thank you, sir. Sir, still in the exam, if the students commit lobectomy, will you accept, sir?
Sir, if a PG says that, I will accept and ask what are the reasons for him to do a lobectomy. Suppose if he says the thyroid nodule is less than 3 or 4 centimeters, the features are not against doing a conservation, we can still do, because the worst complication, as all of us know, in junior hands is probably recurrent nerve injury, superior nerve injury, and hypoparathyroidism. Provided you should be able to follow the patient for a long period of time. And that should be there. In that absence, in our setup, we are converting ourselves from lobectomy to total thyroidectomy, actually. That's why it's better to give clean message to undergraduates, either a hemithyroidectomy or a total thyroidectomy.
Instead of using lobectomy, they can commit it as hemithyroidectomy.
Hemithyroidectomy, it is better to forget the term lobectomy because you carry that one lobe is removed. Vittal sir used to say the minimum surgery in thyroid is hemithyroidectomy.
Yes, sir.
So the lobectomy is synonymous with hemithyroidectomy. It is not something.
Thank you, sir.
Thank you very much, sir. I request Professor Madhubandian, sir, to hand over certificate to Professor Arasu. I request Dr. Kannan, sir, to hand over certificate to Sagai Embusegar, sir, and Abraham, sir. The next topic is obstructive jaundice by Dr. Raja Mahendran. The panel. Theater. Theater.
May I call upon Dr. Rajamagendran?
சார் என்ன பண்ணணும் சார்? என்ன டாபிக்? சார் என்ன ஸ்டார்ட் பண்றோம் சார்? அப்செக்டிவ் ஜாண்டிஸ்.
May I call upon Dr. Rajamagendran? Is going to talk about obstructive jaundice.
Checking. Hello. So good evening all. I thank ASI for giving an opportunity to present the topic on obstructive jaundice. So for final years, if you get obstructive jaundice in exam, never hesitate to take it because it is the easiest case to pass. So I'm Dr. Rajamagendran, so author of Surgery Sixer and some books. So thank you all. So the best wishes from RRM Gastro and from my coaching institute. So let us start with the topic. It's a simple topic. If you understand the anatomy, all surgical topics, if you know the anatomy, it is nothing to worry. So surgical jaundice is nothing but obstruction anywhere along this pathway. Okay, anywhere along this pathway from common hepatic duct to ampulla, it is known as obstructive jaundice. Can you tell me the total length of bile duct? What is the total length of bile duct? Yes, bile duct length is 10 centimeter. Okay, and bile duct diameter is 6 millimeter. If the bile duct diameter becomes more than 6 millimeter, there is some obstruction along the pathway. So what are the common causes of obstruction? You all know. So congenital causes, inflammatory causes, all these are theory you can read. But for your exam, what are the cases that will be kept for your exam is a CBD stone with a non-cholangitic case can be kept for exam, and a distal CBD or a periampullary cancer can be kept. Hilar cholangiocarcinoma can be kept. Pancreatic head cancer can be kept. So your aim is to differentiate between these cancers. What are the clinical features? They come like that. So let me show you what are the features. Painful jaundice is characteristically seen in stone. So CBD stone can cause cholangitis. What are the features of Charcot striate? Can you tell me? Pain, jaundice, fever. So pain, jaundice, fever is a feature of cholangitis. So usually you won't get a CBD stone with a cholangitis. You will get a CBD stone without cholangitis can be kept in the exam. And painful progressive jaundice is seen in hilar cholangiocarcinoma. Pain with jaundice is seen in pancreatic head cancer patients will have back pain. And very important, the examiners will definitely ask you, when will you get painless intermittent jaundice? Painless intermittent jaundice is periampullary cancer. Because of the sloughing of the tumor, you get painless intermittent jaundice. So please don't forget to see all the clinical features of jaundice. You have to examine jaundice in the eyes, and you have to examine the jaundice in the undersurface of tongue. All the places you have to examine. Very important, you have to examine for the nails. What do you see in the nails in jaundice patient? Because of continuous scratching, because of the itching, they'll have a shiny nails. They'll have a shiny nails. They have scratch marks on the abdomen. All these are essential points you should not miss. So what you see in conjunctiva, oral cavity, nails, trunk, extremities, PR, you should look for clay color stools. So these are the places where you have to examine for jaundice. Because of tight schedule, I'm just pushing up some of the slides. So these are the features. What is this? It's very common. Most of the patients coming with obstructive jaundice to hospital will have some native treatment. These are all native treatment. Pseudo வைக்கிறது, நூல் கட்டுறது, நிறைய படத்தெல்லாம் காமிச்சிருப்பாங்க. So you would have seen so many points like this. All these features should be mentioned in presentation. You can see all these are our local patients who all got local treatment. They definitely give history of native treatment. And you can see this fellow is having dilated veins on the abdominal wall. So dilated veins is a feature of obstructive jaundice, as well as in normal medical jaundice also you get dilated veins due to obstruction of IVC. Okay, IVC obstruction, what syndrome? Budd-Chiari syndrome, IVC obstruction, hepatic vein thrombosis and all will have Budd-Chiari syndrome, ascites, all these features you have to examine. And you never forget to examine for left supraclavicular node in any obstructive jaundice, because usually for final year exams, they will give only malignant obstructive jaundice, because cholangitis, CBD stones and all will be very sick patients, so they won't keep for you. So please thorough with that and look for any scars in the abdomen. If there is a scar in the abdomen like cholecystectomy, what may be the cause of obstructive jaundice? Previously, there may be an injury of bile duct which has caused CBD stricture. So these are the various etiological factors you have to examine one by one. The only question the examiner will be expecting from you in obstructive jaundice cases to know about the gallbladder. About what law? Purvaisier law. If you are Purvaisier law sollitingna obstructive jaundice, you are passed. Purvaisier sollana, they will be in trouble. So Purvaisier law romba easy. Who will have enlarged gallbladder like this? Cancer or stone? Very simple. Cancerless gallbladder irukuma, stone gallbladder irukuma. In case of cancer, that is Purvaisier law. So please don't forget what is Purvaisier law. Please understand Purvaisier law. Let me explain you. So this is the bile duct, you know very well. This is bile duct. Bile duct, if getting obstructed by cancer in the periambulary region or in the distal bile duct, what will happen? The gallbladder, which is a normal gallbladder, will become enlarged like this because it is a normal gallbladder. So any cancer distally will cause enlargement of gallbladder. Any stone, where is the stone come from? Where is the stone coming from? It is from the gallbladder. So gallbladder already romba thickened eye, it will be cholecystic. So thickened gallbladder, even with obstruction, cannot enlarge. So if it is stone, gallbladder not enlarged. If it is cancer, gallbladder is enlarged. This is Purvaisier law. If it is due to stone, gallbladder cannot enlarge because it is already a thickened gallbladder, fibrosed gallbladder, so it cannot enlarge. So this is very important point. This is known as Purvaisier law. Exception to Purvaisier law kepanga. What is exception to Purvaisier law? Number one, in which cancer gallbladder will not be palpable? Cancer idukku mela irundhuna, above the cystic duct insertion over here. This is known as what cancer? Clad skin tumor. In clad skin tumor, gallbladder will not be palpable. Okay, so that is one exception. Another exception is two stone. One stone in the bile duct, another stone in the cystic duct. So double stones will have gallbladder palpable due to mucocele. Please don't forget that is known as mucocele. So very important for your exam about the Purvaisier law. Definitely they will be asking you. So please don't forget about the Purvaisier law. So the examination point, very important point is to look for gallbladder. Please remember, you should examine for gallbladder from the right iliac fossa. Don't go and keep your hands under the right hypochondrium because gallbladder will be very much enlarged. It will be palpable right from the right iliac fossa. You have to palpate for the gallbladder. This is the image showing you when you get gallbladder palpable, when you will not get gallbladder palpable. Don't forget this image. This is the image of Purvaisier law. So Purvaisier law is a high yield MCQ for your exam as well as for PG entrance exams. So this is a clay stool. Can anybody tell me what is the second stool in this picture? What is this stool? What is the name of this? This is clay color stool. That is Thomas sign. That is known as Thomas sign, in which the clay color stool mixes with the blood in periambulary cancer. This is known as Thomas sign. So Thomas sign na clay stool la blood mix aachina eppadi theriyum. That is known as Thomas sign. So the diagnosis is very simple. That's all. Obstructive jaundice case la ivlo da expect பண்ணுவாங்க. In the exam you can easily clear obstructive jaundice case. This is a case of obstructive jaundice. Site of obstruction probably at the below the level of cystic ducta or above the level of cystic ducta and solvom. Below the level of cystic duct means gallbladder will be enlarged. Above means it won't be enlarged in case of cancer. So they will be just beating around the same bush whether it is stone or cancer. Rendu question case the exam lepanga. Either it is due to stone or due to cancer. So please remember the 3 points. This is a case of obstructive jaundice. The site of obstruction probably at the level of hilum, at the level of mid CBD or lower CBD, like that you have to tell. And investigations will show elevation of direct bilirubin, alkaline phosphatase and prothrombin time, and INR will be elevated. And very important, you have to know about all the values of the LFT. Definitely will be asked in obstructive jaundice case. And ultrasound, what is this sign? Anybody? What is this picture showing you? In an ultrasound of a gallstone, what sign you are seeing there? What is this? Posterior acoustic shadow. Posterior acoustic shadow is a feature of gallstone. So the first done investigation in an obstructive jaundice is to look for posterior acoustic shadow from a gallstone. First point, don't forget this. But what is the gold standard investigation for obstructive jaundice? It is MRCP. Okay, not HIDA. This is posterior acoustic shadow. You can see clearly here. So this is HIDA scan, but this is not always done. It is specifically done for some indications to look for the functioning of the biliary system. Function of biliary system or physiology of biliary system is studied with the help of HIDA scan. It is not always used. The investigation of choice is not this. This is what? What is this? ERCP. All images are from Bailey and Love. This is an ERCP image, but this is not the investigation of choice. It is used for removal of stones. When you want to do removal of the stones, that case only we use ERCP. So please remember, this is the gold standard investigation for obstructive jaundice, showing you MRCP with the stones, obstructing in the distal CBD with the gallbladder stone. Both are seen in this case. So this is MRCP. So this is, what is this investigation? This is percutaneous transhepatic cholangiogram. We put a catheter and we put the contrast into the liver. So this is for studying the intrahepatic biliary radicals. We use percutaneous transhepatic cholangiogram. This is a ERCP showing you a cancer in the hilum. This is ERCP showing you stone in the gallbladder and the bile duct. This is ERCP showing another ERCP showing stones. So this is MRCP showing you clad skin tumor. What is this contrast used in MRCP? What is this white color? What contrast is this? It is not a contrast. Bile acts as a contrast. Bile itself acts as a contrast. That is why MRI is known as MRCP here. Okay. So this is MRCP again showing you periampullary cancer. So this CT scan is must for patients you suspect pancreatic cancer patients. You have to undergo send the patient for pancreatic protocol CT. So what is the management? Management is very simple based on the diagnosis. If the patient is coming to you with a CBD stone and a gallstone, the treatment is this. So you can see what is the treatment going on here. So this is a video showing you ERCP sphincterotomy. Sphincterotomy is being done there. You can see at 1 o'clock position, we are cutting the sphincter and we are going to remove the stones by this procedure. You can see stone sphincter cut panna odane stone thana vara arambichirum. We can use Dormia basket to clear all the remaining stones can be removed out. So we can, after removing all these stones, we will put a stent. You can see that is the stent. We are going to put it after the ERCP. This is a gold standard procedure for CBD stones. And if patients are not able to not successful with ERCP, we will go for an open surgery. This is a surgical open or by laparoscopy. We can see the CBD is going to be opened vertically. So you have to open the CBD vertically like this. We have to remove the stones by surgical maneuver, surgical method. You have to open it, remove the stones using the special forceps. What we are using here is, it's an image-based question for an evening session. That is Desjardins stone removal forceps. After removing all these stones, we keep a, what tube is kept inside? We keep a T tube. Okay, T tube has to be kept. So this is a treatment for CBD stone. For pancreatic, other problems like for biliary stricture, we do a hepatico-jejunostomy above the stricture level. And for scenarios like distal CBD cancer, periampullary cancer and all, we have to go for Whipple's operation, might be asked in your exam. So be thorough with the Whipple's, what all being done in Whipple's operation. In Whipple's operation, we put a rooftop incision and we remove the distal stomach. So you can see this is explaining the Whipple's. The stomach, distal part of stomach is removed. And you can see the entire duodenum is removed out. And finally, we are going to anastomose with that is bile duct. And what you are seeing now is the cut part of pancreas. This is a distal body of pancreas. So this is portal vein. This is IVC. We are going to do, how many anastomoses will be needed after Whipple's resection? 3 anastomoses will be done. You can see here, I'll be showing you the 3 anastomoses. That is a pancreatic duct. We have to do the pancreatico-jejunostomy and we have to do hepatico-jejunostomy and we have to do gastro-jejunostomy. So 3 anastomoses will be needed after Whipple's operation. So whenever you are discussing about obstructive jaundice, definitely the examiners will be asking you few questions from pancreatic cancer and from Whipple's operation. And it is easy. You can, once you understand the images of Whipple's operation, you can answer this question. So these are the specimens of Whipple's. So the other cancer is cholangiocarcinoma. We have to resect the bile duct according to the involvement. So some questions from obstructive jaundice image. What is this forceps? This is known as Desjardins stone removal forceps. Okay, Desjardins stone removal forceps. So what is being done here? This procedure is done for obstructive jaundice patients who are very sick and having cholangitis. We will put a tube directly into the intrahepatic radicals and do a procedure known as percutaneous transhepatic biliary drainage. So this is done by radiologist. Percutaneous transhepatic biliary drainage is done here. Can you tell me what is the name of this syndrome causing jaundice? Anybody? Stone in the gallbladder compressing the bile duct causing jaundice. What is this? Very good. This is known as Mirici syndrome. So Mirici syndrome is another cause of obstructive jaundice. And what is the name of this? What is the cause of this jaundice? Purvasir law. Tell me what is the reason for this jaundice? Bile ducts are dilated. That is, what is this? Stone. Gallbladder is contracted. So this stone is there. This is known as meniscus sign. Okay, meniscus sign. Meniscus sign in MRCP is seen in CBD stone. Okay. What is the name of this sign? This is known as Mercedes-Benz sign. Mercedes-Benz sign is shown here. You can see the classical Mercedes-Benz sign seen in gallstones. So these are some of the important images from Bailey and Love and other books. You can see this investigation is known as T-tube cholangiogram. This is a T-tube in which we put the contrast before removing the T-tube. In this case also you are seeing a mist stone. This is a picture showing you a mist stone in a T-tube cholangiogram you are seeing here. So please don't forget this is a T-tube which will be kept for exam. So T-tube cholangiogram investigation is shown here. Okay. So these are the points. What is this stent? This is done during ERCP. We keep this stent inside the bile duct known as Amsterdam stent. Amsterdam stent is used during ERCP sphincterotomy பண்ணிட்டு உள்ள வைப்போம்ல அந்த stent இது. So that, but many medical gastroenterologists, they use this stent. What is this? What is this stent? Can you see? The stent is inside the bile duct. What is the name of this stent? This is known as, yes, double pigtail stent. Double pigtail. I hope you know pig, no? Pigs will have tail like this. So that's a double pigtail stent. Like a pig's tail, it is present. So some people also used to call it as double J stent. It will be straight after insertion. It will get coiled so that it will not come out. So this is double pigtail stent. And this is specimen of what specimen? This we call it as Whipple's specimen. So after Whipple's operation, the specimen is known as Whipple's specimen. So any doubts you have in obstructive jaundice, please tell. Just I have given a fast review of obstructive jaundice, but obstructive jaundice is an easy case to pass. In your exam, if you get an obstructive jaundice, don't hesitate to take. Definitely the examiners will come with the intention of passing you because it is usually a PG case. For MBBS students, if obstructive jaundice is kept, means they are going to pass you. Remember that. Okay. So thank you.
Thank you, sir. On behalf of the students, I want to ask two more questions, sir, for the benefit of students. For any mutilating surgery in the body, for example, CA breast, you have to prove by biopsy. Such a major Whipple's procedure you are going to plan for a periampullary carcinoma. Is it mandatory to prove the malignancy, if at all, by what method, or it is not mandatory?
In obstructive jaundice patients, we can most of the time we can find out the diagnosis, sir. But if you have a doubt, there is nothing wrong in doing a PET CT, sir. We always advise them to undergo PET CT scan to rule out malignancy. For example, if you have a doubt, it is a chronic calcific pancreatitis causing jaundice or cancer pancreas causing jaundice, we will go for a PET CT scan. Even if in PET CT sometimes we have a doubt, such cases we have to take EUS guided biopsy. So EUS guided biopsy is a recent advance, but it is not available in any of the government medical college hospitals, you know very well. But EUS guided biopsy, if available, is the gold standard to take biopsy in case of pancreatic cancer, distal bile duct cancer, any cancer you can take biopsy, especially causing obstructive jaundice by EUS guided biopsy. So EUS guided biopsy, just have an idea about it. Okay. Yes.
So students, there are two indications wherein you need not prove by histopathology, you can plan curative surgery, major surgery. One is your obstructive jaundice. Even without proving tissue diagnosis, you can contemplate major radical surgery. One is periampullary carcinoma or carcinoma head of the pancreas. Number two is renal cell carcinoma.
Yes,
Do you
sir.
agree, sir?
Yes.
These are the two situations wherein there is no need for tissue proof prior to planning.
Yes,
And then what is the indication for PTBD, sir? In this obstructive
Percutaneous
jaundice?
transhepatic biliary drainage is a procedure done for cholangitis patients whom ERCP failed. If ERCP we are trying, we are unable to drain the biliary system, patient is very sick, we can do percutaneous transhepatic biliary drainage, number 1. Number 2, for obstructive jaundice patients who are having elevated prothrombin time INR and not able to take up a surgery because more than 15. So the latest guideline says more than 15 milligram per deciliter, we can do pre-op, reduce the bilirubin level before surgery. So these are 2 important indications for PTBD, percutaneous transhepatic biliary drainage. Yes, sir.
Thank you, sir. Thank you.
Thank you,
sir.
sir. Thank you so much. Thank you all. I thank wholeheartedly for the ASI for calling me for this function, because this is a place where I was sitting along with you like a final year student some years back. Happy to see you all back here as students, and I'm as a teacher here. Thank you so much. Thank you. I thank Chandrasekhar sir and Kannan sir for inviting me. Thank you, sir.
Thank you, RRF team, for their support for ASI R&R CME undergraduate CME program. Thank you, Rajamahendran.
Thank you, sir. Thank you, sir. Thank you, sir.
See you, tongue.
Request the students from ACS Medical College who will be presenting customer of the tongue. Dr. Balu Murugan is requested to be the convener, and in the chair will be Dr. Vivekanandan Subramanianathan, Dr. Sengutavan, and Dr. Abraham Jabakumar. Dr. Durai, Professor of Surgery at Kilpauk Medical College. Okay. Doctor.
Good afternoon, sir. Next slide. A 50-year-old gentleman from Coimbatore, manual labor by occupation, with chief complaints of ulcer over the left side of the tongue for past 4 months. Next slide. The patient was apparently normal 4 months back, and he noticed an ulcer over the left side of the tongue, which was insidious in onset. Initially, the ulcer was small in size and now progressed to attain the present size, associated with continuous dull aching type of pain in the region of ulcer, not radiated to ear, aggravated with food. Next slide. History of excessive salivation, history of occasional bleeding from the ulcer, history of loss of weight, no history of difficulty in opening mouth, no history of difficulty in chewing and protrusion of the tongue, no history of sharp tooth, denture, no history of hemoptysis, dyspnea, and bony pain. Next. Past history is a known hypertensive for 2 years under a proper medication, no history of diabetes mellitus, bronchial asthma, tuberculosis, coronary artery disease, no history of sexual exposure, no significant surgical history in the past. Personal history is a smoker for 25 years, 8 cigarettes per day, and chewing pan for 25 years, 3 times a day, alcohol for 25 years, mixed diet, normal appetite, no significant family history. Next. Some history summary. The patient has a positive history of alcoholic and chews pan and smoking cigarettes for 25 years, and came with the chief complaints of ulcer in the left side of the tongue for past 4 months, with positive history of excessive salivation, pain in the region of ulcer, bleeding, occasional bleeding from the ulcer, and loss of weight.
Yes, sir. From the history onwards, what's your probable diagnosis?
What
do you suspect?
It's a malignancy. It is a short duration, and the age is more than age is 50, and then it is having a short duration, and excessive salivation is there.
Why there is excessive salivation in malignancy?
Because of irritation of the nerve, and the patient is not able to swallow, they will have
Number one, irritations of the nerve.
nerve.
Irritations of the nerve endings. And the ulcer itself is a irritant and then not able to swallow the saliva. What the cause for the pain in malignancy?
Because of lingual nerve irritations.
Because of the lingual nerve involvement.
Involvement.
So in malignancy, the pain is not, it's initially not painful. Later pain because of one is infection. Number two is infiltration to underlying.
Okay.
Is there any halitosis?
No, sir.
What is halitosis?
Bad breath. Like
Bad odor.
Odor.
Yes, bad odor is due to what?
Necrotic material slough from the ulcer.
Yes, the
That
release of the-
releases ammonia, mercaptan.
Yes, from the necrotic tissues of the malignant tissue. Okay. Yes.
When you call the ulcer is a chronic ulcer,
Sir,
when you call the ulcer here, chronic
more than
non-healing ulcer here,
6 months with not healing.
6 months,
3 months. 3 months.
3 months. If it's ulcer not healing more than 2 to 3 weeks, then you call it. We are suspicious ulcer, no?
When you call it as a chronic ulcer, he is asking. The ulcer is not healing more than 3 weeks. It is called chronic ulcer. Okay. Yes,
Next.
he is a smoker and alcoholic.
Yes, sir.
Okay.
Next.
So here, the patient says he's not able to speak properly or not able to eat properly. What do you suspect in a tongue ulcer?
Sir, muscles of the tongue will be involved, like genioglossus, styloglossus, hyoglossus,
Which nerve is involved?
hypoglossal nerves.
Hypoglossal nerve is a motor nerve. It supplies the extrinsic muscles. Okay. Yes.
Next slide.
Next.
Yes, go to the examination.
In general examination, positive of pala present and palpable submandibular lymph node in the left side. No ictus, no cyanosis, no clubbing, and no edema. Next slide. Vitals are found to be normal, pulse 92 beats per minute and respiratory rate 16 breaths per minute, BP 130/90 mmHg, and temperature afebrile. Next. Oral cavity examination, the lips are found to be normal, buccal mucosa, submucous fibrosis is seen, and hard palate and soft palate are normal, tongue loss of papillae with ulcer, floor of the mouth is normal, teeth stained in brown in color, no sharp teeth and with normal arrangement, retromolar trigone is normal, tonsils are normal. Inspect
What is trismus?
Inadequate opening.
So when you examine the oral cavity, whether the patient has got a normal opening or not.
Yes, sir.
Whether the patient has got a normal opening,
Yes, sir. The patient is able to, we can able to put the 3 fingers of the hand. So fingers.
whose finger? Okay.
Index, middle,
Usually that examiners, there's a patient's finger.
examination.
Okay. But you said there is a submucosal fibrosis.
Yes, sir.
But how is he able to open? Whereas there is a submucosal fibrosis, obviously is going for a trismus, no? In your case, there is a submucosal fibrosis, you said?
He has mentioned submucous fibrosis present.
Okay.
But it depends upon the grade because submucous fibrosis is having 4 grades. So 3rd and 4th grade only not able to open. 1st and the 2nd grade you can able to open the mouth. Okay.
Inspection, brown colored teeth, tongue normal in shape, no deviation, moves in all direction. Anterior 2/3 of the tongue has a solitary ulcer which grow, the growth approximately 3 x 4 centimeter in size. It extends extension anteriorly 5 centimeter from the tip of the tongue, posteriorly 3 centimeter from the retromolar trigone, medially from 2 centimeter from the midline, and laterally 2 centimeter from the floor of the mouth. Next. Irregular in shape, irregular margin, anterior well-defined and posteriorly ill-defined with everted edges. Floor of the ulcer is covered with slough. Floor of the mouth is normal. Next. Next.
Yes.
Yes.
Palpation.
Palpation, tenderness present, a solitary exophytic growth of 3 x 4 centimeter is in the left side of the tongue, irregular in shape and surface, anteriorly well defined, and the extension is anteriorly 5 centimeter from the tip of the tongue, and medially 2 centimeter from the midline, laterally 2 centimeter from the floor of the mouth. Next. Floor of the ulcer is filled with slough, which bleeds on touch, induration of base and the surrounding area.
How you check induration in tongue?
Sir?
How you check induration in tongue?
How will you check the induration? How will you test the induration?
So when we palpate the base of the tongue with a bi-digital exam.
Ask the patient to open the mouth.
Without protruding the tongue out. You have to keep the tongue inside
Not ask.
and you have to palpate. If you protrude, what happens? The muscles will act and it gives a appearance of a induration. Yes.
Next. Lymph node examination, left submandibular lymph node palpable, which is 2 centimeter in size, with well-defined margin and hard in consistency, not warm and non-tender. No other palpable swellings in the neck.
Palpation of the oral cavity. Are you able to palpate any irregularity of the mandible? All the tooth sockets are normal. Gingiva is normal. Everything you have to palpate.
You have to see any caries tooth, loosening of a tooth, and inner table of the mandible, because it's near the ulcer. Any involvement of an inner table.
Shaking of the tooth.
Yes.
All these things you have to examine in the palpation.
Yes.
Okay.
What are the precancerous lesions in the oral cavity?
Leukoplakia, erythroplakia, and oral submucous fibrosis, chronic hyperplastic candidiasis, and then verrucous leukoplakia, oral lichen planus, Plummerman sideropheric dysplasia.
So you all know, you should, all the exams, they will ask you what are the risk factors and what is the precancerous lesions in the oral cavity. Okay. Yes.
Next slide. Other systems are found to be normal. CVS S1, S2 here, no murmurs. RS normal, vesicular breath sounds. Abdomen soft, non-tender, no organomegaly. Next.
Okay.
Next.
Yes, what's your probable diagnosis?
Carcinoma of the anterior two-third of the tongue with the stage of T2N1.
So put in which side? Left side or right? Left side, no?
Left side.
Left side. Yes.
T2N1 and M0, sir.
In your presentation, whether the ulcer cross the midline?
No, sir, it doesn't
So
cross.
you should mention that is also why it's important.
If it crosses midline, we will do surgery as a total glossectomy, and the lymphatics will be.
So bilateral lymphatics, lymph nodes may be involved. So that's why you have to see whether it's across the midline or not.
Yes.
Yes.
Next. Next.
What type of malignancy it could be?
Fungating type of
What is it? Microscopic.
Squamous cell carcinoma.
Pathological type.
Pathologically, microscopic, squamous cell.
Macroscopic, what type of?
Fungating type of.
What are the types of macroscopic classification?
Fungating, ulcerative, fissure, nodular, frozen.
Okay. So how many types of squamous cell carcinomas are there? There are 3 types of squamous cell carcinoma. Number 1, verrucous type, basaloid type, and then sarcomatous type. There are 3 types of squamous cell carcinoma: verrucous type, basaloid type, and sarcomatous type. Yes. Which is more virulent?
Verrucous.
No, verrucous
Verrucous
carcinoma is
better.
less virulent. Yes. Basaloid type is the more virulent tumor.
Anywhere, if you say verrucous means low virulent, better prognosis, locally aggressive malignancy. Okay.
What are the other types of malignancy can occur in the tongue?
Adenocarcinoma.
Then malignant melanoma. So adenocarcinoma and malignant melanoma can occur in the tongue. Yes. What are the differential diagnoses for ulcer tongue?
Aphthous ulcer, dental ulcer, syphilitic ulcer, tuberculous, and chronic non-specific ulcer.
Okay. Painless ulcers?
Painless,
What you told already? What's the painless ulcer?
aphthous ulcer.
Aphthous ulcer is more painful, no?
Carcinoma initially to be painless.
Okay.
Painless ulcer.
That is a painful, no. Certain things, certain.
Syphilitic ulcer is painful or painless ulcer?
Painless.
Syphilitic ulcer, chancroid, is the painless ulcer. Okay.
Next.
Yes, how will you proceed?
So investigations, first non-invasive investigations like CT, MRI and CT, sir. Then invasive, we do edge wedge biopsy and FNAC of the lymph node.
Okay, okay. What are the groups of nodes you are examining?
Submental, submandibular.
What are the levels you know?
Yes, sir.
What are the levels?
1A is submental, 1B submandibular, 2 is upper jugular, middle jugular, lower jugular, posterior is 5, 6 is central compartment, and 7 is mediastinum.
Very good. You are expecting where is the mets from the tongue?
From the tip of the trunk to the submental, from the lateral side to the submandibular, and the posterior is upper deep cervical group of
Okay, good.
1, 2, 3. Three
Yes.
levels. So see a tongue most common.
Supraomoid group.
Yes.
Yes.
Yes, what are the investigations you will do?
FNAC of the lymph nodes and edge wedge biopsy from the ulcer, and then MRI of the tongue, head and neck, and CT, and then
No, you do a MRI, head and neck. That also going to give you things. Why you want to give a CT scan and MRI both? Go for an MRI because it's the tongue. So you want to know the depth of invasion. No, how much it is. So MRI will be better than a CT intent. If you have bone involvement is there, you can take for a CT or OPG, ortho-pantomogram. Then
CT is available, OPG is not at
Not
all
needed.
required. If MRI is available,
OPG.
CT scan is also not needed, no needed. So MRI is the best mode of investigations for CA tongue.
Yes.
Okay. Yes, then for histopathological, you have to take a wedge biopsy. Wedge biopsy or a wedge biopsy. You can take punch biopsy also for the CA tongue.
Yes.
Yes.
So why you want to take a edge wedge biopsy?
because in the central there will be necrotic tissue, so we will not be seeing it. And the second point is we will be able to see the normal epithelium when we take from the edge.
So only say you can have a comparative and
compare.
also more proliferative cells in the periphery. Yes.
Okay, investigation done.
Next.
What's your plan in your case? What type of management you want to give treatment?
So hemiglossectomy and left-sided hemiglossectomy with same side modified neck dissection and opposite side prophylactic lymph node dissection.
Why? Your thing is only level 1 nodes are involved.
Yes, sir.
Only level 1 nodes are involved. Why you want to go for opposite side? So you can go for a left hemiglossectomy. Then you can go for a
Modified
radical neck dissection of that side. Okay.
Then after surgery, what will you do?
Sir, if section surgery, reconstructive surgery, flap we will place.
No, ma, you have done hemiglossectomy and modified radical neck dissection. Okay, after that, what will you do? How will you follow the patient? Will you do any mode of treatment?
Radiotherapy.
Radiotherapy, yes. You have to give radiotherapy. When will you give primary radiotherapy for the primary lesion?
So less than 1 centimeter of lesion.
Less than one. What are the types of radiotherapy you know?
Brachytherapy.
Brachytherapy, teletherapy, and interstitial therapy. So combination of both interstitial therapy and teletherapy you can give.
So in a treatment for a yearly cases, there are both radiotherapy or a surgery or things. If you want to conserve it or things, can even a brachytherapy also you can give. Okay.
Yes.
Yes.
For T1 lesion N0, what's the mode of treatment?
A wide local excision, sir, with 2 centimeter margin clearance.
Followed by
A radiotherapy.
Neck.
for T1 N0 lesion.
No, you're done a primary, you removed. Anything for lymph node station you want to do or not?
Radiotherapy of the lymph node.
Why you want to go for radiotherapy? In a yearly case, any one modality you try. No, you go for surgery means surgery.
Surgery you can do modified radical neck dissection. Modified radical neck dissection.
So N0 even
that is called prophylactic dissection. For N0, N0, wide local excision followed by prophylactic neck dissection you have to do. Same side prophylactic neck dissection.
Especially a tongue and other things, no?
For
There
N-
is around
for
30%.
For T1 lesion, N0, you have to give wide local excision followed by prophylactic neck dissection of the same side. Okay. Palpable nodes, we have to go for a bilateral neck dissection. What are the complications of CA tongue?
So aspiration bronchopneumonia, and then torrential bleeding from the lingual artery, and then cachexia, starvation, and then
Aspiration pneumonia, please.
yes, sir.
And
then
cachexia. Then the patient will develop.
edema, laryngeal edema there will be laryngeal edema, and there will be obstruction for breathing.
Okay. Cause for death in this patient?
So she said,
What is the cause for the death?
Starvation, cachexia, bleeding, torrential bleeding.
Bleeding from where?
Lingual artery,
Only lingual artery?
external
Extracarotid.
carotid artery due to
External carotid or internal carotid?
external carotid.
Bleeding from internal carotid, not external.
What is an advanced case? What do you manage?
Hemiglossectomy, glossectomy, total glossectomy, hemimandibulectomy, and then modified radical commando operation, neck dissection.
No. It's a composite resection. You say the commando. It's a composite resection if it's the involvement of a mandible. A tongue, the mandible with a node is there. Where you go for a wide excision like hemiglossectomy with segmental or marginal mandibulectomy with going for a modified radical neck dissection. This all you take it. No, it's called a composite resection. That is for the adjunct involvement of the other structures. He's asking about a T3 or T4 lesion. When the bigger the lesion, you are surgically, if you are not able to do, you can go for external beam radiotherapy or a brachytherapy, and you have to make it operable, and you can go for a surgery also. Okay. Yes. It's a very good presentation.
Yes, good presentations. Very good.
Thank you, sir.
I'll ask the Dr. Professor Durai to hand over the certificate to the presenters. Next, may I call upon Professor Durai to talk about carcinoma of the thyroid. Yes, sir. Dr. Vijayan, Dr. Shagayan Misegar, and as well as Dr. Sanmugam will be the chairperson for this program. Dr. Bhaskar sir, please be on the stage.
Sir, Wanga. Sagayam. Huh? You don't know. I am going to present just lecture on malignant thyroid lesions. Yeah. Good afternoon, everyone. So, I think Professor Arasu has covered more about your thyroid tumors. So I am going to cover about thyroid malignancies. You know that? It's coming. Thyroid malignancies.
So the next topic would be by Professor Durai. The topic is malignancy thyroid, is it?
So all you know, the thyroid is one of your long case in your exams. Understand? So we say a thyroid My topic will cover what is the classification, what is the staging, and what are the different type of malignancies occurs in the thyroid, and how will you manage and what are the prognostic criteria. Next, in the brief, you know all the thyroid, any malignancy to occur in an endocrine gland, thyroid is the most common one. Among that, it's why it's thyroid is more common, very easily accessible. And the patient also notify it, and the physician also easily notify it. And that is very common in females and extremes of age. Any extremes of age always suspect malignancy. What are the etiological factors? As we say, there's the exposure to radiation, childhood exposure, more than 5 years exposure, most 5 years after that, then one may develop a thyroid malignancy. There is a family history with the red proto-oncogen mutation, they go for a medullary carcinoma thyroid. KRAS or BRAF mutation go for a follicular or papillary. Then prolonged thyroiditis may be a development of later age group of a lymphoma and papillary carcinoma thyroid. Long-standing MNG recently increased. One should suspect a follicular carcinoma. There are some familial syndromes also associated. One is the Cowden syndrome, Gardner syndrome, and Corney syndrome. In Cowden syndrome, it is associated mainly from a breast cancer and thyroid cancer. Both may be associated with the Cowden syndrome. In a Gardner syndrome, familial adenomatous polyposis colon with thyroid cancer. When to suspect in a malignancy in a thyroid nodule? Any discrete nodule in a male patient, always suspect malignancy. Any child with a thyroid nodule, suspect malignancy. Any thyroid nodule with a palpable lymph node, suspect malignancy. Any fixity or a hard or firm nodules in a thyroid, always suspect. Any associated pressure symptoms, dysphagia, dyspnea, hoarseness of voice, or you have to suspect malignancy. Next. Hard nodules can be different, maybe a malignancy, or it is an hemorrhage in a nodule, or a thyroiditis, or calcified nodule. In your exams, the hard nodule, what are the differential diagnoses? You can mention. So this is a classification in a thyroid malignancy, whether it's a primary thyroid malignancy or from a secondary, from a breast, colon, or kidney, or melanoma. The primary, whether it is from a purely from follicular cells, or from a parafollicular cells, or from the lymphocytes. Purely from the follicular cells, whether it is a differentiated one or an undifferentiated one. The differentiated one may be your papillary carcinoma thyroid, follicular carcinoma thyroid. Among that, the papillary is the most common one. From the parafollicular cells, the malignancy is a medullary carcinoma thyroid. From lymphocytes, it's a lymphoma. Next. This classification is a Daniel classification. So they'll ask what is the classification for thyroid malignancies. Daniel classification is the next. What is the relative incidence? Papillary carcinoma is the most common, 80, and follicular is the next one, the 10%. And undifferentiated anaplastic is a 5%, and medullary carcinoma is a 2.5%, and lymphoma is a 2.5%. Next, what is staging? Staging of a thyroid malignancy. The stage, as you know, TNM staging, tumor, node, and metastasis. The T stage, less than 2 centimeter intrathyroidal nodule, is again subdivided into T1A and T1B. T1A is a less than 1 centimeter. It is called a micro papillary tumor or papillary carcinoma. Then more than 1 centimeter and less than 2 centimeter is a T1B. T2 lesions, anything more than 2 centimeter, less than 4 centimeter. T3 lesions, it is a tumor more than 4 centimeter intrathyroidal or extrathyroidal involvement. Any tumor size with the extrathyroidal involvement of a strap muscles. T4 is a gross extrathyroidal lesion. One may be involvement of the soft tissues like a trachea, pharynx, and soft tissues, or B may be an involvement of a prevertebral fascia and encasing the carotid. So with that, any patient with a carotid encasement where the berry signs is a positive, one should suspect it's a T4 lesion. Next. Nodes, there is a N1, N0 and N1, whether the node is involved or not. N1 is a A and B. Whether the central compartment node is involved, N1A. If it is the involvement of the ipsilateral or contralateral neck nodes, it is called a N1B. Next. This prognostic staging criteria is important, where in a differentiated thyroid cancer, the age is important. The age is below 55 years or above 55 years. If you are below 55 years, the prognosis is better. So they group into stage 1 and stage 2. Any T, any N, M0 is a stage 1 disease in a age group of less than 55 years. In stage 2, any T, any N, M1, it is a stage 2 disease. But a patient with age more than 55 years, it stages into stage 1 to 4B. Next. With that, we will go to the most common one is a papillary carcinoma thyroid. The most common, more common in a younger females around the age of 20 to 40 years. It occurs in an iodine sufficient area. It's iodine sufficient. This is a more common to a lymphatic spread to the lymph nodes. Very less aggressive tumor, slow growing. Next. Next. What is the pathological feature of a papillary CA? This is the thing they will ask you in the questions. These are things. One is a colloid follicle having a papillary projection with the central fibrovascular core. This is one. Number 2 is a summoma bodies. It's a lamellated calcific structure between the cells. Number 3 is an orphan ani nuclei. It's a homogeneous chromatin peripherally with the empty nuclei. This is a nuclear grooving and intranuclear cytoplasmic inclusion is one of the pathognomic of papillary carcinoma. If any, next. This is a summoma bodies. This is the lamellated dystrophic calcification in between the cells. Next. You know that summoma bodies can present any papillary neoplasms, papillary cystadenoma of ovary, meningiomas. This also can be present. This is the papillary projections. You know the papillary projection with the central core of a fibrovascular core. Next. Next. This is a nuclear grooving with the intranuclear inclusion bodies. Next. This is a character, orphan ani character, where there is an empty nuclei with a homogeneous chromatin. Next. So with this, you can diagnose as a papillary carcinoma thyroid. What are the variants of papillary carcinoma thyroid? Papillary carcinoma is a papillary microcarcinoma. There is any tumor less than 1 centimeter intrathyroidal lesions called a papillary microcarcinoma. The prognosis is very good. So even they go for in this malignancy, if they ask you, you can go for a hemithyroidectomy and leave also. Okay. Next is a papillofollicular variant. Here the papillary behave like a follicular carcinoma, more of a folliculars. It's comparatively it's a more aggressive than the papillary. Here it's called a Lindsay tumor, where more papillary and follicle is called a Lindsay tumor. Then tall cell variant. Tall cell variant is occurs in elder patients, more aggressive, and prognosis is a little bad. Then columnar variant occurs only in a male and it produces a more mortality. Then diffuse sclerosing variant. It's a very aggressive, occurs in children more lymphatic spread will be. Next. So we know that peculiarity of the papillary CA is lymphatic spread. It go to the lymphatic. Very slow growing, less aggressive tumor. It is a multifocal. It is a multifocal and multicentric. Sometimes the intrathyroidal lesion cannot be palpable and patient may present with the nodes in the neck. That is called a lateral. It is a metastasis. Next. What are the investigations? The investigations, as you know that it is a triple assessment. One is anatomical, then pathological, then physiological. Anatomically doing a high frequency ultrasound. High frequency ultrasound that will know whether there is a thyroid gland. There is a swelling is from the thyroid gland. The nodule is solitary or multinodular. Whether it is a solid or a cystic components. Whether it's a intrathyroidal or extrathyroidal. Whether any nodes are present or not. All the things we can able to get. Once the nodule is there, when you suspect it is a malignant nodule. When is a nodule is taller than wide. It has got a irregular margin, micro calcifications with a vascularity. If it is there, then one should suspect the nodule is a malignant one. Once the FNAC thyroid, once you suspect it's a malignant, suspecting with ultrasound, go for a FNAC of the thyroid nodule. As we know that FNAC Bethesda criteria, you can the 5 and 6 suspect of a malignancy. Usually in the papillary CA, the TSH levels will be higher because it's a TSH dependent tumor. Plain X-rays, one is to know the tracheal position. Number 2, sometimes the patients in the old extended portion only you are going to keep no. So you have to know any cervical spondylosis there or not to see. And third thing is you have to see any micro or a macro calcification in the thyroid nodule. MRI neck indicated only when there is a local compressive effect of the swelling, like a tracheal involvement, esophageal involvement is there, then you can go for a MRI neck. All the patients always you have to go for a video laryngoscopy to rule out preoperative status of your vocal cord. Next. What is the treatment for a papillary CA thyroid? Papillary CA thyroid, if it is diagnosed, total thyroidectomy. There is no nodal involvement is there by ultrasound. Only the treatment is total thyroidectomy. If there is a nodal involvement in the central compartment, go for a total thyroidectomy with central compartment neck dissection. What is central compartment neck dissection? It is a removal of level 6 lymph nodes from hyoid bone above, from the innominate vein below, on either side the carotid sheath. All the lymphatics has to be removed. If the lateral nodes are involved, then go for a modified radical neck dissection on the anterolateral. So anterolateral neck dissection, you can do that. There is no role of prophylactic neck dissection for the nodes. The nodes are not there, there is no role. But in a CA oral cavity, there is a role of prophylactic neck dissection. But a thyroid is a very low aggressive, so there is no role of prophylactic neck dissection. Once you do the surgery, you wait for 4 to 6 weeks. The TSH has to raise 10 folds of the normal. Next. And subject the patient for radio uptake. Next. Next. This is one of the flow chart where you wait for 4 to 6 weeks and do a radioactive uptake scan. If it is a significant residual lesion is there, you can go for a radio remnant ablation. Radio remnant ablation. That is in a low risk, go for a 30 to 100 microcuries. In high risk group, go for a 100 to 200 microcuries. Previous slide. Then follow up the patient with a suppressive dose of thyroxine. Here is a TSH dependent. So you have to give a suppressive dose of thyroxine around 200 to 300 milligram per day to maintain the TSH level less than 0.1 milliunits per liter. Then follow every 6 months. You have to do a TSH estimation and the thyroglobulin estimation. Normally you have done a surgery. Now there should not be any thyroglobulin. The thyroglobulin you detect post-operatively, there is a recurrence of the tumor. Then regularly you do an ultrasound neck to follow up the patient. Next. Next. So in a follicular carcinoma, next is the follicular carcinoma. So follicular carcinoma, so what it occurs slightly elder age group because it occurs in a pre-existing multinodular goiter. Patient may be having a multinodular goiter for 10 years. Then there is a sudden increase in size and developing a malignancy. So it occurs in an iodine deficient state. The patient will be, again, the females are the most commonly involved. It can present as a solitary or a multinodular goiter. It can be divided into an invasive or a non-invasive type. Next. Next. So usually the follicular compared to papillary will have a local compressive effect. It can compress, produces a hoarseness of voice, or it can compress the trachea and produces the changes in the breathing. So this is the microscope. Here in a, what is how you differentiate a follicular adenoma from a follicular carcinoma? By a mainly a capsular and vascular invasion. So this is the only way you have to differentiate from a capsular and vascular invasion.
Sir, we are running short of time.
Yes, sir.
Please.
Next. The one another thing is the follicular, it meets to the blood spread is more common compared to lymphatics. So they go for a metastasis to the bones. These metastases are pulsatile secondaries. They are pulsatile. They are female with a nodular goiter with any swelling in the sternum or a skull. One should suspect a follicular carcinoma with metastasis. Next. Next. So here the treatment is same like your papillary CA, total thyroidectomy. If nodes are involved, go for a lymphadenectomy. Follow-up is the same. Next. This is a arthal cell variant. This is a variant of a follicular carcinoma. It will more aggressive than follicular. The presence of Ashkenazi cells or oxyphil cells. This will not take up a iodine. So it can be diagnosed with a technetium-99 sestamide scan. So here it is a compared to follicular neoplasm, the involvement of a nodes are more in a arthal cell variant. So total thyroidectomy with a MR&D is needed. Next. Anaplastic, it is a fast growing in the elderly patients where it involves give a compressive effect for the carotid and the adjacent structures. So this is a scabbard where you get scabbard. So if you see this is the trachea is compressed one side and producing a scabbard shape. That's why scabbard trachea. Next. Anaplastic, once you diagnose anaplastic, there is a core biopsy. So in a thyroid, always we use a FNAC. Core biopsy is needed in a anaplastic carcinoma to diagnose and also in a lymphoma. Thyroid lymphoma, you do a core biopsy. Once you diagnose anaplastic, it is a T4 stage. It is a stage 4 disease. And next, treatment, mostly the patient comes late. Next, come late. So always it is only to relieve the compression, you do a isthmosectomy or tracheostomy with the external beam radiotherapy and needed. Sometimes adriamycin chemotherapy may be needed. So usually it is a patient will go for a yes. Next, medullary carcinoma. It arises from the parafollicular C cells. The parafollicular C cells comes from a ultimobronchial body from the neural crest. So usually it is a calcitonin secreting things, more calcitonin secretion. Next. So it's the two types. One is a sporadic and the familial. Sporadic is 80% and 20%. Next. The familial is associated with the Men's syndrome. Next. The feature is mainly is a amyloid stroma. This is the amyloid stroma. Next. This is the staging. Next. So Men's syndrome 2A and 2B. It is a mainly parathyroid and pheochromocytoma will be associated. Next. Here the marker is a calcitonin level and urine 24 hours metaprints and the VMA study and CA will be raised. Next. Here always go for a total thyroidectomy with central compartment neck dissection. Total thyroidectomy with a central compartment neck dissection. Next. And you have to give no need of suppressive dose or here a supplement dose of thyroid. Next. Lymphoma for the sake, usually NHL is a more common and the patients diagnosed by a core biopsy can be treated with a next. Usually it's a rapidly growing tumor, may be associated with fever and patient will have a compressive symptoms. Next. The treatment is a CHOP regime. Cyclophosphamide, doxorubicin, vincristine and prednisone. Next. These are some of the prognostic criteria. Always remember. Ages, aims. It depends upon the age. The age less than 40 and the grade is low grade and no extrathyroid involvement. Size of tumor less than 4 cm. Good prognosis. So the 20 years of survival and mortality is less than 2%. If it is a high risk group, it is more than 40%. Next. Next. This is a total thyroidectomy. All should know what is the position they keep the patient? Rose position. Rose extended position. They go for suprasternal incision, flap raised, and they have to identify the nerve and protect the nerve and go for a total thyroidectomy. Next. 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 Thank you, sir. Thank you.
Thank you very much, sir. It was well narrated and it's an exam question. So it was very well done by Professor Durai. If there are no questions from the floor, we switch on to the next program.
Thank you, sir.
Now the certificate to be issued by Professor Shanmugasundaram, sir.
Thank you, sir. Thank you very much for the excellent lecture. May I ask Dr. Shanmuga sir to issue the certificate to Dr. Durai, sir. Next, let us move on to the right levels of mass clinical discussion.
The one announcement. Last call for the quiz participant's name. Dr. Anbu is there. Please give your names to him. Next round, we'll have the quiz. Thank you.
The quiz prize is plus 532. Presentas for the right levels of mass case. Please come onto the stage.
Sri
The examiners is same.
Sri Ramachandra Medical College.
Yes.
Where are the?
Yeah, please come.
Where are the presenters?
Sujit, come here. Chairperson, all three. Where is Sujit? Yeah, Sujit, sir. Thank you. Thank you so much.
வாங்க சார் நீங்க உட்காருங்க.
The presenters from Karpagam SRMC. Yeah. Please come on. And the examiners, Dr. Sagav Indesegar, Dr. Shanmuga sir, and as well as Dr. Sudeep from SRMC.
Sujit sir from Karpavinaga Medical College and Professor Bhaskar sir from Karpavinaga Medical College and our senior surgeon Dr. Sarmusundan sir and Sagayan sir. Welcome, sir. Please, students, please give them big round of applause.
So the next presence was the diabetic foot ulcer. Please download your presence here. Since we are running short of time, better to upload your presence slides. So in that case, shall we move on to the lecture?
What happens to the diabetic foot? With the candidates ready?
Yeah.
Introduce yourselves.
Good afternoon, everyone. My name is Gautam. I'm coming from the Sri Ramchandra College. We are presenting a case of right iliac fossa mass today.
Right iliac fossa.
Louder, please. Good afternoon, everyone. I'm Dr. Gautam from Ramchandra College. We are presenting a case of right iliac fossa mass. Thank you. Next slide. Next slide. 51-year-old female hailing from Tiruvallur, who is a homemaker, presented with complaint of pain over the right iliac fossa, pain over the right lower abdomen for 2 months. Patient was apparently normal 2 months back, following which she developed pain over the right iliac fossa, which was dull aching, intermittent, non-radiating, no specific relieving or aggravating factors, no history of nausea, vomiting, hematemesis or melena, no history of abdominal distension. Patient gives history of loss of appetite and loss of weight, which was not quantifiable. No history of fever, evening rise of temperature, no history of chronic cough, no history of alternating bowel habits, no history of bleeding per rectum, no history of abdominal uterine bleeding, no history of dysuria or hematuria, no history of jaundice or lower backache, and no history of breathlessness or chest pain. Past medical history, patient doesn't have any comorbidities, no previous similar episodes of pain, or no contact with TB positive patients. Surgical history, patient underwent cesarean section 23 years back. Menstrual history, patient attained menopause 6 years ago. Obstetric history, P2L2, 1 normal vaginal delivery and 1 LSCS. Last childbirth was 23 years back. Family history, no history of breast, ovarian or colorectal malignancies in the family. Summary, a 51-year-old female presented with complaint of dull aching, intermittent, non-radiating pain over the right iliac fossa for 2 months, associated with loss of appetite and loss of weight with no comorbidities.
Ending. So from clinical history, what might be your diagnosis?
I can give a differential diagnosis.
Okay. So what is a provisional diagnosis?
I am thinking of ileocecal TB or appendicitis.
Appendicitis or something else?
Sorry, sir?
Appendicitis?
Chronic appendicitis.
Okay.
Third one being carcinoma cecum.
Okay, so go ahead with the examination.
Orman, I just want to ask you this in the history, why you wanted the altered bowel habits of this case? Patient right leg fossa mass?
I wanted to rule out if patient has episodes of constipation along with loose
Is
stools.
it very common in RAF? Or it's on the other side?
It's usually
It's
present with malignancies of left-sided colon.
Then why you wanted, you're thinking about colonic malignancy in this side, although it's part of colon. That's, you did not ask them.
Okay.
That means blindly following something.
Okay.
Patient has got a swelling, pain, right leg fossa.
Okay.
You don't go for an alternative calcium diarrhea, which is a feature of a left-sided colonic obstruction. Understand?
So now that you have talked of altered bowel habits, what altered bowel habits are you looking for?
Constipation along with loose stools.
What do you mean by loose stools?
Liquid stool.
Is there a definition?
Diarrhea. Sir.
So what do you mean by diarrhea? Can you define diarrhea? Because you come with altered bowel habits. I thought you should be aware of what is altered bowel habits.
Change in consistency of the stool.
Change in consistency of the stool. Is that the one?
Diarrhea.
That's what you mean by diarrhea?
Frequency and consistency of stools.
Okay. Can you be a little more specific? Frequent means how frequent? Per day. So more than 3 episodes of defecation can be called diarrhea, or single episode of watery stools can be called diarrhea. So what is constipation then?
Passage of consistency which is harder than the usual. Consistency.
You're not clear. If you don't pass feces for how many days, you call it as constipation?
2 to 3 days. Sir.
2 to 3 days, 2 or 3?
3 days.
3 days. Okay, you're right. So 72 hours and above. If you don't pass the stools, it can be considered a constipation. Or single one passage of hard straining stool with difficulty. It's also inspissated stool especially can be called a constipation. Okay. Because though it's not necessary for this, because you raised that question, I thought you should know what it is. You know, what is a spurious diarrhea then?
It is usually seen in left-sided colonic malignancy,
Yes,
where there is
good,
obstruction.
good. Yes. Can you explain what is a spurious diarrhea? You should know what is a spurious diarrhea.
There is obstruction. When there is obstruction on the left-sided colon, the stools will try to push through the growths.
Yes.
Which will allow passage of liquid stools.
Can you explain a little more? You're right. Can you little more explain about the source of watery fluid from there?
Passage of mucus stools.
See, when there is not a total obstruction, when the feces go and obstructs the lumen, the leftover lumen, there is increased secretions in the proximal intestine, just like in any other intestinal obstruction. So when the feces gets loosened up, the watery stuff comes out. That's called a spurious diarrhea. Again, it gets blocked. It's a repetitive symptom. Okay, next.
Moving on to examination. On examination, patient is afebrile, pallor present, no icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy. Vitals, pulse rate 90 per minute, BP 130 over 70 millimeter mercury, and saturation is 98% in room air with ECOG score of 1. Next slide, please. Examination of abdomen. On inspection, umbilicus in normal in position and inverted. Fullness noted in the right iliac fossa. All quadrants move with respiration. Previous cesarean scar noted, healthy. It was a phalansteal scar. No visible gastric or intestinal peristalsis. No visible sinuses or dilated veins. No visible pulsations. Hernial sites were free and renal angles free. And left supraclavicular fossa, no fullness noted. On palpation, abdomen was soft, no tenderness. A mass of size 4+3 centimeter, palpable in the right iliac fossa, irregular in shape. All borders felt. It was nodular in surface, hard in consistency, with restricted mobility. Upon leg raising test, the mass becomes less prominent and the plane of swelling is intra-abdominal and intraperitoneal. There was no hepatosplenomegaly, no other mass palpable. Hernial sites free on palpation as well, and left supraclavicular fossa, no lymph nodes palpable. And on percussion, there was impaired note over the mass, and liver dullness starts from fifth intercostal space in the midclavicular line up to the costal margin. On auscultation, normal bowel sounds were. Per vaginal examination, cervix was normal, cornice is free. The mass was not palpable per vaginally, and no other growth palpable. Per rectal examination, a normal sphincter tone, no mass or growth palpable, and no bleeding PR. Other system examinations, clinically normal. So my provisional clinical diagnosis is carcinoma of the cecum.
Yeah, how you assess the plane of the swelling? Plane of the swelling.
Upon leg raising test, the mass is becoming less prominent, so indicating it is not a parietal wall swelling. And on putting the patient in left lateral position, it falls to the side freely, so indicating it is not retroperitoneal, and it is an intraperitoneal swelling.
Suppose if it is a parietal wall swelling, what swelling will you expect? Parietal wall swelling.
It could be a hematoma.
Hematoma. Is there any tumor that will come across in that location? Any tumor arising from anterabdominal wall?
Desmoid tumors.
Okay. Any other thing? Any other parietal wall swelling?
Liposarcomas.
Liposarcoma. No, that is a retroperitoneal. You will get lipoma. Okay. What are the retroperitoneal swelling in that you will get in that location? Retroperitoneal swelling.
It could be from the ascending colon.
Ascending colon, that is an intra-abdominal. No? What other swellings? What are the organs behind that?
Ureter.
Ureter. Anything? Any abnormality, congenital anomalies or abnormalities?
Non-ascended kidney.
Very good. Similarly, just opposite to that one.
Undescended test.
Yes. Okay. So what is the name of the test to assess the plane of the swelling you are doing here?
Carnet's test, like this.
Carnet test. How will you do the test?
Patient in supine position and the leg to be raised without the knee flexed.
Okay. What is the purpose? What you are doing?
Contracting the rectus muscle.
Rectus muscle. So what will happen to the swelling if it is a parietal wall swelling?
The mass tends to become more prominent.
More prominent. Okay. What will happen in other swellings, intra-abdominal swellings?
It's less prominent.
Less prominent. So how will you differentiate from retroperitoneal and intraperitoneal swelling clinically?
Either in left lateral position or knee elbow position.
What will happen?
Knee elbow position, the mass should fall down freely if it is intraperitoneal, and in left lateral it should fall to the side freely.
Okay. So what is your clinical diagnosis?
Carcinoma cecum.
Carcinoma cecum. Okay. Can you tell me that? Enumerate the findings why you are telling this is carcinoma cecum.
With history, elderly female with pain in the vague, dull aching pain in the right iliac fossa, with loss of weight and loss of appetite. And on examination, pallor was present and a hard, irregular shaped mass, intra-abdominal, intraperitoneal, with restricted mobility in the right iliac fossa.
Can it be a malignancy? Because you are telling short duration swelling. Is there any past history of tuberculosis?
No past history of tuberculosis.
No past history. Can it be a malignancy?
Malignancy.
Okay.
Just one thing I wanted to tell you. This leg raising test will not go for your mass in the right leg. Because your rectus is going to contract. It will not be simple. It will not go for it. You must do something else like a Valsalva to check contact the stop muscles. Again, the swelling in 4 to 3 centimeters is so small. If you geometrically have an idea, size of the swelling, it should be more. You said fullness in the right iliac fossa. That means the swelling should be more than 10 centimeters to make a fullness in the abdomen, even in the wasted person. So probably that finding of inspection was wrong, and the test leg raising test is not appropriate to do this. You must contract the frank muscles. This is a frank muscle with the other and the right leg muscle. Understand? So that is what you should do. And again, in a history, patient, you should ask for any contact. Not necessarily the patient should have had a history of fever, weight loss, and anything. But even the patient has had a contact history, silent tuberculosis must be there. Understand? That you should also rule out. Understand? That you should rule out. Then this, then more fatigability of the patient. If you're thinking in terms of the right leg fossa mass is present late, your duration only 2 months. So it should present late. And then if it's you think in terms of malignancy, then you should rule out the prominent feature of right leg fossa mass or malignancy is anemia. So you must see for fatigability, anemia presents weakness, tiredness, not a loss of weight. Yes. These are all the students to carry out.
Inspection, your left of the incision.
Yes. Yeah, hernial sites.
Not in the hernial side, in the scar.
Scar as well.
So that should be one of the differential diagnosis. Okay.
Apart from this, any other differential you want to offer? You said the carcinoma cecum first.
Yes, sir.
Then
The female patient.
Female patient.
so you ruled out this thing, tuberculosis.
It could be ileocecal tuberculosis.
You're thinking in terms of ileocecal
A
tuberculosis.
second differential.
Okay. Any other?
Appendicular mass.
What appendicular mass? 2 months duration, is it?
Yes, sir.
2 months duration, what appendicular mass do you anticipate?
Secondary to appendicitis.
When do you get an appendicular mass if it is appendicitis? And when do you get appendicular mass after that?
After an acute episode of inflammation, the appendix may perforate and form a phlegmon.
Not necessary to
Not
get
necessary
perforated.
to perforate. Inflammation itself can produce adhesions.
Okay.
Okay. Because what's the reason for adhesion in appendicitis, apart from perforation?
Sir is asking how the mass is found.
The omentum tends to cover the terminal part of ileum with cecum along with the appendix.
It's a diffuse inflammation of the appendix. It's called pan inflammation. That's
Yes.
why you get adhesions in
Yes.
appendicitis itself, not necessary perforation. Any other thing apart from appendicular mass? Could be a tumor, primary tumor of the appendix, which can cause mass.
Yes.
Anything else? Did you think in terms of a Crohn's disease? No, as a differential.
Yes.
Sir is asking differential diagnosis.
Wouldn't you think in terms of some Crohn's disease?
Yes, it could be.
So
But-
what about actinomycosis and all that?
Yeah, but
No, is that in your differential I'm asking? All
this-
this
with
should
this,
be in your
yes,
differential
yes.
diagnosis. Okay. If it is tuberculosis, what type of tuberculosis you anticipate?
hyperplastic,
So what are the other types?
ulceroproliferative.
And the combined type?
Yes.
Okay. So what investigations you would like to proceed?
Specific investigations to proceed with colonoscopy and
Why you are colonoscopy now? Especially.
since
Routine investigations there. No.
my first differential is carcinoma cecum in this.
No, diagnosis, investigation. Which is best? The colonoscopy, anything else? No, anatomically, what investigation you want to do?
Ultrasound to start with.
Basic.
Whenever the mass is development, we would like to do this now. We would like to do the minimal early non-invasive investigation first, which will not harm the patient. That should be our protocol.
Yes.
Wherever available, it may not be specific or might not be sensitive, but it will give a clue to you. So you will go for a hand. Then probably you go colonoscopy. Understand? What do you see in colonoscopy?
Colonoscopy, the mass can be seen and as well biopsy can be taken. And any other synchronous lesions can be ruled out.
Then there is no mass.
Colonoscopy, what are the parts you see?
Till the terminal ileum.
Terminal ileum, yes. What is the measure of terminal ileum you see?
It's about 1 to 1.4 meters from the anal canal.
Okay, you see the lesion, you're taking a biopsy. What do you think you want to do it further?
Then we take a biopsy.
Yes. What do you expect to see?
Adenocarcinoma.
Adenocarcinoma. Then
Plan for metastatic workup.
Yeah.
And then proceed for surgery.
What metastatic workup you want to do? You don't mention anything. Just simply see. Is there a serum CA? No. Other than that, what metastatic workup you like?
A CECT abdomen will show the liver mets and as well
What other mets?
lymphadenopathies. And chest X-ray.
Okay. Yes, then what are you going to do about this case? How are you going to proceed with it? After this, you're saying thank you, want to thank you after this. You won't like to know what after investigation, you tell the patient, okay, you're diagnosed. Oh, would you like to put us? For that additional side, what is your plan? Is it not? You're presenting a case. It not ends with the investigation, no? Management of patient includes investigation and treatment. Is it not? So you know, you have to present a case, then you have to say what you are going to do for it. Is it not? You never have a detailed view. You can at least say what you are going to do. Baseline treatment, which is available. You must tell, no? What are you going to do for this patient?
Plan for right hemicolectomy.
Right hemicolectomy. Good. Okay, well, accept it. What are you going to do in the right hemicolectomy? Have you seen a right hemicolectomy?
Yes.
What do you do?
The terminal part of ileum up to the proximal 2/3 of the transverse colon is resected.
2/3 of the transverse colon. What are the precautions you take while doing an hemicolectomy? Because this is a cancer case, no?
Yes.
This is a case of cecum. You suspect a malignancy, no? So how do you start the case? We just clamp the ileum, mobilize the colon and do the resection, or take some precautions.
The vessels should be ligated
Which
as
vessel? Where do you start? That's what we are
the
asking.
ileocolic vessels and right branch of middle colic.
Yes.
Or
Where do you like it?
ligated as
The dissection or ligation of vessels in malignancy and in other non-benign conditions different. You can do it at the periphery. But malignancy must go to the root of the vessel and then do it in the ligation more proximal sections. So that which you will start doing this or ligation first and then do the resection.
ligation first and then
Yes, you must do the ligation first. The main vessels ligate so that you know the level of demarcation. You know the colic, so you know what level of ileum to remove. And you can go and proceed and do the answer. Yes.
So before surgery, will you do any preparation? Before surgery, planning for right hemicolectomy.
Yes.
So what preparation you will do for this patient? Directly you will do surgery or any other preparation you want to do?
Bowel preparation.
Yeah, how will you do that one? What is the need for bowel preparation?
For a clean surgery and
Anyway, you are going to do the anastomosis.
anastomosis.
Okay, so it should be very clean. So you should prepare a mechanical bowel preparation. So you have to do the polyethylene glycol preparation. Peg leg.
Okay. You have done a staging, you found a lesion in the liver. What will you do? Metastatic lesion in the liver.
Will you do surgery or not? Sir is asking.
Plan for chemotherapy.
Okay, anything else? You mean neoadjuvant chemo?
Neoadjuvant chemo.
நான் சொன்னேன்னு சொல்லிட்டியா?
Yes.
Okay. Anything else?
If there's an obstruction,
Then plan for palliative bypass procedure.
what type of palliative bypass?
Iliotransverse bypass.
Okay. So what will you do if there's a lesion in the liver? Sir, காட்டுறாரு பாரு, ஏதோ காட்டுறாரு.
You are in a center where you can do it.
So,
segmental.
So if
no problem.
so this is because this is the only metastatic condition where you can have a curative chances. So that's the reason I'm asking this question. So you can't have any other for any other secondaries from anywhere else. You cannot have a curative resection. This is the only place where you can have a curative resection.
What is the surgical procedure for ileocecal tuberculosis?
No surgical procedure.
Asking surgical procedure. Huh?
We'll leave it like that.
Like that.
We'll leave it in the past.
Mass.
After diagnosing, doing
All the investigation after doing it's a ileocecal tuberculosis. What is that? I don't know it is medical line only. If it's failed, what is the surgical treatment?
No. So what will happen? Finally, they will have a severe obstruction. No? You will have to intervene at some point of time. Understand? So what happens in a peptic ulcer? You repeatedly treat, and after some time, the physician will have no other say. Okay, go to the surgeon because it will go into obstruction. Because you see tuberculosis, you initially treat, then what happens? After some time, okay, no problem.
Surgery same, right? Same. So it is asked you for Chen and for malignancy, where to ligate? That's a question. Okay. Yes. Right. Thank you.
Thank you. Thank you, sir.
Done well, yeah. Give him a big hand, yeah. Okay, thank you.
Request to give the certificates to the presenters. And I request Dr. Chandrasekhar to give the certificate to Dr. Shanmugha Sundaram. And I request Professor Shanmugha Sundaram to give the certificates to Dr. Bhaskar and Dr. Sujit Kumar.
I welcome Dr. Vincent Narona to talk about the cervical lymphadenopathy. I welcome Dr. Anandi Madam to the chair.
Cervical lymphadenopathy. Good afternoon. Actually, in the initial program, this was supposed to be 30 minutes, but it's cut down to 15. So I'll be as brief as possible. Okay, next. Now, I have drawn two triangles. What are they? Can you tell me the boundaries? What's the boundary of the anterior triangle? The anterior triangle is bounded above by the mandible, behind by the sternomastoid, and in front by the midline. And posterior triangle is bounded in front by the sternomastoid, below by the clavicle, and behind by the anterior border of trapezius. Next. 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 So, how many lymph nodes are there in the neck, head and neck? See, in the whole body, there are about 800 nodes, out of which a small area like head and neck has got about 300 nodes. It's one of the very important areas for lymph nodes. So, a lot of people describe these different nodes. First person was Rouvier in 1932, different people. But what was the basic thing that all of them did? They divided the nodes into a horizontal chain and a vertical chain. Okay? Next. Then Pack said, instead of horizontal, he said circular. That means he started with submental, submandibular, facial, preauricular, parotid, preauricular, postauricular, occipital, and went around circular and vertical. But today, next. Today, what we follow is levels of nodes. Level 1 is the submental and submandibular, which are 1A and 1B. Level 2, 3, and 4 are upper jugular, mid jugular, lower jugular, that correspond to the upper 1/3, mid 1/3, and lower 1/3 of sternomastoid. Level 5 is posterior triangle. So supraclavicular nodes come in posterior triangle. Level 6 is medial to the carotids. Okay. Next. There is also a level 7, which is not in the neck. That's in the superior mediastinum, because thyroid also drains to that. Now, if you look at this diagram, it very clearly shows you where the different nodes are. Remember, the sternomastoid comes from behind forwards. So the level 2 is going to be broader. Level 3 is little narrower, and level 4 is more narrow because the sternomastoid has come front. Whereas the level 5, because of the sternomastoid coming front, is quite a big area. Now, level 6, you can see level 6. What does it drain? What does level 6 drain? Level 6 drains all the midline structures. That means your larynx, trachea, thyroid, they all drain to level 6. All the midline structures. Remember, what does level 1 drain? Chin, cheek, alveolus, tongue, all the structures which are in the center. Level 2, 3, and 4 drain the posterior structures. Posterior third of tongue, the pharynx, larynx, etc. And it's in orderly progression. It goes first to 2, then to 3, then to 4. Okay, next. So this is the structure of a node. If you see the structure of the node, there are many afferents coming to the node, but only a single efferent going away. You have the outer cortical region and the medullary region down here with the germinal follicles. Next. So this just shows you a histopathological picture and the same thing in a diagrammatic form. Next. You know that nodes are the primary barrier to infection, and they are also enlarged in malignancy. Now, what are the enlargement of nodes as per the age? 0 to 15, commonest is inflammatory. 16 to 40, it's also inflammatory. The difference is in children, it's usually non-specific inflammation. Any infection in the teeth, gum, tonsils, etc. But after 16, the commonest in India is tuberculosis. And remember, above 40, think of malignancy. The commonest above 40 will be secondaries. But remember, lymphomas have got a bimodal peak. One in children, second in older people. It's above 60 usually. Lymphomas have a bimodal peak. Next. Next. So what is a significant node? Every node enlarged is not significant. In the neck, it has to be greater than 1 centimeter size. Supraclavicular nodes greater than 0.5 centimeters are significant. Remember, for a supraclavicular node, if it's more than 0.5, it is significant. In the inguinal region, it should be more than 1.5 centimeters in size to be significant. Next. There was an old rule called the rule of 80. This is for above 40 years, 80% of non-thyroidal swellings are nodal, 80% of the nodal swellings are neoplastic, 80% of the neoplastic swellings are malignant, and 80% are secondary. What it tries to tell you is, if a person of middle age comes with a nodal swelling, it is most likely to be a secondary. That is the first thing that is only telling you. That 80 may not be true, but that it is secondary is very, very important. Next. Next. So basically, if you see, there are many causes of lymph node enlargement, but we could put it as inflammatory, neoplastic, and miscellaneous. Next. So inflammatory nodes, in a very simple way, we can divide into acute and chronic. Again, specific and non-specific. Acute specific can be something like infectious mononucleosis. Acute non-specific is most of the time you're going to get children with non-specific nodes because of infection in the teeth, gums, tonsils, etc. That is acute non-specific nodes. Chronic specific, most common is tuberculosis. Chronic non-specific is acute persisting. Remember, in many people, the nodes which enlarge acutely do not disappear. They may still remain. Okay. Next. Now, when you take the causes of lymphadenopathy, there is a mnemonic MAIM, which is malignant, autoimmune, medications, and I is infections. There are huge number of causes. You need not actually bother about, but just to be safe, common things are common, but always keep in your mind, sometimes some rare thing may come across. You may have a Kaposi sarcoma, or it may be a sarcoidosis, or even some medications can produce lymph node enlargement. Next. In infections, see, huge number of infections can produce lymph node enlargement. This slide is just trying to tell you that lymph node enlargement in the neck is not sometimes very simple. There can be a huge number of infections that can cause it. Next. So in your diagnostic approach, history, physical examination of the node, I'm not going to deal with that because we have a case. Basic is to do a blood count, X-ray and a Mantoux. Ultrasound of the neck is very important to see the number of nodes and the characterization of the nodes and which node to do an FNAC for. CT and MRI are done if your FNAC is showing malignancy, to check for local spread, and PET CT to find out where the primary focus is if you have diagnosed a metastasis. So this is a basic workup from an investigative point of view of the node. But remember, I'll come in a subsequent slides to telling you about the primary. Next. Just a word or two, a few seconds. Sometimes this node may come as something called Kikuchi's disease. Nowadays, this is becoming a little common, but remember, it's a very rare condition. It has also been reported with after COVID infection and after COVID vaccination, but it resolves in 1 to 4 months. So it's a benign condition. Next, there's another condition called Castleman's disease. It's a rare, again, lymphoproliferative disorder, may be associated with HIV. It may be single or multiple nodes. And again, this is a rare condition. But remember, some of these conditions which you think may be tuberculosis or maybe non-specific are coming as Kikuchi and Castleman. Next. Now, this is very common. So a few slides on TB. Second most common site of TB after the lungs. Predominantly, it occurs in young adults. Remember, TB nodes can present in any way. It could be single, firm nodes. It could be matted nodes. It could be atrophic nodes. It all depends on the stage and the immunity of the patient. Next. So this is the staging called Jones and Campbell staging, which divides it into stage 1, 2, 3, 4, and 5. 1 is the stage of lymphadenitis. It is single, mildly tender node which cannot be diagnosed as TB. It may like any other lymphadenitis. The second stage is the stage of periodenitis, when there is inflammation spreading to the capsule and clinically it is matted. So that's the diagnostic sign of TB, matting. Third is cold abscess, when caseation occurs and it softens. The fourth is a collar stud abscess, when it erodes through the deep fascia and comes out under the skin. The fifth stage is the stage of sinus formation. What was the old name for TB nodes in the neck? It was called scrofula, and the sinus was called scrofuloderma. It used to be called next. So this is the stage 1, single node in the posterior triangle. Next. This is, you can see, matted nodes. 2 nodes are joined together. Next. Here's a patient with a cold abscess, level 2. Next. And here's a patient. In front, there's a lymph node. And at the back, there's an abscess, which is collar stud abscess. Next. This is an ultrasound picture of a node which is caseating. Next. So in TB, this is showing a node that is showing a cold abscess and pus is being aspirated. Next. So what do you see on a section of a node? You'll see multiple areas of yellowish white, cheesy white material because of caseous necrosis. And what is the typical histological picture of TB? Can anybody tell me? Yes? Central caseous necrosis surrounded by epithelioid cells and Langerhans giant cells, not Langerhans. Langerhans giant cells, okay? You must always say central caseous necrosis surrounded by epithelioid cells. You can see in this slide. And the stain is called Ziehl-Neelsen stain. So central caseation surrounded by epithelioid cells and Langerhans giant cells. Next. So this is the histological picture. Next. How do you treat TB? This is the latest guidelines. New case, previously treated case. New case, INH, rifampicin, isoniazid, ethambutol. HRZE, 2 months, followed by 3 months, 3 drugs for 4 months. 4 drugs for 2 months, followed by 3 drugs for 4 months. The second half, the second 4 months, you stop pyrazinamide. If it's previously treated, you add streptomycin for the first 2 months and 1 more month without streptomycin and then 5 months of HRE. That means the total treatment increases by 2 months. So what is previously treated? A recurrent case, failure. The recurrent is somebody who is treated fully but come back. Failure is treated fully but failed, lost to follow up or undocumented. This is the latest schedule of treatment of cervical node tuberculosis. Next. If you have a cold abscess, we aspirate by non-dependent by Z technique under cover of anti-TB drugs. You can aspirate at weekly intervals, 3 times you can aspirate. But if it still recurs, you may have to open, drain it, scrape out the nodes and close it. Don't leave it open, don't put a drain. Next. Now we come to the neoplastic nodes. Neoplastic nodes could be primary or secondary. Primary, we have the lymphomas and the non-Hodgkin's lymphomas. Now, if a node is a secondary node, it is a good thing if you can't find anything to get an FNAC done because that will tell you the cell of origin. If you do an FNAC for a secondary node and you find it's a melanoma, one of the areas where you look for the primary is the eye. Because apart from skin of the cheek or the tongue, the eye may be the primary. Second, if you find it's a papillary carcinoma, look for thyroid. If the thyroid is not enlarged, they used to call it before lateral aberrant thyroid. What is lateral aberrant thyroid? It's a metastasis from a papillary carcinoma. Then, if you find adenocarcinoma, think of a primary in the salivary glands. If salivary glands is not present, look for elsewhere in the body, like lung, stomach, colon, ovary, etc. And if it's squamous cell carcinoma, next slide. We'll come to squamous cell. See, lymphomas, apart from Hodgkin's, there are huge number of non-Hodgkin's, different types. You remember there are so many types, very rare. Next. Now, Hodgkin's has been divided into the classical Hodgkin's or the nodular lymphocyte predominant Hodgkin's. The difference is in classical Hodgkin's, you have the Reed-Sternberg cell. In nodular Hodgkin's, you have the popcorn cells. And classical Hodgkin's is divided further into nodular sclerosis, lymphocyte rich, mixed cellularity, and lymphocyte depleted. These four. Next. This we'll skip. Next. 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 So those were showing you all the different types of non-Hodgkin's. Well, now what's the Ann Arbor staging? Ann Arbor staging divides into 1, 2, 3, and 4. Single group of nodes is 1, or single extra lymphatic site is 1E. 2 or more nodes are 2, or with 1 node and 1 extra lymphatic is 2E, or 2S is 1 nodal site and spleen. Similarly, spleen comes into 3. When you have nodes on either side of the diaphragm is 3. If it involves the liver, bone marrow, lung, CSF, it's 4. Okay. Now, A is absence of symptoms, B is symptoms. Symptoms include weight loss, night sweats, fever. Okay. Next. What are the investigations in lymphomas? Node excision is preferred to FNAC. FNAC will not give you a diagnosis. And even after node excision, you may need to have an immunohistochemistry. X-ray chest, CCT of chest, abdomen, and neck are mandatory. Neck, chest line, PET scan is also recommended. Today it is said with a good PET scan, no bone marrow biopsy is needed. Today it has been given up in all the guidelines. Only bone marrow is to be done if PET is not available. Next. These are the blood tests to be done for patients of Hodgkin's. Next. And when we come to treatment, it is divided into early stage, favorable, early stage, unfavorable, advanced stage. Very simple. Early stage, favorable, 2 cycles of ABVD, 20 grays radiotherapy. Early stage, unfavorable, 4 cycles with 30 grays. So 2 cycles, 20 grays, 4 cycles, 30 grays. And if it's advanced stage, only chemotherapy, either ABVD or BACOP. No radiotherapy, only for residual disease. So radiotherapy, remember radiation is only given for localized disease. Radiation cannot be given for generalized disease. Next. So ABVD is adriamycin, bleomycin, vinblastine, and dacarbazine. And BACOP is bleomycin, etoposide, doxorubicin, cyclophosphamide, vincristine, procarbazine, and prednisone. These are the 2 regimes you remember. Next. Secondaries in the neck, I already have told you this. Squamous cell carcinoma. Next slide. So the left supraclavicular node was described by Rudolf Virchow. It's called Virchow's node, or we can pronounce it as Virchow. The sign enlargement is called Troisier's sign. Next. So if you have a patient of squamous cell carcinoma, open the mouth. There are 7 subsites you have to look for, which are the buccal mucosa, lip, alveolus, floor of mouth, tongue, palate, retromolar trigone. If that is negative, it could be a hidden carcinoma or occult, which you look for the nasopharynx, posterior 1/3 of tongue, epiglottis, pyriform fossa, postcricoid, and upper esophagus. Look for these hidden sites by doing a nasopharyngoscopy, laryngoscopy, esophagoscopy, and taking a biopsy. Next. Next. So staging, just remember in size 0 to 2, 2 to 4, and greater than 4, and involvement of deeper structures T1, T2, T3, T4. And in nodes, it is up to 3. Next slide. 3, up to 3, 3 to 6, and greater than 6. Now, next. So it is divided into stage 1, 2, 3, 4. T1, N0, M0 is stage 1. T2, N0, M0 is stage 2. The minute a node comes, it becomes stage 3. Okay, remember that. Next. But today, the latest classification includes these two: depth of invasion and invasiveness, extranodal extension, which could be clinical or pathological. Just remember these two, need not go into more details. Today, they have included depth of invasion also as a prognostic factor, as well as extranodal extension. Next. Okay, we'll skip this. Next. 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 Okay. Now, in treatment of nodes, one of the only places in the body where you do prophylactic neck dissection is dissection of nodes is in the oral cavity, cancer. Otherwise, nowhere in the body, you prophylactically remove nodes. There are different types of neck dissections. Next. So, if there are no nodes, you can give for floor of the mouth, lower alveolar ridge and tongue, you can still give do neck dissection. Why? Because it has been found that 50% of nodes have some metastasis, even though they are not clinically enlarged. And if there is metastasis, the prognosis goes worse by 50%. So in these areas, you can go ahead with a prophylactic dissection. Next. So there were different dissections described: radical, selective, or limited. Radical neck dissection, I'll just show you a picture, is removal of all the fat, fascia nodes from the mandible above to the clavicle below, from the midline in front to the trapezius behind, including the internal jugular vein, the sternocleidomastoid, and the spinal accessory nerve. That was radical. Next, in the selective, you've got the supraomohyoid, or remember, radical, you'll remove 4 or 5 node levels, selective 3 node levels, limited 1 or 2 node levels. Next. Various incisions have been described. Next, including an incision with 2 horizontal. Why this incision was described? Because in all that Y and T, sometimes necrosis would occur and the vessels would get exposed. Next. So this is the extent of radical neck dissection. Next. And modified neck dissection is divided into 3 types. In type 1, you preserve the spinal accessory nerve. Type 2, you preserve spinal accessory and internal jugular vein. And type 3, spinal accessory, internal jugular vein, and sternocleidomastoid. Next. So this is a picture of a patient who has had a radical neck dissection. When all the fat and fascia is removed, remember, the vessels and all are exposed. So you cannot afford to have necrosis of the skin. Next. Now, how do we cover a defect? Suppose there's a cheek or something where you removed a tumor. The most common is a pectoralis major myocutaneous flap based on the thoracoacromial artery. You can see on the left the contour of the flap. That pink shaded thing is the flap which is taken and turned up. Last slide. Next. So this is a patient in whom a flap has been done. The incision has been taken. The flap has been rotated to cover the defect in the cheek. So this is called a pectoralis major myocutaneous flap. Next. Thank you. I've tried to cover as much as I can in short time. Thank you.
Next case presentation by Chennai Medical College. Diabetic foot ulcer. Please come on to the stage.
We honor the
certificate to the Professor Vincent Narona by Professor Anandi Madam and Dr. Kannan sir. Thank you.
Professor Uttar Kumar. Our pair board.
So, a 48-year-old male, Mr. Muthu, who is an electrician from Krompet, presented to male surgical OPD with the chief complaints of ulcer on the left foot for the past 20 days. Patient was apparently normal 20 days back, after which he sustained a cut injury in his left foot due to motorcycle accident. The wound did not heal and gradually progressed to the current stage over the past 20 days. He developed an ulcer in the great toe of the left foot and swelling over the left foot medial aspect, that is medial aspect of the left foot. and patient had pus discharge from the wound 2 weeks back. No history of fever, history of pain for the past 1 week, which is insidious in onset and progressive in nature with no radiation, aggravated on movements. Patient was admitted 2 weeks back in a private hospital and was treated for his illness. Surgery was done, that is left grade 2 amputation with wound debridement with IV antibiotics. Then patient came to our hospital for further management of his own wound. Patient is a known diabetic for the past 4 years and is on oral hypoglycemic drugs on regular treatment. Patient doesn't have history of hypertension, asthma, TB, coronary artery diseases, and thyroid disorder. So a 48-year-old diabetic patient with the history of post-trauma, non-healing ulcer over the medial aspect of the left boot for the past 2 weeks with associated serous discharge and pain.
So, can I have that summary? Okay. What is an ulcer?
Sir, it is a discontinuity in the skin.
Nalla solliya.
Discontinuity in the skin.
Discontinuity?
The skin or the mucous membrane.
The skin of the mucosal membrane. What do I say? Define an ulcer.
அது இன்னும் கொஞ்சம் ரிஃபைண்டா சொல்லுங்க. கரெக்டா தான் சொல்றேன்.
Where
Where is the discontinuity happening?
எல்லாத்தையும் சேர்த்துட்டேன்.
Combine it and make it as one sentence.
It is a discontinuity in the skin or mucous membrane with associated with granulation tissue.
That skin disruption in the skin or mucous membrane epithelium. That's it. Okay.
Any breach or any discontinuity in the lining epithelium of the skin or the mucosa is called as an ulcer. Okay. Right.
So what is an erosion?
Erosion.
Is there a term called erosion?
Yes, sir. Imaginating into the deep
Erosion.
structures.
Erosion. Can you define erosion in a skin?
Imaginating
Okay,
into the
it
deep
is according to the depth of it's also discontinuity. It's also a discontinuity, but it's the depth of penetration of the wound. So can you, now I gave you a clue, you can tell me the depth. What is an erosion? What is a ulcer? In an erosion, the basal layer is intact. You have the 5 layers of the skin, isn't it? From basal, then you have keratinous, I mean, what is that? Spinous layer, all these layers, and then you have all the layers, isn't 5 layers. If the basal layer is intact, you call it as erosion. If the basal layer is gone, you call it as an ulcer. Why? What is the difference?
Sir, spreading ulcer may cause further cellulitis.
If the basal layer is intact, it can heal by itself. You don't need any support. You just need to observe, and if there is an infection, give antibiotics or whatever. Whereas if the basal layer is not intact, that means you have to assist the wound to heal, like suturing or grafting, whatever. So that's the difference between an erosion and an ulcer. You should know the difference so that you plan the treatment. Okay. So what diabetic foot, what is the main cause of your pathology?
Sir, microangiopathy and atherosclerosis, then neuropathy, then infections.
Yes,
cause
you're
due
right,
to
you're
increased.
So neuropathy, what type of neuropathy you are looking for?
Peripheral.
Peripheral neuropathy. So how will you test the peripheral neuropathy?
The motor component or the
What are the
sensory
components?
component?
What are the components of neuropathy, and what tests will you do? How will you test for a sensory neuropathy? Okay, there is sensory neuropathy, there is motor neuropathy, there is autonomic neuropathy. How will you test sensory neuropathy?
Sensation over skin can be tested with a cotton wick and sharp pointed eyes. See the deep and superficial.
Sharp point means what sharp point you'll use?
Microfilament.
What?
Microfilament.
Yes, microfilament. What microfilament we use? There is a size. There is a size. So 4.17 is the size of the monofilament. It's the nylon monofilament, which is used to test the sensory neuropathy. What does that do? It displaces certain amount of tissue when it presses. So if it is able to press 1 gram of tissue, the normal person is sensitive. Whereas for a neuropathy, even 10 grams, that is the 5.07, if that is used, even then there is no sensation. So the main cause is repetitive trauma in a diabetic patient. So there is, if you have to sense other things, you can see autonomic neuropathy, you can see dry skin, all that. Then the other thing is motor neuropathy. What happens in motor neuropathy? Motor neuropathy, the intrinsic muscles are supplied by the intrinsic muscles undergo atrophy. So the extrinsic muscles take over. So there is a deformity, like clawfoot deformity. So where the metatarsals have become more prone, and they are more prone for ulcer. So you should know this component of diabetic foot ulcer.
Okay, tell me, what are the causes of ulcer?
Ma'am, it can be pathological and clinical. Pathologically, it can be specific, like
Tell me some specific ulcers.
tubercular, syphilitic ulcers, like that. And other non-specific ulcers, ma'am, which includes venous ulcer, arterial ulcers.
Okay, what are the clinical types of ulcer?
Clinically, spreading ulcer, callus.
Okay, what are the parts in an ulcer?
We have edge, margin, and the base and the floor.
Okay,
so
what are the different types of edges in an ulcer?
Sloping ulcer, then punched out ulcer, undermined ulcers.
Can you give one example for each?
Tubercular ulcers have undermined edges.
Yes, you're right.
Then healing ulcers will have slopy edges.
Yes, yes.
Where do you get a raised edge?
Raised edges in squamous cell carcinoma.
Okay, and a rolled out edge?
Basal cell carcinoma.
Okay, so your patient has got a diabetic foot ulcer. Okay, so how do you plan to manage?
First, we will control the hyperglycemia.
Okay.
Then wound debridement.
Okay.
Then IV antibiotics, broad spectrum antibiotics till the culture sensitivity comes.
So what is the commonest organism you find out in a diabetic foot?
Staphylococcus, Streptococcus, beta hemolymph, then pneumococcus.
Okay.
Tell me the three concepts of diabetic neuropathy which needs to be controlled. One is neuropathy itself. The other is infection. The other is angiopathy. So how will you control infection? How will you control angiopathy?
For infections, we'll just give antibiotics.
Okay, you'll do a culture sensitivity and antibiotic. Then what happens to the arterial problems?
To rule out arterial pathology, we have to take
what are the
arterial-
main vessels which are affected in a diabetic foot? Main vessels affected in a diabetic foot. Okay. What are the vessels in the foot which are in the leg and foot which is affected in diabetic angiopathy?
In case of arteries, dorsalis pedis, then posterior tibial artery.
The tibial
then
vessels and
dorsalis.
the peroneal vessels. These are the vessels which are affected. Supposing if they are affected, you will have to go for some form of restoration of arterial supply.
Okay, what are the investigations you want to do in a person with a diabetic foot?
First, we'll do the routine investigation.
Okay, done.
Then
What are specific investigations after routine?
Take X-ray foot.
X-ray foot. What do you want to look into it?
To rule out osteomyelitis.
Okay, good.
Yes. What is the importance of, supposing you find osteomyelitis, what will be the difference?
Rapid spread. So when it's a case of osteomyelitis, you'll have to go for an amputation of the organs. in the next
Amputation.
joint.
So you find an osteomyelitis, you amputate, is it?
What is
There's
the
a
treatment
there's
for
a spread in the-
osteomyelitis? All cases, do you go for amputation?
If there's extensive spread in the bone tissue, we go for amputation.
First, you have to see whether your bone can be salvaged or not.
Salvage is the most important.
Okay, if it's salvageable, you can do saucerization, sequestrectomy, all those things can be done. If not salvageable bone, then you go in for your amputation and other things. Okay, right. You have an ulcer in your pressure points. What are the pressure points?
Sole of the feet,
Entire sole.
heel of the feet. Heel of the sole.
The heel, the ball of the great toe. These are the pressure points. If you have an ulcer in the pressure points, what kind of a dressing you like to do? How do you avoid this pressure?
In other words, what is offloading?
It is called as an offloading dressing. Okay, we'll put a dressing in such a way that that part of the ulcer doesn't come into contact when you
Will
land
give,
your foot down.
negative pressure.
What, ma'am?
Will give negative pressure.
Negative pressure is vacuum assisted
Vacuum
dressing. That is you're trying to tell me. The question was, what is offloading devices? Okay, so that when you land on your foot, your ulcer part doesn't come into contact with the ground. It is going to be somewhere in the air, so that your pressure is not going to be dissipated onto the wound. So that will allow the wound to heal. Do you know what is Wagner's grading in an ulcer?
Tell me the grades.
0 to 5 grades.
Okay.
It starts off with no, there's no ulceration in the first. The skin is intact. Stage 1 has a superficial ulcer. Stage 2 has a deep ulcer with no abscess. Stage 3 has an
The
abscess.
deep ulcer, which is involving the tendons, the muscles, and the bones.
Yes, ma'am.
The third one only, deep ulcer with the abscess. Then
Stage 4 has gangrene.
involving
Just a part of the foot.
Okay, the
Stage
forefoot.
5 has an extensive gangrene involving the entire limb.
Okay, good. Right. What do you mean by debridement?
Cleaning of the slough, ma'am, till we find a healthy tissue.
Come again?
No, what is debridement? Debridement.
Actually, it is debrima, the pronunciation. Since we have got adapted to Indian pronunciation, it became debridement.
We can call it as debridement, no problem.
Yeah.
Cleaning of the dead tissue till we find the healthy tissue.
Yes. So what are the modes of debridement?
What are modes? MODES.
Modes.
Methods.
How many types of debridement are? One is your mechanical, what you do surgically is
When you
mechanical.
surgically remove, we call it a mechanical debridement. What are the agents which will assist you to do the debridement? When you want the slough to be peeled out, when it's good, Usol. What is Usol?
Edinburgh University solution.
What kind of an agent it is?
Chemical.
Yeah, correct. It's something like a chemical agent. What are the other chemical kind of agents available for doing debridement? So that's another method is called as a chemical debridement.
Betadine.
Betadine. Betadine is
Betadine should not be used actually.
it's not a method for debridement then.
What is enzymes used for debridement?
Any papain based debridase, heard of it?
You haven't heard of it.
Okay.
So what is then water pump? Can it be used? Water pump can be used? No. Yes or no? Don't know. Okay. What is biological debridement?
Any something, some agents like flies,
Flies
which will help you to debride the wound.
or puru puchis,
Pulu puch. Heard of maggots?
Maggies.
Not Maggie, maggots. Okay, maggots
You
helps
eat
to do
Maggie,
a
don't you?
debridement.
Okay.
Tend to remove all the dead and devitalized
Of
tissue.
all this, which is the best device to remove the devitalized tissue of all four or five we talked about?
Chemical.
It's the maggots which do the best job. So what fly they derive the maggot from? Any idea? Okay, it's a sand fly. That's fine. Okay.
Okay, if your person has got an entire limb which has gone in for a gangrene. Okay, what are the types of gangrene? Define gangrene.
It's a dead tissue due to cut off of either in blood supply, either injury or.
It is a macroscopic death of a tissue. Okay, when it's going to be visible, you say it's a macroscopic death. Okay, fine. A person has got a limb which is gangrenous, almost involving up to the forefoot. Now what you are going to do? What are the other investigations you want to do? You had done only an X-ray.
We have not gone to the investigations.
What are the other investigations you want to do?
Arterial brachial pressure index.
Good, good.
Wonderful. Then?
Can you tell me what it is? Solle.
Okay, ABPI, ankle pressure by
Pressure,
the
brachial index.
pressure.
Okay.
What is a critical limb ischemia?
Less than 0.9.
What is the normal volume? Ratio, sorry. It's a ratio.
0.9.
Ankle pressure, brachial
Yeah,
pressure.
0.9 to
1.1.
1.2. Okay, anything going to be above 1.2? What will you think of? Is it normal or abnormal? If it's abnormal, well, if it's going to be below 9 also, it's abnormal. Above 1.2 also abnormal. Then what is the difference? So above 1.2, usually you think in terms of an atherosclerotic vessel, wherein you'll not be able to compress it. Okay. If you're not able to record the ankle pressure, what other pressure can be used? If there is no gangrene in the foot, any other pressure can be used? A toe pressure can be used. When you're going to use this pressure, you can determine the vasculature flow. What is the flow which is happening in your
The refilling time.
limb, right? Okay, what are the types of amputation you know in the lower limb?
We start from ray amputation.
Start from disarticulation of one first toe, then next level like that. You come up. Till removing the entire lower limb. What are the levels of amputation? When you remove the toe, what is it called as? Disarticulation. When you remove the toe along with the head of the first metatarsal, you call it as what? Or the metatarsal race amputation. When you remove at the level of the metatarsals, it's called as a transmetatarsal or a Lisflank's procedure. Okay, still more somewhere around the ankle joint. Any other procedure you heard of in orthopedics? Science amputation, below knee amputation, through knee amputation, above knee amputation, hip disarticulation, and finally hindquarter amputation. These are the various levels of amputation which are going to be present in your lower limb. Okay, fine. So our patient has got a diabetic foot. Now your patient, you need to do a dressing. Patient has got a good wound which has healed properly now. Now what do you want to do for the ulcer? Which has healed, there is a good granulation tissue.
Skin grafting.
Skin grafting, wonderful. How does a grafting receive its blood supply?
There's no blood tissues involved in this.
Okay, in that case, how does it receive the vascularity? What is that method called as?
What is mechanism of diffusion?
What are the stages? Some neovascularization, something like that, which is happening there? Never heard of it. Imbibing, inosculation. Okay, when can you put a graft? When can you put a flap?
Based on how Graphs are more prone to infectious recurrence.
Mike.
So grafts are one which can be used only when you have a good amount of a granulation tissue. But if you have a tendon or a bone which is going to be exposed, you can't put a graft over it. It will not take up. And grafts are not suitable over joint areas. Okay.
So what is epidermal graft, dermal graft, composite graft?
Based on the layer of skin we are involving in the graft. Based on the layer of skin we are involving in the graft.
Epidermal graft, what are used? Dermal graft, what are used? What are the cells which are used? And composite grafts, what are the cells used? What is? Okay. So, okay.
Sir, இவங்க மேல வந்துருங்க. மேல வந்துருங்க. Next, may I call upon Dr. Kushal Mittal, the Dynamic Honorary Secretary of Association of Colon and Rectal Surgeons of India. He is with us now. He is all the way from Thane, and every 3 months he is conducting the minimally invasive proctology training course in all corners of India, especially in Mumbai and as well in Chennai. Every 3 months he is conducting the program. It is one of the high taken program by all the general surgeons and the proctologists and as well as the surgical gastroenterologists. You know, the bread and butter of the general surgery practice is piles, fissure, fistula, and hernia, hydrocele, and then finally cholecystectomy and appendicectomy. So Sir is one of the pioneer in the minimally invasive proctology, and as well as he is the well-known trainer for the surgeons. So he is teachers of teachers for our budding surgeons and as well as surgeons all over the country. Sir, is it ready, sir?
So after this program, there will be quiz. So those who are appearing for the quiz, stay back and finish the quiz. Quiz will contain some 30 questions and it will be just 15 minutes duration.
Hello, check.
Hello. Hello. Put this on. Can you make it loud? It doesn't have pointer doesn't. Can you ask him? Put to my presentation. I'm sure you're all tired by now. Yes or no? So we do, in my training program, we do exercises before the next lecture. So I want you to release your pen and go like this, hand forward. Okay? Keep moving. Those guys there, madam, your friend is not doing it. Right? Up. Now, hold this and stretch. Make a noise. And in front. That feels good. Side. Those guys there. Okay, one of the things my teacher taught me, your friend is not doing it, they should sign their name. Right? I want to sign your name by your hands. So, sign. Now, hold this. Okay. Make a noise. And in front. That feels good. Now the shoulder. Side. Those guys there. You're taking shortcuts. Full name. Left hand. Sign their name. Right? She's not doing it. She doesn't know how to sign. Elbow. Okay. Shoulder. Those who have small signatures are good. Now, make the blood run to your head. Now, make the blood run to your head. Got it? My pointer. Huh? Huh? Now, so I'm going to all of you are going to become surgeons. Yes or no? And also we'll try to do a specialty. And after that, so what remember when I put better surgery, 40% are going from door to door. All of you are going to become good. Yes or no? You can diagnose it well, manage it well.
Annual diseases is, it gives you a big practice and gives you lots of money to keep your family healthy, and then you can practice small things otherwise. The beauty is, most of the problems you can see. You can see the external hemorrhoid, you can see the skin type, you can see the fissure, you can see the anal warts, you can see pruritus and eye, you can see the abscess and the fistula. So all these things you can see, and it's all visible, and these are the conditions that you look into. And family health symptoms, as you know, think about it. The patient is with bleeding PR, pain, discharge, mass at anus, something coming out, pain and nasal blood, pruritus eye, and the pressure, you see the anal ward. You say, why is it dying there? And the reason is there is the patient visible, and these are the conditions that you solve the problem. Or there is a symptom, as you know, is think about it. Something coming out, pain and mental pruritus eye, and the pressure, you say, why is it dying? If the patient has you should make it visible, and these are the conditions. If it's a painless, I know, think about it, if it's a painful, something coming out, pain and mental why is it crying? And this goes into the and these are the bleeding PR, painless, and they are present in the party of the cell. And these are the so when it is the color of the something, so you know that blood is bleeding from and right there is bleeding from everything else will need to think about it. So when it put leading PR the second one that think of PR picture, and the third one is you always the second one that if it's there, so pain dedication is allowed. You think of motion if it was it could be from the anal region, from the pyloric region, it could be anal abscess, anal fistula, anal ulcers, spontanema, inguinata. It does, it's recoiled into the external opening with motion and staining. Anal perianal masses, What are the muscles you can see in that area? This is a differential diagnosis. Collapse and thrombosed hemorrhoid, skin diaphragm, fibula, and polyp, anal abscesses, cancer of rectum and anus, sebaceous lipoma, anal. These are the common. Don't go beyond this. Anal masses, does it appear in the motion or it's always there? So you have this one which appears at motion, the first one. And the second one is always there because it is external thrombosed hemorrhoid. The one on the right top, this one right top is anal abscess and the discharge you can see. So is there pain and discharge? So this patient is a 56-year-old male bleeding PR. There's a big mass and patient is unable to pass motion. So diagnosis is obvious and grade 4 hemorrhoid usually unusual. So something coming out of the uterus. This is really important, and as a postgraduate and as a student, these patients need to be put on top of a clinical examination table after passing motion, squatting position, keep a bowl under it, and tell the patient to straight. What do you get? This is the patient's training, and what I get is the grade 3 hemorrhoid. That's it. And the patient, why I say grade 3? Patient has to put it back with the finger, it doesn't go back in on its own. It could be larger, but it's just to demonstrate that reduction is grade 3. This patient said, I have taken hemorrhoid operatory, and on examination in the squatting position, when the patient is trained, you have the whole rectal collapse coming out. So you have to remember, every patient who says they have hemorrhoids may not necessarily be a hemorrhoid. This is a child of 10 years. His parents got him, my child has hemorrhoids. On examining him and on telling him to apply pressure, it was a rectal. You have to finish it. Follow. The patient on the left is a patient who has rectal cancer. He came for hemorrhoids for 1 year and bleeding PR. On examination, there was nothing on PR examination. On proctoscopy examination, the hemorrhoids were normal. Then what was coming out? But there was blood and mucus in the rectum. So I told the patient to strain, and this cricket ball size mass came out. That was CA rectum. Needless to say, the patient went for radiotherapy, chemotherapy, and then ultra low anterior section was done. And this lady on the right, she has got hemorrhoids with prolapse. Now, when you tell the patient to strain, this is what happened. She was comfortable, and when she strained a bit, I could see hemorrhoids grade 3. Why grade 3 here? Even grade 2 circumferential. And when she relaxed, so it was not tri-compartment syndrome, her vagina was also out. Next slide. So incomplete evacuation could be rectal prolapse, hemorrhoids, CA rectum, and picolates. We need to take care of them. Rectal prolapse has to be driven by hemorrhoids. Rectal prolapse are concentric rings, and hemorrhoids are blocks, 3, 7, 11 blocks. It's really different. Then CA rectum being the lower third, you may be able to palpate. If it's higher up, you won't. You get it on sigmoidoscopy or colonoscopy. And picolates are a big problem. These patients come to you saying that I've got a mass, I'm passing lots of stool. Every 10 minutes I pass 10 ml stool. That is spurious diarrhea because the picolate is blocking everything. The liquid motion is coming from the side to the bottom. So pruritus and you really don't think about it. These patients are in agony, they scratch themselves all day long and at night. So you have to look locally what's wrong. Is it a midwife discharge from hemorrhoid infection, top of figures, or is it possible to try and Then, is it yeast infection involved or allergic toilet paper? You have to take care of this. And then it doesn't help, then you have to go in for further treatment, which is an advanced treatment. That is, we inject vitamin blue into the skin, and that that helps in healing. Fecal incontinence, you have to ask. Why the patient has fecal incontinence? Impaired ability to control and release of gas and stool at the desired time. The usual cause is trauma by the surgeon or trauma by the gynecologist. And this is a big list. I don't want you to see it, but I would want you to focus on inflammatory bowel disease, functional bowel disease, anorectal disease, fistula, trauma of various types, obstetrical trauma, anorectal surgery, accidental trauma. That is the surgeon is getting them. So you need to know how to manage these patients. And never forget, when you are looking at a patient who has an anal problem, never ever forget to ask how the stools are. And Bristol stool scale is a wonderful thing. Type 1, 2 are constipated, and type 6 and 7 are diarrhea, and 3, 4, 5 are various ways of normal stool. So perineal mass, always examine spotting. How do we examine these patients? Inspection, examine, palpation, endoscopy, sigmoidoscopy. The eye sees what the mind knows, and I want to train your mind in the next 10 minutes. So examination of anal column. If you're writing down, make an oval shape on your paper. That's the anus. Then make 2 lines. 3, 7, 11 are obviously employed. Internal and external. 12 and 6 are missional. And skin tag and 12 and 6. The confusion occurs when there is external influence and also skin tags. They are next to each other. They'll be next to each other. That 12 o'clock next, and that's why you're wondering what it is. Then you have the fistula. If the fistula is anterior, then it goes to the anus less than 3 centimeters, it will open directly. If it is away posteriorly, it will open directly at 6 o'clock. If it's again either side 6 o'clock, and if it's further away more than 3 centimeters, it will again come to 6 o'clock. And apart from this, in the end, you must see the nasal cleft for minor sinus disease, which is often ignored when you see these problems. Now, the question I wanted to ask you were, what are these 2 lines? This one and this one. Why you want to know these lines is really important. It bears surgical technique. If you have a fistula here, you operate like this, you go all the way up and you cut. But when you repair it, the muscle is only till here. Only this much is the muscle. Everything else is just fat. So you have to do a primary sphincter repair. That line represents the outer border of external anal sphincter. That's the outer border of external anal sphincter. Then, when you are inspecting the anal beacon, diagnosis is on the right. Just looking at the left, perineal discharge, bleeding perineum, skin oxidation, cellulitis, external fistula opening, scar of previous surgery, infestation. Patient is in left lateral position. I like to examine in front, but I'm showing left lateral position. You have to examine 4 areas: the anus, the perineal area, the perineum, and the gluteal folds. Then you say my anorectal examination is complete. Gluteal folds for external opening of a fistula. So inspect, do a PR examination, do a proctoscopy. If you examine in front, you don't even need to touch the patient. We are obviously going to do a PR. The light is from above, the patient is pulling their buttocks on their own. The vision is good, especially if the patient is bad. See how the vision is. So the diagnosis here is grade 3 hemorrhoids, the left picture, and the right picture is a fistula and left picture thrombus, external hemorrhoid. Middle picture is fistula, and the third picture is scarring because of fistula and a recurrent fistula. When you see a patient like this, you start to wonder, what does she have? She looks normal, but you need to stretch it. And when you stretch it, you see that he has a 4-degree perimeter tear. That's only when you get to know the degree of tear. So digital rectal examination is like a stethoscope for the heart and a stethoscope for the surgeon. So when you put your finger in, read the alphabets. You can see pelvic movement, rectal cancer polyp. You can feel the wall. Is there any duration? You can feel behind the rectum. You can feel in the pelvic floor. You can feel above, in front of the rectum. That is, in female, you can feel the cervix, and in male, you can feel the prostate. It's important to feel that because sometimes you will be. I have felt masses in the uterus when I was in the PRN, but rule out the cancer. And then prostate, you always need to know it. Even if you're doing a PR examination because of an NM pathology, you need to know the size of the prostate. And you will see above the rectum. So mandatory for digital rectal examination. These are the really important points. Explain to the patient what you're doing. Have a sense of privacy, whether to female or female. Safety, for this omega, always like now. Position, left hand position on floor. Exposure, undress to base midnight. People undress just a bit. The bed is giving the way to one of those spread. You will miss. Good line is a must. Assistant, your assistant should also be gloved. Dignity. Don't talk on the phone. Keep your phone off the hook. Don't address anything. Intercom has to be closed. Mobile has to be shut. Talking to someone else is not good. You have to figure it out and talking to somebody. That's wrong. And the door is locked. In mentioning females, you can either record it or you can cover the area. Obtain a written consent even for OPD. This is a law. We don't do it. I know we don't do it. Nobody does it. But if somebody came down and really went out, it's an invasive procedure. So when you have a patient examining like this is the angle that makes for sense. The lower button inside the examining table, there should be a gap between the upper portion of the table and the wall, and always cover the table. Do not examine it like that. When you're doing, don't put your finger in. Be general. Go see the bigger picture. You have to go from one side. Don't put it in like this. You got to go from one side. So hemorrhoids are the PR, I've just told you. And these are the internal. On the left side, you see the internal hemorrhoids and external hemorrhoids large. Right side is normal. Your pointer. Does it have light? Light. I wanted for light because it's not working. Okay. Yes. Because I'm able to point. Inspection for prolapsed files. PR. When you do a PR, you'll only see thrombosed hemorrhoids, nothing else. Proctoscopy to know the hemorrhoids. So the hemorrhoids are in the proctoscope is grade 1. And on staining doesn't come out, is grade 1. Sigmoidoscopy, colonoscopy. Now you are on hemorrhoid type. This is only external hemorrhoid. Internal hemorrhoids only. And when combination is there, this is the usual finding you will get. It's a mixed hemorrhoid. Okay, why does it bleed when you have this? Because the hemorrhoids are here, stool, hard stool is going down. The mucosa is gray over and it starts to bleed from there. So you have various grades of hemorrhoid, grade 2, and there's a thrombosed hemorrhoid. Again, you have grade 3, and this is grade 4 hemorrhoid. So it depends. So you need to know what is causing hemorrhoids and why the problem is there. If you show this picture to the patient. They understand why hemorrhoids are formed. And it's an animation, it's a beautiful, simple animation. This is the stool which is coming down. And the stool is unable to come out. So what you do is you're straining and straining and straining. What happens with straining is the hemorrhoids, the normal anal cushions, they start to become larger. They become larger in size, and gradually as it comes down, they become big. And when they become big and the stool passes, they will also start to bleed. So this is what we have to prevent. We have to prevent straining. So your treatment is focused on preventing straining. And when straining is prevented and stool is soft, this problem will go away. So symptoms are painless bleeding PR, mass per rectum, discharge, pruritus, pain only triangulated or thrombosed hemorrhoid. So why is it? Because of constipation and straining disrupts the framework of cushions and displaces the hemorrhoid with congestion. Secondary hemorrhoids can occur between 7 and 11 are the normal ones. This is at 1 o'clock and 6 o'clock. These are secondary hemorrhoids. And if you want to see the grading of hemorrhoid, use a proctoscope. And if you answer this in the examination, I think you're going to fail. Because the grading is symptom. Patient tells you the grading. If it comes out, nothing comes out, patient has been eating grade 1. If it comes out and goes back in after defecation, is grade 2. If it comes out, does not go back in on its own, the patient has to push it back in, is grade 3. And if it stays out, grade 2. So you can't say that I'm going to do proctoscopy for grading. Proctoscopy is not for grading. Proctoscopy is only to find out of grade 1. Is it bleeding from the hemorrhoid? So this grade 2 hemorrhoid. I think I have to go back because this, and this is grade 4, unreduced. Then you have a thrombosed external hemorrhoid. And then you have to, as I said, rule out rectal prolapse. So this is hemorrhoid and rectal prolapse. Rectal prolapse has a layer along the muscle which comes. And this, as you all know, is rectal prolapse and external hemorrhoid. So this one I've already shown you. Please come again. Okay. This picture has come. Now, I want to talk to you why this picture was important. This is when I told her to strain and I see grade 2 circumventional hemorrhoids and grade 3 got me suspicious and that's when I told her to do it. Had I done this, taken this patient up for surgery and under spinal anesthesia, the whole thing would have come out. You cannot operate because you have taken consent for hemorrhoids. You're not taking consent for prolapse. So you need to go back to the table and what are you going to tell the patient? Sorry, I missed out. And this is a 30-year-old male with a cancer of anus, always diagnosed by 13 other doctors before me as piles. And if you do a PR examination, you'll be surprised to learn that you can many a times just feel the rectal CA. And this is the grading as I told you, grade 1, grade 2, when the patient strains, this doesn't go back in grade 3 and goes back in with pressure, doesn't go back into grade 4. Now, why do you need all this information? You need it because you're going to have a chart like this in your file. And that shows bleeding, pain, burning, inner discharge, prolapse file, visible file, itching, straining, constipation, other things. And then examination, external hemorrhoids, skin tag, fissure, fistula, pruritus, and stenosis, sphincter other things. And proctoscopy, internal hemorrhoids, yes or no. And you can subgrade them, hypertrophic papilla, and rectal mucosa, how is it inflamed or not. And then you're going to make a grade of hemorrhoid 1, 2, 3, 4. Subgrades A, B, C, D, this is by ACRSI. And associated disease like fistula or fissure. And you will note that every time you take a patient up for hemorrhoid, you see fissure is also there. Fistula can never be seen beforehand. So 3, 7, 11. So this is the grading I've already told you. The subgrading is when there is a single pile mass is A, when there are two piles but less than 50% circumference is B, circumferential hemorrhoid is C, and thrombosed gangrenous hemorrhoid is D. Now people get confused in the exam when the question is asked grading. Why? Because they think the grading is also for external hemorrhoid, and if you get a patient and it's got a swelling and it's external hemorrhoid, you will say it's grade 4. You're wrong. This classification is only for internal hemorrhoid, not for external hemorrhoid. External hemorrhoid is not going to be outside all the time. So you can't say external hemorrhoid outside is grade 4. So that's how it looks in the figure. And subgrading, how does it look? This single pile mass, two pile masses, three pile masses, and this is circumferential. It could be gangrenous. So with all the information, you put it on this chart. And this chart tells you what you should do. Basically, grade 1 you do medical management, that is in green. Office procedures, that is in purple. And for grade 3 and 4, you basically do surgical procedures. This is available in Indian Journal of Surgery, February 2017. Beautiful picture is there. So, medical management includes stool softener, eye management. The first three are the most to be normal. Then ecosanitary say steroids are good, 1000 milligrams daily, but if you're operating the patient, it has to be TDS 4 days, BD 3 days, then OD, CSPAR and local. Now, once you've done it, what do you do? So you have what to address. When you're operating a patient of hemorrhoid, are you addressing bleeding? Are you addressing collapse? Are you addressing a thrombosed hemorrhoid? And the surgery depends on what you're doing. Remember special conditions like HIV, pregnancy, cirrhosis, portal hypertension, children, small children, patients on anticoagulant bleeding disorder. So all these things you have to keep in mind before you actually do surgery. Choice of surgery, non-surgical procedures, development, rubber band ligation, infrared population, non-cutting surgery, DER, laser, translucentopexy, and cutting is stapler and hemorrhectomy, as you know. So what to address? Bleeding, collapse, and thrombosis. Bleeding is conservative, non-operative, and operative if that is not helping. Collapse, operative, and thrombosis, operative. So, if you do a clinical evaluation, patient is more than 40, has weight loss, fever, rectal bleeding, deficiency, iron deficiency, abdominal pain, diarrhea, fecal or blood, you need to do colonoscopy. And if it's grade 1 or grade 2, you do conservative treatment. If it fails, then you think about surgery, office procedures, sclerotherapy, rubber band ligation, IRC. Failure, you think grade 3, you operate. If it's this is a failure, you operate. And inoperative, you have hemorrhectomy, DGR, laser. And grade 4, operative, and also grade 3, cutting procedure, MIPHN, and hemorrhectomy. So this is the whole thing, gambit of what you need to do for a patient who has a hemorrhoid. So this is a big chart and we don't have the time to go over it. So Fisher, I'll go fast. I won't show you the video. You can see it on the net. Pain, it's painful defecation. That's all you need to remember. And various presentations are there. And pain is the biggest complaint the patient has. At this time, after 6 to 8 weeks, skin tag develops. And the bleeding is because the heart stool is going down, it's rubbing on it. You can measure it, the pain and the tone of the sphincter by a tonometer or by a vast scale. And then you put it on this chart where the patient has a problem, which stage the patient has. Yeah, and natural history of anal fissure. In this patient, this is the acute fissure, chronic fissure, and an abscess which will rupture and form a fissure, fistula complex. And in children, think about polyps and inner fissure. The treatment is stage one, analgesic, smooth softeners, high fiber diet. And then chemical spectroscopy agents are wonderful. That is diltiazem and nifedipine. And the choice of surgery is lateral spectroscopy, which can be open or closed. Radial or vertical, blade or with laser. And fissurectomy means skin tag, lateral margins, and hypertrophic papilla. And when a low pressure patient is there, the inner tone is normal, doesn't really cause do not cut the sphincter, and this is how your chart has to be. And remember, this is because of steroids. Patients who apply a lot of steroids end up having this problem. And I'm not going to go to the next slide. This will be the last slide. I want to ask you, this patient was operated 4 days back, and the patient has excruciating pain. Could not walk. She was screaming in pain. What is your diagnosis? She was operated for fissure and has extreme pain. What is the problem with her? The first thing you see is the fecal matter here. You see the fecal matter here? That means the pain is severe. You cannot examine this patient without anesthesia. And under anesthesia, the only problem with her was she had a fecal leg. And that fecal leg was enough illness. It prevented the sphincter from closing, and that's why she had the pain. So remember, any inner surgery you do, you need to give laxative. Do not constipate the patient. In fact, give the patient laxative. Thank you. Thank you.
Thank you, sir. Thank you for the excellent overview about the approach to the anal disorders. In fact, sir can give tirelessly the whole day lectures and videos, but running short of time, he has cut short his lecture. For the token of appreciation, the Association of Surgeons of India and Chennai City chapter presenting this certificate to sir. Sir, madam. Please.
So, who are all appearing for the quiz? Can you put up your hands? Na kaiye kaano. Okay, excellent. So, your 10,000 rupees cash prize. So, please, place yourself. Place yourself. Or gap out ukarunga ellarum. Don't sit next to each other. Leave a gap. Those who are not appearing, please go back and sit. All those who are appearing, please come in the front. Those who are appearing, come and sit in these rows. Those who are not appearing, you can go behind. Separate and the group, they have to separate. If you're not appearing, please go behind. You're appearing. Come in the front. Come in the front. Come in the front. Leave some gap and sit. See, the program is like this. Your questions will be displayed. You'll be given a link and you have to connect with that link. And you'll have 30 seconds to answer your question. So 15 minutes, it's done. It's over. So in 15 minutes, we'll select 10 of you for tomorrow's final rounds. Same. Yeah. Single person. Those two. That girl, you can please sit. Or run seat. At least 2 seats. Those of you are not appearing, Behind. You're not appearing. Okay, you are appearing? That man. You are appearing? No. All of you not appearing. And the, what is that? And the camera in the appearing. Yes? Is it right? That's Paria. Camera in the appearing. All the others behind are not appearing. Are you appearing? Come in the front. Come in the front. The mobile now. We are not asking any questions. If you are not appearing, come in the front. Are you appearing? Come in the front. Come sit here. You are appearing. Come sit here. If you are not appearing, you can sit anywhere. But those who are appearing, please come to this box. You are appearing, please come here. Please come here. Okay, you can type the link. Don't sit close. At least 2 seats separately. At least 2 seats between each other. That girl is not appearing. Okay, fine. You are not appearing. Behind. Okay. All these people. All these people are appearing? No. Yes or no? Please come here. Come here, come here. Come to the front. Come to the front and sit. All those who are appearing, please come here. Go there, sit down. Make yourself comfortable. Give at least 2 seats in between. 2 seats in between. So all those who are not appearing, is it? Am I right? They are not appearing. You are appearing. Yes or no? Okay. What about you? Come in the front, man. You are appearing, come in the front, I said. This square or rectangle, whatever. What about that fellow? You're not appearing. Okay, fine. That person? No. Okay. Shall we start? 30 seconds per question. And it will go on. By 15 minutes, it will be over. And did you give that link? You can start that link and start answering questions. Yes, please. You can start. Huh? Yes. Okay. Huh? Appear. Questions in the display. Yes. That's fine. I'm here. First question. కొంచెం పెరుసా పోవడం లేదా? Can you enlarge it? Yes. Yeah, that's good. First question. If I want, that before doesn't matter. That's on the 35. Not 39 or something. Okay.
All these questions are from Bailey only. So there should be any questions. I mean, clarifications. No talking, just be on your own.
So
Any questions missed by anybody? In between? How many did miss the questions? How many? How many did you miss? Two. Two. 4. 2. 3. 2. 1. 2. Come, all of you who missed the questions. Just right there. Just get up from your place. All those who said the missed questions. Come here. Give your names. The finalists will be announced tomorrow. And tomorrow, similarly, we'll have the session. Because you are missing questions, I think we'll give you the paper so that you can fill it up. Name and the institute.
Nicely, we can appreciate the action of medial and
It means, remember, it is a state. Really, it should be having 2 to 6.
RRR was a very good idea because it helped us with all rapid brush up and all the 1 marks were get it in one single place.
Program was very good and it helps us to stay in that competitive mode every alternate day. The rapid revision program was very helpful in my last minute revision and they helped me reach the 906 rank in NEET PG 2021.